साइड में थोड़ा सा मेरा डार्क आ रहा है फेस, लाइट नहीं है ठीक। लैंप लगा दे, वो वाला लैंप उठा के ना।
Hi there, Vimoj. How are you?
Good morning.
Good morning, Dr. Virendra. This is Dr. Tejpal here.
Yeah.
Hi, Tejpal sir. It's nice to see you.
Yeah. So how are things in Canada?
Things are good. It's going to be midnight.
Oh, midnight. you look completely fresh and
I'll be jet lagged without leaving the place.
okay.
Light थोड़ी सा.
Hello, sir.
Hello, yes. Hi, Aditi. How are you? Good.
I'm good, sir. Thank
Good.
you. How are you?
I'm good.
So Dr. Vimoj accepted the invite in spite of it being late night there.
No, I think, I mean, it's important that time doesn't matter. Whatever is the time, it's fine. So,
Sir knows me well. It's nice to see you all. The interface is so impressive with the online, the website, going into the conference room. And
Yeah. Dr. Mehta is also here. Hello, sir. Good morning. So you'll have to unmute yourself.
Good morning.
Good
hello.
morning.
Good morning, sir.
Good morning, sir. Batish है, sir.
Oh, good morning. बातिश तुम तो पहचान में नहीं आ रहे हो यार.
अरे नहीं सर, सेम है, बिल्कुल वैसे ही हैं. And
We'll start at 9:30.
Yes.
Hello, Dr. Kimberly. Dr. Kimberly, are you there? Hello, good morning.
Hi, good morning. How are you?
I think it must be night there.
Oh, yes, it's midnight around here for us.
Right.
Can we start? अभी क्यों स्टार्ट कर? हाँ स्टार्ट हो चुका है. हाँ कर दे. वीडियो तो और क्या? टाइमर ऑफ करो.
Hi, Manjari.
Hello, how are you?
I'm good.
Good to see you. Thank you for setting up this amazing conference. I've been trying to listen into some of the talks from before. It's very exciting.
So the good part is we were able to cover everything, but the not so good part is good sessions are going on simultaneously.
That is true. Actually, while I was looking at it, I wanted to attend some that are going on now. Actually, are about to start now. Yes, but will any of these talks be available like later to watch?
Yes, so they are being recorded and
Perfect.
they will be available. Yes.
Yes, I think that'll help a lot. But congratulations, amazing thing you guys have put together.
Thanks. So we'll begin our session for today. A very good morning to all of you. I welcome you all to the third day of Paras Cancer Conclave. Our virtual conference began on 19th of March in the evening and on 20th. Very successful and good interactive sessions for all subsites in oncology and early diagnosis sessions happened on the 2 days. We had keynote addresses by Dr. Rath and Dr. Pramesh yesterday in the inaugural session. We had over 8,000 registrations and the delegates attending were around 1,500 yesterday. So going on to the third session for today, which is the neuro-oncology session, I would like to welcome all of you to the session. And to begin the session, I would like to invite our chairpersons, Dr. V.K. Batish, who is the Associate Director, Neurosurgery at Paras Hospitals, Panchkula. Welcome, sir. Dr. V.S. Mehta, who is the Director and Chief of Neurosciences at Paras Hospital, Gurgaon. Both of them are very senior neurosurgeons and they don't need any introduction. Dr. Kishore Singh, unfortunately, would not be able to join for this session. So I would request you, sir, to take over the proceedings to invite the speakers and please ensure that the speakers stick to the time limit. Questions we can take at the end of the session and they would be coming in the chat box. Over to you, sir.
Thank you. So let's invite the first speaker, Dr. Vimos Nair, who is going to talk to you on recurrent ependymomas, is radical treatment and overkill. Dr. Vimos.
Thank you so much. I'm just trying to share my screen here. And I hope you guys can hear me and see my slides.
Yes.
Okay, that's perfect. Good morning, everyone. It's actually midnight right over here. And thank you, and thank you to the organizers for inviting me to this talk, especially Aditi for giving this session to all of you. So my name is Vimoch Nair, and I'm an assistant professor in the Division of Radiation Oncology at the Ottawa Hospital. And I'm also a clinician investigator here at the Cancer Therapeutics Program. So I'll be talking about recurrent ependymomas. Is radical treatment an overkill? So I don't have any disclosures relevant to this talk. So in the next 18 minutes or so, we shall talk about different local therapies in relapsed ependymomas, a brief review of the literature, especially when it comes to re-radiation of ependymomas, and talk about the different radiation techniques and the principles when it comes to re-radiation of relapsed ependymomas. So as you all know, most of these tumors are aggressive and you treat them with surgery, and we try to give local radiation therapy to a dose of 59.4. But the fact is that a third of these patients do relapse, and most of this relapse happens in the first 3 years, but delayed recurrences could happen months to even years later. The recurrences, when it happens in much older patients, the outcome seems to be a bit worse, or with half the survival compared to younger patients. Biology has to do a lot with these, especially with these tumors having RELA fusion gene, as well as the patients with posterior fossa type A, marked in red. These are seen in younger patients and are prone to relapse, and does seem to have a worse outcome, explaining the relapses. We looked at our pooled analysis here, combining the data from Ottawa, Princess Margaret, and Oklahoma, and we find that surgery is indeed an important factor that influences relapses. Grade 3 tumor seems to have more relapses, and many of these relapses seem to occur in an interval between 1 year to up to 30 years, and up to 41% of these patients seem to recur in a pooled analysis. At this time, we only presented this as an abstract, and we shall be tidying this up, and paper should be coming out soon. So when these tumors relapse, it could be metastatic in a quarter of patients, and the patients who have more localized relapse, they do seem to do better than that of metastatic patients. At the time of relapse, the progression-free survival in these relapse patients can be less than almost a third, and most of the 5-year overall survival is 27 to 57%. So when these relapses do occur, our questions are: shall we just repeat the same treatment again? Shall we just resect them and give adjuvant radiation therapy? In the event surgery can't happen, shall we just give upfront radiation? Should we do chemotherapy, or are there any trial options available? So we'll be talking about most of these local treatment options in these relapse cases. So at this time, we recommend discussion in a multidisciplinary setting. Here, at the Ottawa Hospital, we do have a local tumor board where all patients are discussed locally, but we also have a provincial tumor board, which is where all neuro-oncology centers do log in online, and we discuss cases that happens every week. So discussion in these rounds is always recommended in such a salvage setting. So when these relapses happen, should we operate these patients? Let's look at the evidences. So it looks like if a surgery or resection seems to improve the overall survival, as shown in the systematic review, and you get a median overall survival of around 2 years if you do resection. And there has been multiple retrospective single institution series confirming the same. It's not just resection, but having a gross total resection seems to improve the progression-free interval as well as the overall survival in almost all retrospective series that's out there from different centers. So here on this slide, I'm just showing the most recent Boston series, but this seems to be the same flavor in all retrospective series. The data from Tata Memorial that Tejpal sir has published recently also confirms the same, that in Indian patients too, we should aim for a gross total resection, as the outcomes both in terms of progression-free survival as well as overall survival seems to be much better if you do a gross total resection. So yes, you should aim for a gross total resection, and that's beneficial in these patients. But what about radiation therapy? Should we re-radiate? Let's look at what the data says. At this time, most of the information that we have is retrospective. It's non-randomized. There is a phase 2 prospective trial that's ongoing, but until then, we don't have any prospective validated trials in the context of relapse ependymomas and re-radiation. But if you compare these modalities side by side, it does look like if you do surgery, there is a benefit. And when you give radiation therapy, their median overall survival is around 29 months. At this time, there does not seem to be any effective systemic therapy in these relapse setting. So In the Boston group, their data still confirms that yes, radiation or re-radiation is beneficial whether you do a gross total resection or in general. So there seems to be a benefit, again, very small numbers in these retrospective series where you could reduce the relapses by giving radiation therapy. At this time, whether it does improve survival, it's still unclear, as majority of these papers only show a local control benefit, not much of an overall survival benefit. This paper, the results from Tata Memorial, I find this very interesting in the fact that delaying radiation therapy, so the way that this was presented is that if you give chemotherapy before radiation, the outcome seems to be actually worse. But the way that I would look at it is that delaying radiation therapy by giving chemotherapy before does seem, the patient seems to do actually worse, radiation being an effective therapy. So again, the same data, the same paper summarizes these results, that a gross total resection seems to give better outcomes. Giving radiation earlier seems to be always better. Tumors that recur after 2 years or delayed recurrences are associated with a better outcome. And the other part was that the symptomatic radiation necrosis rate from this series was around 5.5%, and I'll compare this with other papers in a few minutes. So, yep, looks like we do need to give radiation when these tumors relapse. We need to aim for gross total resection. But what if these tumors relapse locally after resection? Should we do a local radiation or should we give a craniospinal radiation? So let's look at what the data say. So this is from the pooled UK data, where in older patients who got craniospinal radiation actually did much better than that of focal radiation or no radiation at all. And of course, they are just reaching barely significance in this paper here. The data from Toronto, they looked at craniospinal radiation versus focal radiation, these relapse patients. And in all comers, there was a benefit when it comes to local control or freedom from progression at 5 years, was 83% versus 15%. But this benefit was much marked for infratentorial tumors with, again, very small numbers, with the number being around 100% with good local control with CSI versus focal radiation therapy. So this, in a sense, changed the practice in Ontario, which is the state or the province that I practice now, that for infratentorial tumors, our standard is craniospinal radiation. The same paper, again, very small series, did show some benefit when it comes to supratentorial tumors and overall survival too, but that was not statistically significant. So this sort of skews even though the evidence is not very strong, that maybe we should be doing craniospinal radiation in these patients. So there has been this data from the German group who looked at giving focal radiation in relapsed ependymomas, but this study was mainly to study the impact of temozolomide. What this paper concluded was that radiation therapy was not associated with any benefit, but 75% of these tumors were infratentorial and received only focal radiation therapy. So my sort of confirmation bias when I read this paper is that if we had given a CSI, were the outcomes going to be a bit different. But even with focal radiation, there was some benefit when the surgery was incomplete. So patients with subtotal resection actually had a benefit from radiation. So putting all this together, looks like the best treatment option for these patients has to be craniospinal radiation, even if there is a local relapse. Now, with the local radiation that was given from the Toronto series, the radiation necrosis rate at 10 years was around 7.9%, which was comparable to the Tata Indian data of 5.5%. So with newer technology and access to all kinds of technology, use of hyperfractionated radiation therapy in all sites, there has been this bias towards doing more and more hyperfractionation without too much evidence. But let's look at the published data in this busy slide here. Here I tried to sort of tabulate most of the hyperfractionated data from all published single institution series, and you can see very small numbers. And many centers have done a SRS for these tumors with giving 18 gray and one fraction. Some centers have given 24 and 3 for in-field recurrences and 30 and 3 for outside the field. There has been 5 fraction approach from the Japanese series. But in general, the local control with the hyperfractionated, whether you give 1 fraction or up to 5 fraction, the local control rate seems to be in the high 70s or 80s. Here in the St. Jude series, the outcomes are comparable to conventional radiation. But what really stands out is compared to the radiation necrosis rates in conventional radiation therapy, which is in the range of 0 to 8%, here you find up to 5 to 10 times the radiation necrosis rate, ranging from a quarter of the cases to 83% in the St. Jude's data. So the way that we interpret this is that if you have two treatments with same outcomes, but you have one treatment having a high or 5 to 8 times risk of side effect, why choose the toxic treatment? And hence, in Ontario, we prefer the conventional fractionation when it comes to relapse. So our practice for the local relapses, based on the Toronto numbers, we still favor giving focal radiation therapy to a 5 millimeter margin. And for infratentorial recurrences, we do craniospinal radiation of 36 gray in 20 fractions and boost up to 54 gray at least. Now, the sort of rule of thumb is that if the patient received 59.4 the first time, we give 54 the second time. If the patient had received 54 gray the first time, we would give 59.4 the second time. For disseminated disease, it's 36 gray CSI with the boost to 54 to 59.4 based on the same principle. For the boost or the local treatment, we treat the tumor to a 5 millimeter margin that's modified for an anatomical spread. Our PTV margins in our center is up to 3 millimeter, but we have treated patients on the CyberKnife with a millimeter margin because that 1 millimeter still helps us reduce the dose to the brainstem nearby. So during planning, we do need to be mindful of the cervical cord. The ongoing phase 2 study actually gives the option of shielding the cervical cord after 27 gray. Again, that's based on an individualized basis. We don't know what the effect of this would be. At this time, there's not much reports of that cord toxicity in these CDs. And again, try not to give any 54 gray or no hot spots in the brainstem nearby. But frankly, in my practice, if ever there was a supratentorial tumor near the chiasm, I don't go up to 54. I may sort of cool it down to sort of 36 gray there, like underdose of PTV, and try not to give a hot dose or cumulative EQD2s above 110 gray. So Boston also published their evidence with or experience with protons, and it's again very small series. In this patient, they did underdose the brainstem and the spine, similar to what St. Jude's has published, that you can limit the previous doses if previous doses to the brainstem and spinal cord if those structures have received radiation before. The one thing that stands out is that when you're giving a dose of around 110 gray, you can find that most of the brainstem actually did not receive that hot dose with using proton therapy. Same applies to the cord, that despite giving an accumulative dose of 110 or above 100 gray, the planning was able to spare most of these vital structures. But in this series, the local control rate were actually much less. And one of the reasons why they say that is because the comparator, other papers that they compared with, actually used craniospinal radiation. And one other thing that I note in this paper, which I felt was did sort of influence how I lower the dose in these patients, was that the only patient who got 23.4 gray actually had a relapse. So I still think twice if I have to underdose it to 23.4. So I prefer something hotter if I have to do a CSI. We look forward to the results of the St. Jude's phase 2 trial, which it might take a few years for this to come out to know what the actual efficacy in a phase 2 setting is when you come to re-radiation of these ependymomas using the doses that I mentioned earlier. So when it comes to radiation, it doesn't end with the second dose of radiation. If you look at this, the Boston long-term data, many of those patients did have stable disease at 5 years and 10 years. But by the time they reached 15 years, still there was more, around 10% of these patients actually recurred after 10 years, giving us the message that maybe we should be scanning them even and following them up in the long run so that we catch these recurrences. The Toronto series actually published on this. Here you can see that the data from sick kids actually had 101 relapsed ependymomas, where around 14 patients actually got radiation. That's the third time. And at that time, you're already exceeded the dose that the brainstem and the spinal cord can receive. So at that time, the intent was just to give, based on the availability of technology, giving focal SRT or SRS. And those were the options that was available. One patient actually received proton therapy, and it might be done in the United States. And actually 6 or half of those patients actually received or the fourth time radiation. And you can see that this was actually a fourth treatment, which was given to the spine. This likely might not be the same site, but the 35 gray and 20 fractions is basically the approach that we have a clinical trial for relapse gliomas. So again, not strong data to recommend this, but it does shows that there is feasibility. And in the long run, these patients do relapse, and when they do seem to live longer, as the median survival is actually a few years. So they do live longer, and they live long enough to get repeat radiation therapy. So we might need to be prepared for that. So in conclusion, a third of these ependymomas do recur. When it happens, gross tumor resection offers the best chance for tumor control. And re-radiation for recurrent ependymomas is actually feasible and improves the local control in these patients. Conventional fractionation may give the same results with reduced side effects compared to the hyperfractionation. It's better to use the highest precision technology the second time, in case not only just to reduce side effects, but also some of these patients do relapse much late, requiring more sparing. And we have to await the results from the St. Jude's publication when it actually comes out, so that we know what's the actual efficacy in a larger setting. So thanks to everybody who had registered for the Pediatric Radiation Oncology Society conference that we hosted in 2020 virtually, and we will be hosting this hopefully in person in 2023. So just informal invitation for all of you to attend and see what we have to offer. And thank you so much for your patient listening, and also for the opportunity to give this talk.
Thank you, Vimoj. Now, I think we can have some question answers straight away. So,
sure, I can't see you.
Does the radiation differs depending on the biopsy at the reoperation? If it is still a grade 1 tumor, what will be your options?
That's a good question. So I didn't show that in the slide. Like we looked at the grade migration in our own data. We do find that it does happen around 10% of the time. In our data, we didn't find anything going to a grade 1. We did find around 10%. There's a jumping between 2 and a 3, and a 3 and a 2. But we never had a situation where it went to a 1. But again, if there is actually a 1 happening, obviously we would discuss in rounds, and I guess we will have to discuss, because this would be a situation that's not the question. I would favor more of at least a local treatment rather than no treatment at all. But again, depends on the patient's age, performance status, a few situations. But in our data of 100 and something patients, we didn't see a grade 1, but it's a very good question. Yes. Okay.
The second question is, do you have the same policy for spinal ependymomas?
Spinal, we prefer to give a local radiation. It seems, if it is a relapse, we might not, again, spine having a structure with strict tolerance, we don't embark on giving long length that kind of doses. With the brainstem, now we know from chordomas that there's this what we call a volume effect, where you could technically give a smaller sliver of the brainstem to extremely high doses. The brainstem seem to take it a bit more, which may not be true when it comes to the spinal cord, especially in younger patients. So we still do local treatments only, but not CSI.
Will it depend on the neurological status at that particular time?
So here,
suppose patient is completely paraplegic. What is
so
the
then
harm in?
nothing we do will make that patient walk. So the intent becomes a bit palliative, whether despite our best effort, even if we give 6 weeks of radiation, that patient here gets admitted. So for in the Canadian setting, that patient is actually admitted for 6 weeks. So with no, you're just losing time and bed sores and all kind of complications. So we end up maybe it could be a palliative option. We discussed the goals of care, whether is radiation going to change anything? Should we just observe versus palliative radiation? But seldom, unless the patient has a pathway that there is a neurologic recovery since the surgery, we don't usually embark on that. But we have treated when the patient, younger 20, 30-year-old patient who says, doctor, just give me everything, I'm willing. Yeah, we have done that. But frankly, in those anecdotal evidence, we didn't find them become neurologically better.
Thank you. Thank you very much. I think we are running short of time. Thank you very much. And we can
Thank you so much for the opportunity.
Invite the next speaker, and Dr. Kimberley, who is going to talk to us on low-grade glioma, surgical resection, and adjuvant treatment. Welcome.
Thank you
Yes,
so
please.
much. Yes. It says I cannot share my screen. Okay, perfect. Thank you. 1 second. All right, let me know if there's any technological difficulties. So we'll discuss today about low-grade gliomas. And as such, there'll be a little bit more focus, I think, on the surgical aspect. So
Hello. I think the internet is slow.
oh, sorry, guys. I think there was a technical issue again. Can you hear me all?
Yes, we can.
Yes, yes.
Okay, perfect. I'm sorry. I think my Zoom just shut down. So for the optimum management of low-grade glioma remains, of course, as this group knows, controversial. There is obviously wide practice variation, and it remains difficult to prognosticate for some of these patients based on what we currently know. They can be somewhat surgically challenging lesions compared to their high-grade counterparts and some of the other tumor types. So we'll discuss that a little bit more today. And then early definition of statistically different patient subsets can help manage or can alter our management up front. And we're only beginning to understand that from a molecular standpoint now as we get better molecular analyses of the various types of low-grade gliomas. And then we'll cover also some clinical trials that are ongoing for this patient population to better understand them. So this is just a quick primer. I'm sure everyone here knows low-grade gliomas, 17 to 22% of primary brain tumors in the United States. That's 20,000 cases for us per year, newly diagnosed. And as we all know, they have a diverse pathology and a diverse clinical behavior with an overall survival, depending on which literature you read, 5 to closer to 15 years. There has been recent reclassification by the WHO, which has helped us to better stratify these patients in 2016. based on 1p19q codeletion. We'll talk about this more in IDH wild mutations. And obviously, this drives survival. Unfortunately, still minimal high quality randomized control trial don't really exist to help guide management. There's some good high quality data, but not a huge body of that. And so as a result, the treatment and management of these lesions remains quite heterogeneous. And that ranges all the way from people who still practice, depending on where they are, wait and see management type of theory for their patients versus various institutions that are very aggressive with upfront management for newly diagnosed lesions or incidentally found lesions. And so an important thing I think to think about, and something I think about when I counsel my patients, since here at our institution, usually the neurosurgeon is the first person to see most of these patients, is, patient preference does have a role in these disease, more so I would say than when you have high-grade gliomas or something more aggressive. I think there is just a much more straightforward path for the patients. So there are questions, obviously, at all stages of care, and that is, that still remain interesting for us to think about as practitioners. From a surgical perspective, since many of these start out first surgically, I think the big questions that currently remain are how do we tell the margins intraoperatively? I'll spend some time on that today. And what is acceptable extent of resection? We have clear data for that in high-grade gliomas, but I think less so for low-grade gliomas. And pathology-wise, how do we identify and treat certain subgroups? We have used molecular analysis to identify these things better in the recent history, but obviously there's still more work to be done. From a radiation standpoint, who should get radiation? Is there a high-risk group, and when that should be timed, and what kind of dosing is recommended? I think these are all valid questions still in the literature. And then chemotherapy, as people probably well know here, the classic question is, what is the best chemotherapy regimen for these folks? Some are better tolerated than others, and some are preferred here than others. And then is there an option potentially for chemotherapy alone, particularly with oligodendrogliomas? gliomas? And we'll chat a little bit about some of the data that has sort of brought that to light, I guess. So I am a neurosurgeon, so I do tend to, maybe I'm a little preferential to talking about surgery, but I'll do my best to keep it balanced. And I would say that in general, tumor margin detection, it can be more challenging for these tumors. Our eyes are not as trustworthy, depending, of course, on the tumor type, the tumor that's particularly in front of you. Sometimes it's very clear. A lot of times when I'm teaching my residents, I tell them to think of it as looking like for marshmallows or clouds inside there. It looks different from that perspective when you're taking up the tumor. But also it has a different tactile feedback. I often tell them too, when they burn the tissue, it will bubble, whereas normal brain tissue will not. But as you can obviously imagine, or if you've been in any, obviously we have a number of neurosurgeons here, it can be more challenging at some points, especially further into the resection, to tell what is normal and abnormal. And so a sort of really simple way, I suppose, to start off, I mean, it sounds extremely simple, but can be effective, just as we'll talk about, that some of the more complex technologies are not perfect, is just to consider basic techniques like fence posting, which is something we use our navigation here for. And we just put it, drop down navigated catheters on the edges of the tumor to the correct depths. And if you are careful with that and fence post at appropriate locations, and I put little yellow lines so that you can see here how that might look around the tumor, then that can help guide your resection when things are not as clear. Obviously, some low-grade gliomas are very clear intraoperatively, and this is not an issue, but sometimes it's hard to tell preoperatively what that's going to be. I would say the best way to tell preoperatively that you're getting a good extent of resection for low-grade gliomas, probably more so than any other tumor, is an intraoperative MRI. It is currently the most detailed thing that we have to offer for that. It is, of course, significantly, if not prohibitively expensive for some institutions, millions of dollars worth. So if you do have the access to that, which certain institutions are very lucky to, I trained at some of those places. I mean, it's important to remember to keep an optimal workflow. Otherwise, your surgery will be very unusually extended, very long. And make sure your staff and your anesthesia, of course, is well trained for this as well, right? Because it can become quite a production. And if for those who do not have an intraoperative MRI, essentially you complete the resection, And then before you put your bone flap back on, you keep everything sterile, cover up the patient, do not put the bone flap back on, flap the skin back over, do your scan and see how much more you have left to resect. And you can do this iteratively, although at some point time becomes an issue. And there's good data, particularly from many institutions, but I think the Germans have really led a lot of the data in this area that looks at intraoperative MRI being a good adjunct to actually increase extent of resection in low-grade gliomas. And so this is the most recent study from the German group, multi-center, and you can see here, you know, what kind of extensive resection that they're getting. And they even went as far as to tell which ones that they thought would be that they intended to have gross total resection and failed to do so. So I think that once you have your flow down and you're doing it well, you can. There's good evidence that shows that intraoperative MRI can help to increase extent of resection. Whether that reasonably offsets the cost, and for many institutions, is I think something more of debate, but certainly has some promise there. The other thing that can be helpful in these tumors, we all know that many of them do happen in eloquent areas. So this is a good time in which to consider using your techniques, your advanced surgical techniques for intraaxial tumors, such as mapping and awake craniotomies, to take your resection, at least if it's hard to tell intraoperatively where the actual tumor margins are, to your functional extents. And so in these cases, to use awake surgery or mapping to take it to where at least you'll minimize deficits. This can, of course, be assisted by accurate preoperative functional imaging, both fMRI, diffusion tensor imaging, or tractography, which you can see here. We, of course, couple these with our neuronavigation so that we can see this intraoperatively and help to know where our extents are, and of course, to give us a better idea when we're mapping where these areas might be to increase our efficiency while the patient's awake. And generally, we tend to reserve our awake craniotomies for when there's speech involved, like you can see with this tumor here, this low-grade glioma here. But of course, you can, if you so decide, to wake up every patient for both movement and speech areas as well. So really up to you. And of course, we can, if there are questions, we can talk more about cortical and subcortical mapping or awake craniotomies. They're relatively popular, but something that we really like doing at Emory, so happy to discuss more. I think a really good adjunct, which I think there's variable popularity. It's not entirely super popular in the United States, but I think each institution has certain preferences, is ultrasound to help. And this actually can be very helpful in the setting of low-grade gliomas, where we don't have some of the other adjuncts that we have for high-grade gliomas to help with extensive resection. And it is not difficult, I think, to eventually pick up the technique for intraoperative ultrasound. And this may be something that's very common with the neurosurgeons on the call, or may not be. But basically, we use it for every tumor resection that we do. High grade, low grade, any sort of really pathology, unless it's very obvious or extraaxial. Sometimes we don't use it, but it's the one true real-time imaging that we have in the operating room, of course. And so we can, and some ultrasounds now are even able to correlate with your navigation, and so that you can have these overlaid. But the important thing, I think, when you're using intraoperative ultrasound is, of course, if you use it regularly, you must scan before, right? That's a common mistake I see. Find out what the tumor looks like beforehand, how even tumors that you think are going to be extremely hyperechoic end up being not hyperechoic at all, and are difficult to see. Whereas sometimes tumors you didn't think were going to light up really well under ultrasound do. And so just good to get a baseline before you begin resecting, and then use, as you can see here in this slide, there's still a rind of residual here in this B area. And it's not not the most perfect thing, but it's clear that there's still some there. And so you can use that to go ahead and further your resection. And then, you just have to get used to the technique. There are things that can be hyperechoic that sort of fake you out a little bit. And that can be like blood, or if you put hemostatic products, gel foam, those kinds of things in there, it can be very bright. And so you want to make sure those are all cleared out before you inspect your cavity. a lot of people are interested in using fluorescence to help increase extent of resection. And I think, obviously, we all know for high-grade gliomas, this is something that is becoming increasingly popular. Of course, initially really pushed forward by the Germans, Dr. Stumer, and then eventually became FDA cleared relatively recently here in the United States. It's something we do a lot at our institution as well. And you can see in the video there's residual tumor and it comes up very bright pink. Use that bright pink to tell us, where the tumor remains. This is very good, as many of you probably know, in high-grade gliomas. And you can see it's an oral agent that the patient drinks beforehand, and then we go under a microscope, a blue light microscope, so that we can see the residual tumor. Unfortunately, with low-grade gliomas, it is not as good of an adjunct, and that has been somewhat disappointing, I think, because these are the tumors that can be a little bit more challenging to identify the margins of. And so I would say on a case-by-case basis, there can be some fluorescence, but it's not always reliable. If you read the literature, depending on who's writing it, somewhere between 10 to up to 46 is an unusually specific number, but 46% of tumors can fluoresce. And this is often, as you might imagine, related to the grade of the tumor with higher grade tumors, grade 3 versus grade 2 low-grade gliomas, fluorescing more. A greater percentage of them fluoresce. And so there is some new research on the horizon, particularly out of the Barrow Neurologic Institute, that is trying to use confocal microscopy, specifically dual axis confocal microscopy, in order to better image low-grade gliomas and pick up this fluorescence, which is not as strong, such that we can't see it under the microscope, and hopefully use that as a potential option for low-grade resection. So as of currently, though, not in practice, and something that is, I would say, still in development, probably not as helpful for low-grade gliomas. So as you can see, there's a clear need in this area for new technology. I would just request that this part not be published. This is some work we're doing. There are multiple, actually, new technologies on the horizon that are trying to address this issue, which is improving our margin detection, particularly in tumors that cannot be aided by fluorescence. And that can either be done by either quantifying your your margin detection or your fluorescence, or just in general better optical imaging. So I mentioned a couple of different initiatives in this area, including Raman spectroscopy, single axis confocal microscopy, which is offered now by Zeiss, but again still struggles with low-grade gliomas, spectroscopic OCT. So a lot of different things that are kind of in the translational phase for research. And something that we're working on here at Emory is something called quantitative oblique back illumination microscopy, some images of which you can see here, which is just a very special type of computed refractive index tomography. As you can see, the scale is a little bit different, and there is, of course, some processing time for this, but this does allow us to see, a very small cellular structures with this imaging. We've translated that to a wide field approach in order for us to potentially be able to detect things at the margins. The issue, of course, is that there is some interpretation associated with all of these modalities, and this requires, close pathological help. And I think that is, all of these things still require a fair bit of training and are not quite ready, I believe, for true clinical prime time. But this does allow us to think potentially about the future of glioma surgery, both high-grade and glioma and low-grade gliomas. Can we resect beyond the contrast-enhancing regions, and will this actually make a difference? And I think we are only beginning to have the technologies to really look at that. And then, of course, we know, as you all probably have, many patients with low-grade gliomas that, you treat them up front, you get the best resection you can, you follow with chemotherapy and radiation. We'll talk more about that. But then, they will come back with recurrence, and this will be a thing that will have to be addressed. And so we do have some new surgical options. Obviously, we can, at the time of recurrence, very strongly, our institution advocates for either re-resection or biopsy, depending on the location. And there's, of course, literature out there that says, re-resection is associated with improved survival. And then, of course, reirradiation and or changing of your systemic therapies. And there are, various options depending on, how the patient has responded and what they've received previously. And of course, you can sign your patients up for clinical trials. We'll talk about that. But one thing that we also offer at salvage, or when we're trying to do salvage therapy now, is brachytherapy, depending on how much radiation they've received already, if they've exhausted their radiation options. And so these are just some new implants called a gametile. They're basically collagen implants with an embedded cesium radiation source. This is a case we actually did of a low-grade glioma where you can see the seeds on the CT scan, very bright, into the cavity to help. This was a third-time recurrence in a very young and functional patient. And so we offered her retherapy with this, this new therapy and worked in conjunction with our radiation oncologist to be able to dose this appropriately to fill the cavity with these cesium seeds. So in low-grade gliomas, I'd be remiss if I didn't talk about the importance of molecular analysis. This is an excellent table or chart that I like to refer back to. I think it's very helpful from Lancet, and it just goes over basically all gliomas, but of course there's some really good data in here, particularly with regards to low-grade gliomas. And it references, if you look here at the bottom, the trials that, sort of support some of these things. Or give some ideas for how you might treat these patients, and so good places to look. And so I think the importance of molecular analysis has become very important in low-grade gliomas, and particularly low-grade appearing gliomas it has never been more important for those. So this is a good example of a patient of mine who everybody thought she was going to have quote unquote a low-grade glioma, a very young patient. Who presented with seizures, or a classic presentation for low-grade glioma, and had no contrast enhancement, as you can see on her imaging, but we ended up resecting this lesion, and it came up actually being WHO grade 4 astrocytoma, or what back in the 2016 criteria would have been glioblastoma. So I think you can no longer rely only on histology without looking at the molecular things as well. And so I just caution always myself to think about the fact that even though it may appear like a low-grade glioma, today we really have to complete the full analysis in order to really, there are some a fair number of high-grade gliomas hiding within that low-grade appearing subset. And then of course there's a significant amount of data coming out now about better ways to stratify this group down here at the bottom of the table. This group, this IDH mutant group, is very heterogeneous in its outcomes, as you know. And so it's kind of difficult sometimes in some ways, to prognosticate for these patients. And so, of course, better markers are being identified from a pathology standpoint, including CDK2NA and BLOS, and that has been associated with lower survival in IDH mutant patients. And so these are important things, as further data comes out to help us prognosticate and think of future clinical trials.
Could you
For
please
radiation
conclude? So we are running short of time.
Okay, I will finish up then. I feel bad. I have to get through radiation and chemotherapy. This is the important, I would say, EORTC 22845 is the important trial for radiation. And in general, it demonstrates early radiation is not demonstrating overall survival benefit, but it's been associated with improved progression-free survival. Chemotherapy, I think the classic question is PCV versus Temidar. And I think that's being addressed right now in the CATNON trial. There's some interim analysis from that. And then there's also an idea potentially of is chemotherapy alone a reasonable thing for IDH mutant 1p and 19q co-deleted tumors? There is some excellent data out on this from the New England Journal of Medicine, published in the New England Journal of Medicine on this, where some of this data shows the benefit of IDH mutant tumors that benefit more from chemotherapy versus wild type tumors. And then this is, I just want to point out the tumors I think that potentially might be considered high risk and should maybe be considered more aggressively upfront for chemotherapy and radiation. And then lastly, because we are running out of time, I did want to spend some time, I apologize, about ongoing clinical trials, national clinical trials here that we are enrolling patients into, including the CODEL study, the STELLAR study, which we actually just closed at our site, and the Wait or Treat study. And I put some of the data there for primary and secondary endpoints. And so these are the conclusions. I don't want to take up time in case there's questions. This is our team, and my contact information is at the below, so please feel free to reach out if you have any further questions.
Thank you very much, Dr. Kimberley. Just one question. Is
Yes.
your strategy the same for all the age groups? What if you have a very young patient?
Yes, so I think the traditional thing was the Pignati criteria said that if it was less than 40, that those patients did not need to be so aggressively treated. I think 40 is a little bit arbitrary number. We used
Less than
KPS.
20, say less than 20, very young.
Oh, yeah. For less than 20, I think we generally give more choice to the patient and say, you know, we counsel them that it's possible to potentially watch and wait after surgical resection and getting the appropriate molecular stratification. And it's, of course, counseling them about the benefits and risks of radiation and chemotherapy up front, and then helping them to make that choice from that standpoint. So I guess we give them more choice from that, you know, whether or not they want to initiate adjuvant therapy at that time or wait to see.
Some question from audience. Can you?
There's one question in the chat box by Dr. Manjari. Can Dr. Huang comment on any benefit of attempted re-resection after biopsy with the possible outcome of subtotal resection and not gross total resection, especially in young patients with low-grade glioma who may be able to forego chemo or radiation post gross total resection?
Yeah, I think, you know, the general thought in low-grade gliomas is that, you know, maximal safe resection now is, you know, I guess probably the data is not as strong as for high grade, but whatever you can take out beyond biopsy, although there's not as clear numbers as they do for high grade glioma, I think that is, for the most part, the literature, although, you know, again, single institution kind of stuff, is strongly supports that. So I do think there is a role for resection after the biopsy if it is safe. I think if there's, you know, concern for residual, then that you have to counsel the patient for adjuvant therapy. Again, just it's depending on all those other criteria: size of the tumor, how much you left behind, the age of the patient, the KPS of the patient, those kinds of things.
Can you give us your views about the sampling error in the biopsies?
Yes, I can actually. We actually are doing some work on. I think there is like, you know, depending on, of course, the literature you read, there's various percentages for sampling error, but we have seen that because, you know, as we talked about, certain areas may be particularly low grade and some may be, you know, high grade, and you might miss that with your biopsy. So we have actually a new modality for imaging that we're using for our low grade gliomas called spectroscopic MRI. It's not spectroscopy, it's spectroscopic MRI. It's like a high resolution 3D imaging that one of our collaborators is working on. So we scan all of our patients with spectroscopic MRI to look for the most metabolically active areas, and that has to do with their choline NAA ratios for each voxel. And then we find the voxels that are the most active, and we target those actually at biopsy. So that's one of our research initiatives that we're doing right now to kind of avoid some of that, I guess, sampling error from a biopsy standpoint, if we can only biopsy.
Okay, thank you. Dr. Batish, can you call the next speakers?
So before we call the next speaker, I would request Dr. Batish to please facilitate our two international faculty.
Thank you very much. It's been a wonderful talk, particularly on recurrent ependymomas, which continues to intrigue a lot of people, and low-grade gliomas more than the anaplastic or the higher-grade gliomas, where there's still. So I congratulate both the speakers for an excellent talk. and a discussion, following discussion, and I congratulate both of them. Thank you very much. Dr. Vimoj Nair from Canada and Dr. Kimberley from Atlanta. Thank you so much.
Dr. Natish.
May I now call upon Aditi. Where is the slide?
Yes, sir. We can proceed with the talk.
Yeah. No, I am not getting it.
I think we have to stop the other participant from sharing the screen. Till the time he does that, I cannot share mine.
Anas, can we have the screen sharing rights for Dr. Sumit?
Yeah.
Yes,
it's
ma'am.
come. Okay, so I hope I am audible for all of you.
Yes.
Welcome,
Audible
Dr.
and well
Sumit Sinha.
visible.
Good morning, Dr.
He's a very senior neurosurgeon at Paras Hospital, Gurgaon, and he shall be speaking on a subject of keyhole and endoscopic surgery for gliomas. Welcome, Dr. Sumit Sinha.
Thank you, Dr. Virinder. So can you there's a technical issue in here, no? Can you see my screen moving?
Yes, sir, it's visible.
The screen is visible, but it's not moving. Now it's moving. Yes, sir. Yes, sir. Yes.
Okay, so sorry for that. These are technical glitches that we've learned in the COVID era. And thanks for the, this is the only good thing that we've learned about technology in the COVID thing. And I do pray sincerely that world gets rid of it, of this deadly pandemics very soon. Well, having said that, thank you very much, Paras Conclave, Cancer Conclave 2021, for giving me this opportunity for presenting myself and my work on minimally invasive neurosurgery for brain tumors, especially gliomas. And Dr. Rangarao and Dr. Aditi done really hard work in collaborating and doing necessary things for this session. So before I do start, I do not have any financial disclosures. Well, the next few minutes will be about a minimally invasive neurosurgery, especially applied to gliomas. And when we talk about minimally invasive neurosurgery, there are three different techniques, especially as to how do we do this this technique. One is the endoport surgery, where what we do is we take an endoscope inside a port or a tubular retractor or a tubular or a tube-like structure, and the surgery is done with a microscopic as well as endoscopic assisted vision. The second one is the keyhole surgery, which will be the main topic of interest here in the next 15 minutes. And in this, we make a small craniotomy about the size of the maybe 2 by 2 centimeter or 1 by 1 centimeter, and then take out the tumor inside completely through that small craniotomy, and at times assisted by the endoscope, which may be 30° or 45° or maybe 75° at in some circumstances. So this is a keyhole endoscopic assisted neurosurgery, which I will be talking about in this particular lecture of mine. And the third, as we all know as neurosurgeons, there is the endonasal surgery, which is the bread and butter of our endoscopic neurosurgeon, where endoscope is the only means of visualization and tumor removal, and this is commonly performed in cases of pituitary adenoma removal, where we perform the surgery through the nose and the paranasal sinuses. So let's talk about a keyhole approach. Well, this approach was first propounded by this wonderful human being, Alex Bernatsky, and where I first met him in 2008 in Jordan meeting. And he propounded this concept and said that it is not to reduce the size of the craniotomy to keyhole, rather to make a minimum possible craniotomy required to access a deep intracranial pathology. So it's not, there is no limit for the smallest size. Like it, if I say it's 1 by 1 centimeter, I may be quite wrong in saying that, but I mean, it is, what I mean to say is that it is the smallest possible size of the craniotomy, which I am comfortable with in removing the tumor pathology or any other pathology comfortably and keeping in mind the safety of the patient. So there are many books nowadays, but back in 2008, he was the first one to propound this theory of keyhole approach in neurosurgery with endoscope assistance. And I was quite fortunate to have interaction with him and see him working and employ his techniques into my surgical practice. Another personality is Charlie, and he's my good friend. Everyone in the world knows him, and I had a pleasure of meeting him a couple of times, and he has been here in the Paras Hospital and in India in several places to perform and showcase his skills in keyhole brain surgery, which has definitely got superior advantages as compared to the conventional neurosurgery. So this is his treatise, book written on the principles and practice of keyhole brain surgery. So let us talk about principles of keyhole. What is a keyhole concept? Well, a keyhole is a small hole or an opening through which we can view the entire room. Well, the view which we see through the keyhole is an inverted funnel vision. And which I mean to say is the visual field goes on increasing the moment we see farthest from the keyhole. So of course, this keyhole approach is the best for deep-seated lesions because my angle of vision through a keyhole will of course be wider as the vision goes deeper and deeper inside the skull. So one important thing which is to be kept in mind while fashioning a keyhole is that the keyhole once made is immobile. And of course, you can increase it always, but for a properly placed and appropriate keyhole, it has to be wonderfully placed, accurately placed, and hence use of image guidance before the surgical procedure is an absolute must to have before you practice on this approach. Another advantage of this keyhole is that you can have multiple viewing trajectories with wide and multiple angles of vision through this keyhole. So as you see, this is a reverse funnel-shaped vision in the keyhole, whereas in a normal microscopic surgery, the vision is funnel-shaped. It is broader at the superficial place and becomes narrowed down as you go deeper inside. And this is exactly the reverse in case of a keyhole. So this is the physics behind the keyhole approach. Another thing which you have to keep in mind for performing this approach is the best approach is along the long axis of the tumor. For example, in this thalamic glioma, the trajectory of approach has to be along the long axis of the tumor. And this is, as you can see, is the post-operative scan of the same patient showing complete tumor resection performed on the same evening after the surgery. Now, there are certain possible exceptions for this long axis rule. Of course, when the tumor lies in when the long axis lies in the along an eloquent area of the brain, of course, you cannot cross that eloquent area. So you have to modify your approach, avoiding that eloquent area as is illustrated in this diagram. And you have to go across the long axis, perpendicular to the long axis in order to avoid the eloquent areas. So certain things are not good for a keyhole. For example, looking at the back of the keyhole is not appropriate because the angle becomes very, very acute, and it's not possible even with a 75-degree endoscope to look behind the keyhole. So meaning thereby superficially placed lesions like in the second and the third illustrations shown here, they are not good for a keyhole craniotomy. For these lesions, you have to make a craniotomy as much as the size of the superficially placed lesions. So hence, therefore, at the very beginning, I told that this approach is very good for a deeply situated lesions where you can make a small craniotomy and your vision becomes wider as it goes down. So the advantage, another advantage of this keyhole is that the exposure of the brain tissue for several hours make it vulnerable to injury, thermal damage, especially with the microscopic surgery. If you are doing the light of the microscope, heats of the brain tissue. So for a normal conventional craniotomy, it's a 8 centimeter diameter craniotomy, whereas in a keyhole surgery, the size of the craniotomy is very, very less. So therefore, there is less brain tissue for exposure. One thing which is an absolute must, I previously mentioned also for a keyhole approach, is the neuronavigation, because you need to place your keyhole absolutely accurately over the size, over the location of the tumor. So this is essential for having a wonderful flawless surgery and for achieving a complete excision in the keyhole approach. This is a localization device, we all know that, which helps in localizing the tumor in a three-dimensional space intraoperatively. Of course, this has its flips also, like it cannot provide a real-time navigation, and there is a loss of navigation as we progress during surgery because of the flow of CSF and shifts of the brain tissue during the surgery. But it's an absolute must in order to plan your keyhole before you do the surgery. The second instrument available to us is the endoscope, and it is a beautiful instrument by which you can visualize the tumors in inaccessible areas, because the microscopic vision is a straight vision, and there are certain blind areas while you perform a microscopic surgery, especially with a keyhole. You cannot see under certain brain structure, so you can utilize the endoscope, the angled endoscopes, especially 30-degree, which is the most which I utilize during my surgical procedures, in order to identify the tumors hidden at certain places which are not visualized by a microscopic vision. So the combination of the intraoperative navigation and endoscopy has made the keyhole approach possible, and has provided a vast dimension to this wonderful technique. So this technology with the right surgical skill helps in complete tumor excision, achieving maximal EORs with as limited damage to the normal structures as possible. So we can do this keyhole surgery in any tumor, provided it is deeply located. And my purpose of this talk for the next few minutes will be the gliomas, as I was told specifically. So convexity keyhole is the keyhole which we require for gliomas most oftenly, especially if it is an intraparenchymal supratentorial tumor. We require a convexity keyhole, and now I will share with you some of my operated patients with this technique of glioma. So this was one patient of a high-grade glioma, and the trajectory of the approach is again along the long axis, and this is what I chose. And of course, the neuronavigation was used in the planning of the keyhole in all the patients, as it is being used in my surgeries. It is an absolute mandatory technique to be with you at your disposal by when you plan this keyhole approach. So this is the incision which is being marked preoperatively. Patient is obviously in the prone position, and we are entering the tumor as is shown by the location of the arrows here. The total size of the skin incision is some 4 centimeters, and this is the size of the craniotomy. And you see here dura being exposed after removal of the bone flap. And at the end of the surgery, or maybe in the middle of the surgery, you can take the help of the endoscope, and this is an endoscopic view which you are seeing, which helps you in identifying the tumors clinging around over the overhanging borders of the brain tissue, and you can remove some of the tumor tissue with the aim of achieving maximal rejection at the end of the surgery. So this is the advantage of the endoscope, and you see the normal brain tissue surrounding the tumor once the tumor is being removed, and you can visualize the remnants of the tumor tissue, which you can later on remove with the endoscopic assistance. Another such example of a callosal glioma here, the size of the craniotomy here is about some 3.5 centimeters. And as you can see, this is the post-operative, immediate post-operative first night MR of this patient, showing complete excision of the tumor. This is the volumetric analysis which we do routinely on these patients. This is the residual of about some 0.2 millimeter cube of the tumor tissue. Thalamic gliomas, yes, they are beautiful tumors to be performed by a keyhole approach, and the trajectory of this to approach this tumor is shown by a red arrow here. This is the site of the craniotomy, and this is the immediate first post-op night CT scan of this patient showing complete excision, the volumetric analysis of the tumor tissue. Now you see there are two skin incisions here of the same patient. Now one incision, this patient came to us having a biopsy obtained from somewhere outside. This is the larger incision which you are seeing in the image, and the adjacent incision is the smaller one through which we perform the entire tumor resection surgery. So this is a beautiful approach, a keyhole approach. Thalamic glioma, another one, the trajectory of the approach, and this is the immediate first post-op night in contrast enhanced MRI scans, and this is the first evening after the surgery. The patient is absolutely intact, moving both the sides and talking well, and there is no evidence of any neurological deficit in this patient. So I want to show you a small 2-minute video of this keyhole surgery. Now this is one patient of high-grade glioma, which we performed the same technique, and this tumor was associated with edema also outside peritumorally, and this is the bone flap removed, and the dura is being cut in a U-shape, which helps in better post-operative wound outcomes, preventing the CSF leaks. Now CSF leaks and pseudomeningocele, they are one of the major complications of a keyhole approach, because the opening of the dura is small, and I do prefer a watertight closure at the end of surgery. So you can see the cholecystectomy is being made in the direction of the approach that has been decided by navigation, and you see there is one vein which is traveling and coming into my way of doing a cholecystectomy. So all attempt has to be made for saving this important vein, maybe an important vein, so it has to be saved. And here image guidance is being used in order to identify that I'm going into the correct trajectory, reaching the tumor. So tumor is not reached till now, and the cholecystectomy is made deeper and deeper again. And another thing is that these type of surgeries always to be done under super zoom, super magnification, because there is a very little space, and you need to magnify this space, and you need to be accustomed to operating on super magnification. So this is the tumor here where you can see, and the biopsy is being taken, and then subsequently tumor decompression is being attempted with a suction or a Accuser. Now you have to be very, very careful here. Because the normal anatomy is very, very obscured because of the small size of the keyhole. So you have to be very, very accustomed and knowledgeable in order to know the difference between the tumor tissue and the normal brain tissue while you are attempting a keyhole craniotomy, especially when you are doing a low-grade glioma surgery. So the tumor has been removed in the ventricle. This is the choroid plexus over here, and at the end of the surgery, I generally take inside the endoscope, maybe not in this case, but generally I do take inside the endoscope in order to identify any remnants of the tumor tissue and to take out the tumor tissue if they are there anyway. So this is the preoperative scan of the same patient, and this is the immediate postoperative first post-op night CT scan of the same patient showing complete tumor resection. So the advantages of keyhole surgery for gliomas are it's being a significantly smaller craniotomy, less head shape as desired, less head shape is required, and which is maybe a significant concern, especially to young ladies. Of course, redo surgery if required for high-grade gliomas is made easier because there are more virgin plane of dissection available with less tissue fibrosis and tissue gliosis later on, because the tissue damage is less in the primary initial surgery. So the second surgery becomes relatively easier as compared to what in a conventional surgery. So another advantage is that the post-surgery radiation is known to make the scalp flaps, the scalp flap thin, and will lead to gaping of the suture line, leading to post-operative wound complications in conventional craniotomies. But here in keyhole surgery, the scalp flap is very little, and most of my incidents are linear incidents, so they heal very well after the surgery. But one problem is especially of a CSF leakage, especially when you've not taken care in closing the dura very well after the completion of surgery. So, but most of the times it's a common thing that the wound heals well, especially if you have taken care of a good closure. So the take-home message is keyhole surgery for gliomas may be done safely, and especially if you follow some principles of keyhole concept. And keyhole access makes incisions and craniotomies significantly smaller than conventional approaches, with subsequent better outcomes, better cosmesis, post-operative pain and swelling, and improved tolerance to post-operative radiation. Thank you so much.
Thank you, Professor Sumit Sinha. Now, it's time for a few questions since it's a very interesting topic. And has the vascularity of the tumor been of any concern to you prior to picking up these patients for keyhole surgeries?
Oh, well, no, that's Dr. Virinder. Well, it's. I may not say that it's always of a concern, either with a keyhole or a conventional craniotomy. At any point of time during the operative procedure, I do not feel any lack of space during the surgery. If the tumor is vascular, it will bleed with a conventional craniotomy also, and with the keyhole craniotomy also. And now coming to control the bleeding, there is absolutely no problem in dealing with the hemostasis in a vascular tumor with the keyhole approach vis-a-vis a conventional approach.
Any more questions, please?
No, sir, we can move on to the next talk.
Thank you. Thank you, Professor Sinha. Thank you very much. And we now move on to the next speaker, Dr. Manjari Pandey. She is the Assistant Professor, Hematology and Oncology in the University of Tennessee. And she shall be speaking on glioblastomas, treatment of glioblastomas. Is it really a dead end?
Thank you, Dr. Batish, for the kind introduction. And I'm very honored to be here to speak among senior consultants. It's a tough job to follow such an excellent talk. I'm going to talk about the treatment of glioblastoma from a medical oncologist perspective. And I'm going to try to give a brief overview of current strategies in the treatment of glioblastomas, and then talk about some future directions. So just to begin with the basic epidemiology, what we are dealing with is a relatively rare cancer, but extremely associated with extremely high mortality rate. While it represents about 2% of all cancers, it has a disproportionately high mortality. In the United States alone for the year 2021, we expect to have at least 24,000 new cases of primary malignant CNS tumors, of which more than 18,000 will succumb to their tumors. It is a disease of older adults. Now, of course, it is also one of the most common solid tumors in children, but it is a disease of older adults with a dismal 5-year survival of 5.5%. So treatment strategies in glioblastomas and what we have so far. Historically, the brain tumor study group started looking at the role of radiation therapy with or without carmazine in gliomas, and found that patients who did get radiation derived benefit, and there was a trend toward improved survival with the addition of carmazine. The next big change came when people started studying a number of nitrosoureas in different kinds of gliomas. And this was done for a fairly long time. PCV came up as a treatment for oligoastrocytomas and oligodendrogliomas. Eventually, we then started looking at temozolomide. And between 1990 and the early 2000s, temozolomide was the biggest thing that happened in the treatment of gliomas. Right around 2010s, we started studying bevacizumab, and given the very impressive progression-free survival seen in recurrent gliomas, Avastin or bevacizumab was studied in 2 large randomized phase 3 trials that happened back-to-back, the AVAGLIO and the RTOG0825 study. Unfortunately, both of them showed no benefit in overall survival. Some benefit in quality of life was seen in the AVAGLIO trial. Eventually, the next trial that actually showed any survival benefit was, again, Roger Stupp with this trial with the tumor treating field therapy added to what we know as the Stupp protocol of Temodar with radiation. This particular graphic just highlights the 3 big things that changed the way we manage glioblastoma currently in clinic. So radiation and Temodar followed by adjuvant Temodar, adding bevacizumab, which unfortunately, even though it does not prolong survival, is one of the few things we do for these tumors, and then tumor treating fields added to standard of care. On the top end of the graphic, you will see a number of drugs that are not approved that have been studied or are still being looked at. So just a very quick look at the Stupp protocol. So this was back in 2005 when it was first published. And then a subgroup analysis was done by Monica Hagee in 2012. And this trial showed that adding concomitant Temodar to radiation therapy followed by adjuvant Temodar improved overall survival, median overall survival from 12.1 to 14.6 months, and is currently still the standard of care. Monica Hagee's paper showed that MGMT hypermethylation was predictive and prognostic for improved efficacy. In fact, a lot of people argue there is no role for Temodar in unmethylated tumors at this point. So did it really change outcomes in the real world? Number of analyses have been done to look at this. This one particular analysis looked at least 63 population-based studies, and they stratified them according to recruitment prior to 2005, the earlier period, or after 2005, the later period. This study showed that pooled survival estimates for 2-year, 3-year, after between the earlier and later study period were double, so 9% to 18%, and 3-year from 4 to 11%. However, the pooled 5-year survival estimate did not show a similar improvement. And there are many reasons for that. One of them could be, again, these are analysis of population-based studies, data annotation, molecular profiling of these tumors, different molecular makeup of the tumors that made the population, and so forth. One also interesting aspect of this study was that it did show improvement in survival among the older population. This was contradictory to previous analyses that have been done. So Avastin, what did Avastin do for us? As discussed before, studied in 2 large studies, the AVAGLIO and the RTOG0825 study. Significant benefit in progression-free survival, unfortunately did not show benefit in overall survival. Many subsequent studies of Avastin have been done, looking at subset after subset after subset. Some people believe it helps the proneural subset of glioblastoma. However, there are many questions about pseudo-response from Avastin, probably leading to a perceived PFS benefit. Further, there was about 30 to 40% crossover in both these trials, and some centers cite that as a reason for lack of overall survival benefit. So then comes the tumor treating field therapy, and I understand that this is not currently available in India, but this is something that is game-changing in glioblastoma, and I would not be surprised if it's coming there soon. So EF14 trial looked at adding tumor treating fields to the Stupp regimen. It is a randomized open label trial that took glioblastoma patients after biopsy or surgery and randomized 2:1 to receive tumor treating fields plus maintenance Temodar or Temodar alone. So what are we talking about? What are these tumor treating fields? These are low intensity, intermediate frequency alternating fields that interfere with and prolong cell division, resulting in apoptotic death. To get this therapy, patients' head is shaved and transducer arrays are placed on the skin. The patients are advised to use it up to 18 hours. In real life, and ends up being all day continuously. Again, there is no high-grade systemic toxicity. However, skin reactions are common, and it's just difficult to keep it on. A lot of questions have been raised about quality of life with this therapy. So as you can see on this particular graphic, and I'm not sure if you can see my cursor, to the left is the picture of the device itself and the transducer arrays. The right side shows a mannequin wearing this device. The transducer arrays are placed on the scalp, which is roughly planned with their software called Novotel. This is nowhere as precise as radiation planning. It's a fairly simple technique that even medical oncologists can be trained to do. And patients are supposed to, again, shave their head and put these on and keep them on for as much as possible. And you'll be surprised how long people use it for. So this is the trial schema for the EF14 study. As you can see, temodar with radiation therapy for the first 6 weeks, and then 2:1 randomization to adjuvant temodar in 5 28-day fashion cycles for up to 6 cycles, versus temodar with what you see in blue, the tumor treating fields. This device was continued past first progression pre-specified in the trial protocol. And the results were stratified based on extent of resection, MGMT methylation status, among other things. So this trial, the median age of the patient was 56 years, 68% were men, 87% had resection, while 13% had biopsy only. 1/3 of these patients were MGMT methylated. These demographics are not very different from what we see in the real world or what we see in other trials. Perhaps the age is different from the real world data. So all analyses were intent to treat, and these, as you can see, the use of tumor treating fields along with temodar led to improved median overall survival, 20.9. Perspective of MGMT methylation status, age, extent of resection. The only thing that seemed to matter was the compliance, the duration of use of this device. So this is what we call the long-term analysis of the EF14 study. And as you can see, what's very interesting about this is the percentage of patients surviving year after year. So we had talked earlier about how the 5-year overall survival average is about 5.5%. People who used temodar with tumor treating fields, and in this case continue to use them, have a survival of about 13%. So this really pushed the bar for overall survival. So when we talk about glioblastoma, it is very important to discuss the elderly population or on the 3 landmark studies that define how we care for these patients. Now the STOOP trial excluded patients over 70 years, but there seems to be some benefit in survival in the patient population between 60 to 70 in that trial also. So the Nordic study looked at role of temodar versus hypofractionated radiation versus standard radiation therapy. And essentially what the study showed was that, and I'm going to switch between slides real quick, was that patients who got standard radiation of 60 gray tended to do poorly, whereas patients who got low hypofractionated radiation or temodar did up about equally well. What's also noticeable in these 3 graphs, A, B, and C divided by age, is that patients older than 70 years do better with temodar or radiation, again, depending really on their MGMT status. Similarly, the NOAA 8 trial was another trial that defined standard in the elderly population. These included patients older than 65 with a KPS of 60 or higher. They used temodar versus standard radiation 60 gray, and the temodar dosing was different. This was 100 milligram per meter square, week on, week off. And in this particular trial, again, temodar was not inferior to standard radiation, but there was increased benefit of Temodar in patients who had their MGMT hypermethylated. Finally, a more recent study by Perry et al. That looked at 560 patients plus who were treated with, basically it's like the Stoop protocol, except that the radiation is 40 gray in 15 fractions. So they got 3 weeks of chemoradiation followed by adjuvant Temodar, and they did show a survival benefit. Addition of Temodar to radiation showed a median overall survival of 9.3 versus 7.6 months. And as expected, benefit of Temodar was more in patients who were MGMT hypermethylated. Graphics showing the survival. Also noticeably in this study, while the inclusion criteria was 65 or older, at least a third of these patients were over 75 years of age even. So definitely something to think about. After the Stroop trial, a more recent study, the NOAA-9 trial, has shown this study tried to include the MGMT methylation as a marker for enrollment. So this was for patients who had MGMT methylated GBM and were treated with CCNU plus Temodar in addition to radiation therapy, and showed benefit in overall survival. The median overall survival in the modified intent to treat population was 37.9 months versus 31.4 months in Temodar arm. While this trial did show improved survival in MGMT hypermethylated patient and definitely adds to our options for therapy, this was not considered a practice-changing study because of poor accrual and also lack of molecular data besides MGMT, potential inclusion of mutated IDH patients and hence relatively lower grade glioma patients on this trial. So recurrent glioblastoma. Treatment really needs to be tailored to the individual. While clinical trial would be the #1 preference, resections are encouraged in the appropriate setting. Radiation, hypofractionated versus SRS. We don't know if one is better than the other, but hypofractionated, possibly less risk of radiation necrosis. Re-challenge with Temodar is a very reasonable option. 2 studies, the rescue trial and the directed trial, have shown some relevance and some role of the timing of recurrence from prior Temodar into the potential benefit of temozolomide in this scenario. Bevacizumab is FDA approved for recurrent glioblastoma, but again, we know does not add to overall survival. It adds to PFS, quality of life, decreasing steroid use, and so forth. Nitrosurias are commonly used in this part of the world. We use lomustine, but other nitrosurias as well. And then Optune or Novo TTF. There is no clear standard of care for salvage therapy for this tumor. So are we at a dead end? I hope not. So how will we push the bar? First of all, change the way we think about these tumors and perceptions and keeping our mind open to newer therapies. I had mentioned to you about tumor treating field therapy, which took quite a long time for acceptance over here in spite of a very positive phase 3 randomized control trial, and only now is gaining more and more acceptance even in so-called academic centers or centers of excellence. Understanding the molecular signatures of this tumor. So we will talk about the WHO 2016 classification and then some updates thereof. Finally, interaction of the CNS with the immune system used to be considered an immune privileged site and now is an immune specialized site. Role of liquid biopsy, and then of course artificial intelligence in healthcare. I will not be focusing on advancements in surgery and necessarily specific advancements in radiation in this particular talk. So how can we get better? One study noted that there is indeed a difference in performance between high volume and low volume centers. Based on the National Cancer Database, GBM patients were characterized by facility type, so academic center or not, and then the volume. High volume facility was defined based on 15 cases a year, which does not seem to be that much. At our center, we treat over 40 a year. So over 40,000 patients were included in this analysis, and as you may expect, patients treated at an academic center with high volume experienced longest survival versus academic centers that are non-academic or low volume. Further, resection, radiation, chemo were also most frequently utilized in academic centers and high volume centers. What about the duration of Temodar in glioblastoma? It is more better. Should we just keep going? Until recently, that used to be the dictum. Once patients had benefit from Temodar, people used to continue treatment until progression. However, over the last few years, we have pooled analysis or multiple analyses that show otherwise. So in one of the pooled analysis of individual patient data from 4 randomized trials for newly diagnosed glioblastoma showed that patients who had treatment for more than 6 cycles with Temodar had a somewhat improved progression-free survival, especially the MGMT hypermethylated patients. However, there was no significant difference in overall survival. As expected, there was increased toxicity. Similarly, there's the German glioma network data that came around the same time and showed that there was no significant association of prolonging Temodar chemotherapy on either PFS or OS. Now, remember, both of these data were irrespective or adjusted for age, resection, performance status, MGMT status, or and in the latter case, IDH status as well. So coming back to our tumor treating fields, so there was a post hoc analysis done on the EF14 study that looked at compliance, which is how much is a patient actually using this device. The recommended threshold is 18 hours a day. So that makes a compliance of 75%, which is what the trial would have aimed for, which is what clinically we recommend our patients to wear it for. However, this analysis showed that at a threshold of 50% compliance, there's already an improvement in overall survival. And yes, more is better. The more a patient uses it, the better or more benefit we see in overall survival. So that's another thing we can work on or improve on, is the compliance with the tumor treating fields. At our center, we have a trial called the Trident study, which actually starts tumor treating fields with radiation therapy. And so patients with newly diagnosed glioblastoma post-biopsy or resection are then randomized within a couple of weeks to starting Optune tumor treating fields with radiation, continuing through adjuvant therapy and that point on. So the other thing we can work on is to push that bar is understanding the molecular signatures. And I'm sorry, I cannot see how I'm doing on time, so please do interrupt if needed. So the WHO 2016 classification was a big deal because it added molecular parameters to histology. The need for better diagnostic accuracy, prognostic information led to the development of this classification. Genotype trumps histologic phenotype according to this classification. However, we cannot yet proceed on genotype alone. So we still need histology. We still do grade determination based on histology. So for example, to the left is the 2016 classification, to the right is the older one. As you can see, the diagnosis requires the presence of IDH status, mutant or wild type. If we do not have it or we cannot assess it, we give the criteria NOS, not otherwise specified. Basically means we will need to do more work on it. Another important aspect of this classification was to try to do away with or discourage oligoastrocytoma as a histology. So where did this all come from? This came from a better or improved understanding of the molecular pathogenesis of gliomas, we started understanding that IDH mutation is an early event in gliomagenesis. And so
We are running out of
this,
time.
I'm sorry.
We're running out of time, please.
I'm halfway through my presentation. So what I will conclude very quickly. As we understood more about the molecular phenotypes, we realized that histologic classes don't matter as much as molecular phenotypes do. So on the left, we see gliomas classified to histologic grade. As you can see, GBM, which is the bottom orange line, does the worst, and low grade oligo dendrogliomas, which is the top green, do best. However, same tumors classified according to molecular subtype. On the lowest bar, again, GBM, wild type IDH, but the red line right next to it on the bottom is a so-called low grade glioma with IDH wild type. And so that led to inclusion of IDH in WHO 2016, and now see Impact Now, which is the consortium that leads to further updates to pathology, not where WHO is not able to keep up. The most important thing that came out of this is the definition of a molecular glioblastoma. So if your tumor, even though it's been called a low-grade glioma, is IDH wild type and meets any of these criteria, EGFR amplification, 7 gain, 10 loss, or TERT mutation, TERT promoter mutation, it would be classified as a molecular GBM. And so the push is not to say glioblastoma IDH wild type or mutant, but really the terms is suggested astrocytoma IDH mutant or not. The other thing is the understanding of immune interaction in CNS. And so again, glioblastoma is a very immunosuppressive environment. The treatment itself is immunosuppressive, but the tumor also, microenvironment leads to immunosuppression through various factors such as TGF-beta, IL-10, IDO, and so forth. Interestingly enough, number of treatments have been studied. So far, no big successes in terms of large randomized studies. Failed promises include rindopepimut, DC-WAX, and multiple checkpoint inhibitors. However, there are trials ongoing with immunotherapy, of course, including CAR therapy. Targeted therapy for glioblastomas have been tried from the beginning. VEGF-directed therapies would be a big example. Current strategies include looking for BRAF mutations, NTRK fusions, and so forth. So the takeaway from this slide is it is worth doing molecular profiling on these tumors when we are able, but the response rates of these therapies is not as good as other tumors. And the challenges are tumor heterogeneity, redundant signaling pathways, lack of blood-brain barrier penetration, and so forth. The other thing we could do is improve how we biopsy these tumors. So liquid biopsy, just as it's being used in other tumor types, in a pathologic state, such as a tumor, the blood-brain barrier becomes leaky and the biomarkers can shed into circulation, which can be cell-free DNA, circulating tumor cells, EVs, and so forth. And potential
Manjari, can you conclude?
Yes,
We're running short of time.
Yes, absolutely. So liquid biopsy is another upcoming thing that can push the bar. And then finally, artificial intelligence, machines doing better than we are at the job of treating these patients with glioblastoma. And I will conclude over there. Thank you so much.
I would request maybe we can take one quick question, sir, and Dr. Mehta to please facilitate Dr. Manjari.
Well, glioblastoma still remains a dead end, whatever research we are doing it. But to my mind, one has to find out, the research has to be focused on what causes glioblastoma. Unless we find out that, I think we'll remain dead and will remain. Because all these have improved result by a few weeks or months. But we have not yet close to the cure of these glioblastomas. So,
That is
well,
an excellent
excellent
comment and excellent point. I have no arguments against it.
I know we can go on arguing on this topic, but
I had first met Dr. Mehta once in 1999, And that time the same argument was given, continue to search for a cure for glioblastoma, and we are where we were at the moment. Like Professor Mehta said, just a couple of weeks or a couple of months extra.
Both the points are well taken. I think, like you said, we need to understand the tumor better. I don't think we understand what is going on yet.
Thank you, and for excellent talk. Dr. Manjari, this is a certificate to felicitate you, and really a nice talk. You have reviewed the whole glioblastoma, the treatment and oncology. Thank you very much. Thank you.
Thank you. Thank you for bearing me.
Matish, can you invite the next speaker?
Sure. Call upon Dr. Rakesh Jalali from Apollo Proton Cancer Center. He's the professor of radiation oncology, senior consultant and lead neuro-oncology cancer management team. And he's also on the chair, Senior Advisory Council, Indian Society of Neuro-Oncology. He's the member executive committee, Neurological Society of India. Dr. Rakesh Jalali, please.
Thank you. Just putting my I apologize.
Let's just open your PPT. Sir, I'm audible. Hello.
Yes, you are audible.
Yes, sir, just open your PPT.
Okay. Can you see the PPT?
Yes.
Okay, great.
It's
I apologize for the small
just start. No, it's okay. Just start.
Okay. Thank you very much for this opportunity. It was a great session and very enjoyable and very illuminating talks by my previous speakers. So I'm going to talk on proton therapy in brain tumors and whatever experience we have had in the last 2 to 3 years in this, when we started in Apollo Proton Cancer Center in Chennai. I'm trying to move the slides, unfortunately. Is it possible to move the slides? And
Manas, do we have Sir's slides with us?
No, ma'am.
I'm trying to move the slides, unfortunately.
Yes. Sir, please.
Yes.
Go to the slide again.
Yes.
Stop the sharing and again share the slide. Sir.
Sure. Yes, there we go. All right. So again, sorry for this little bit technical glitch, but I hope you can see my slides now. So I'm going to straight away delve into, we get this era of, you get all these modern radiation technologies over a period of time, whether it is IMRT, IGRT, then you have the CyberKnife and so on and so forth. And now you have the particle beam therapy. One of the debates always has been, what is the evidence for all these modern radiation technology? Most of the time we adopt it on the basis of dosimetric advantage, but my colleagues and myself in Tata Memorial, we managed to do this phase 3 randomized trial, which was appropriately powered enough to detect a meaningful clinically relevant endpoint of long-term neurocognitive and endocrine functional at the end of 5 years with meaningful survival in both the arms between a high precision stereotactic radiotherapy versus conventional radiotherapy in a cohort of young patients with low-grade and benign tumors. So essentially what it demonstrated that the smaller volume of irradiated normal tissue did result not only in a dosimetric advantage, but also a significantly superior outcome for clinically relevant endpoints. So it's kind of a proof of principle study that whenever you have a dosimetric advantage, many a times it can actually lead into clinical advantage as well. We know that proton therapy has been there for a while, but there has been a complete kind of an evolution, especially in the last 10 to 15 years, what is now called contemporary proton beam therapy. So we have moved from what was erstwhile the scatter technology to and what is now modern called image guided pencil beam technology. So in the past, we had a scatter technology where we had to put apertures and we had to put collimators, and therefore some of the advantages were not there. But now with the help of a single small kind of a spot, which can be ranged as low as 3 millimeters, literally a tumor can be divided into a certain depth, and then you can treat by spot, line by line, layer by layer, with many energies, which can treat all the superficial as well as deep tumors and can result in highly conformal dose distribution. The other advantage is that there is significantly less neutron contamination, and also you have incorporated an image guidance system with the help of cone beam CT. And there are sophisticated treatment algorithms using Monte Carlo simulations, both for optimizations as well as for the calculation, and does result in highly conformal dose distributions in many of these tumors. Now, the American Society for Therapeutic Radiation Oncology came out with this model policies where they labeled the group of patients into 3 groups, and group 1 was there was a reasonably good data to support especially the modern IMPT. And as you can see, the traditional indications of melanomas, the base of skull, particularly chordomas and chordosarcomas, some of the spinal tumors, but also the patients with genetic syndromes and also malignant and benign primary CNS tumors. In the pediatric neuro-oncology group or pediatric oncology group in particular, vast majority of the international consensus guidelines in healthcare systems are proposing to move from the erstwhile photon, for example, all the low-grade gliomas, the optic pathway gliomas. If you can notice, the low-grade gliomas, optic pathway, medulloblastomas, craniopharyngiomas, pineal tumors, chordomochondrosarcomas, and also vast majority of ependymomas. If you do have the facility to move over from photon to proton, it is highly recommended that you do it based on the superiority of the clinical evidence, particularly in terms of preservation of normal function and preservation of long-term survivorship. As I mentioned, we have now crossed 300 odd patients in our center, and it's a relatively rapid accrual of the databases for the last 2 years or so. And about 44% of these patients belong to the CNS, both in the adult and pediatric. And we have published our detailed physics performance evaluation for the first proton therapy facility in India. As we know, the intensity modulated proton therapy also has actually made a further advantage, particularly in skull-based tumors. And these are traditionally difficult to resect because of their location, and they tend to have recurrences. Sometimes people have tried to do hypofractionated stereotactic radiotherapy, particularly, for example, like even like on a LINAC or a CyberKnife, but we know that they can actually be very difficult to locate, and particularly in close relation to important neurovascular bundle. Traditionally, they need very high doses, which you cannot accomplish by any photon technology, both for chordomas and chondrosarcomas, and we knew that the protons can improve by about 15 to 20%. With the advent of image-guided pencil beam IMPT, you can further increase by again 15 to 20% based on very large series from European data, and where you can see the 7-year-old survival is quite encouraging, and chondrosarcoma even better in this cohort of patients. We have also treated a fair number of clival chordomas because they still form a major chunk of our practice. And we have managed to go up to very high doses of 72 cobalt gray equivalent, both in chordomas and chondrosarcomas. Chondrosarcomas, sometimes you can manage with slightly lower doses between 66 to 70 gray. And so far, all of our patients have done quite well. We also looked at in detail about the 3D dose reconstruction, and this publication came recently in PMB, where we have demonstrated that in this cohort of patients, particularly with respect to dose conformity in the D95, as well as the reduction of D2, which has relevance to the proximity of the brainstem, we could manage to achieve a reasonable dose distribution in most of these patients. So anywhere between 54 to 56 gray up to 72 gray, depending upon the dose gradients that you can achieve with the IMPT, you can actually accomplish quite a nice dose distribution in these traditionally difficult tumors to treat. And some of the interesting data is that, for example, this was a residual which had been operated twice already, chondrosarcoma. You can see while the size may not change after post-proton, you can see kind of a liquefaction inside, suggesting some kind of response. We are now embarking on a prospective study looking at T1 perfusion as that was the anatomical endpoint, and this is the biological endpoint to assess some of these responses with respect to this high dose radiation, particularly with the proton beam therapy. We have published our series recently about in the JCO's Global Oncology Journal about our preliminary experience of treating children and young adults. And this is the first series from our country with a range of tumors rising between the childhood and young adult population, which comprised a fair number of brain tumors as well. I'll give an example of craniopharyngioma, which is an excellent kind of an indication which I demonstrated earlier. This child was actually our first patient treated in the country, where we were observing the child for a while, and eventually the tumor was slightly increasing in size. We always run a very good photon plan, and we have very good photon planners also with helical tomotherapy. And as you can see, that there is a significant advantage of using the IMPT protocol, particularly in relation to sparing of the frontal lobes, the left temporal lobes, and also the hippocampus. And hippocampus, as we know, is an exceedingly important organ, particularly in preservation of the long-term cognition. We have to be a little careful in the proton therapy, of course, because being the particle charge, the charged particle, so it is very much dependent upon the density. So we have to be careful. We do quality assurance MRIs at least 3 to 4 times during the therapy. And sometimes we know there could be a change in the cyst volume. For example, we had this case where during the treatment only there was a little bit of change in the cyst, so we have to do an adaptive plan. While on the other hand, this case after 20 fractions of IMPT actually showed a reduction in the solid component as well as in the cyst volume. And therefore you have to again adapt because of the cavities and the bone, and sometimes even some shunt and Omaya, you have to place your beams in such a way that they don't go into that so as to cause dose perturbation. So it does need a fair amount of quality assurance and meticulous planning. But if you put it in your SOPs and protocols, you can do a good job. We have earlier demonstrated, based on my previous institution's work in TMH, about the importance of hippocampus, and it's one of the few studies in the world which had a baseline as well as a prospective neurocognitive data at the end of 5 years in a reasonably large cohort of patients treated uniformly to a dose of 54 in 30 fractions, and we demonstrated the doses to the mean dose to the left 30 gray could be a potential dose constraint cutoff for the IQ decline. And this dose value can be many times accomplished in many of these tumors, particularly the neatly how the conform, the low and intermediate dose wash, which is significantly minimized in the proton. That also has some relevance, for example, in pituitary adenomas, both in the non-functioning adenomas where there could be a residual disease, particularly, for example, in the cavernous sinus or sometimes in recurrences, but also increasingly in functional adenomas. And along with the KEM and TMH group, we have demonstrated that perhaps in functioning adenomas, even if it's a microadenoma, it might be a good idea to include the whole cella and supracella. It's kind of almost like a hypophysectomy, but because of the proton beam therapy, you can significantly reduce the doses to the hippocampi in a conventionally fractionated dose regimen to 45 and 45 gray in 25 fractions, and that can show some increasing improved outcomes as well. The one area where the proton has shown unequivocal benefit is the craniospinal irradiation. And we have treated a number of craniospinals. I think we have treated now 30 odd patients. already in the last 2 years with CSI, particularly for medulloblastomas, where you have to treat the whole cranial spine. And the advantages, and literally you can see there is practically no dose anteriorly to the gonads, to the, to the bowel, to the thyroid, to the heart. And this is a very nice dose distribution. And if you compare with photon, there will be invariably a large chunk of normal tissue which would be irradiated otherwise. And this is a very good distribution. We have the paper in this press at the moment, both from our robustly optimized hybrid IMPT plan for CSI. And again, as you can notice, we typically use 4 fields, but first with the 2 fields for the brain and upper part of the spine. And then depending upon the length of the spine, you can possibly treat either with a single field or with 2 fields sometimes, and with a gradient of around the junction about 7 to 8 centimeters. We also notice in pediatric population, because of the end of the range uncertainty, we are consciously introducing a small dose gradient towards the anterior part of the esophagus, and such that there is less esophagitis and no interruptions, and that has been quite gratifying as well. And this paper is in press as well. In adult medulloblastoma in particular, you don't need to treat the entire vertebral body. And we all know whenever we give chemotherapy in adult medulloblastomas in particular, the tolerance to the chemotherapy because of the CSI may not be as brilliant as in children. And because of the IMPT technology, again, because you don't have to treat significantly the vertebral body, and there's a sharp fall off based on several series, and including one recent series also have shown that the tolerance and the interruptions due to chemotherapy are much less. There has been very increasingly nice data on intracranial germ cell tumors, whether it is germinoma or non-germinomatous. Germinomas you can treat with whole ventricular radiation, and this is one of our children who have treated with whole ventricular radiation, and she went on to score exceedingly well academically. And in non-germinomatous germ cell tumors, of course, you have to do the classic CSI with not very high doses. And we have just published last month our first series in Indian Pediatrics about the proton beam therapy in the intracranial germ cell tumors. What has been also unequivocally proven series after series, particularly with IMPT, is the significant reduction of second cancers. Unfortunately, we know in a cohort of patients who are long-term survivors, whether it's a pituitary, whether it's a cranial, whether it's a medulloblastoma or an ependymoma or even a low-grade glioma, some of these patients, unfortunately, about 1 to 3% or even 5% can develop second cancers because of the photon. With the protons, because of the advantages of reduction of the low dose wash, the incidence or the risk of second cancers is practically exceedingly low, and that is another great advantage with proton. Dr. Nayar's made a brilliant talk on ependymomas. We have a good series of 15 odd patients with ependymomas already treated in our center. Our policy already has been to treat the craniospinal in all recurrent settings. We also do routinely 1Q gain, which has been shown a very important biomarker, especially with terms of the leptomeningeal spread. In the upfront setting, of course, we always do the focal radiation, whether it is in the brain or in the posterior fossa, particularly the PFA types, even in very young children. We also know that the bar for treating children, especially the PFA types, ependymoma is coming lower and lower down, particularly with the St. Jude series. We do not no longer treat 3 years being the cutoff because of both not only the proton, even for the photon, we can treat very young children, especially the grade 3 anaplastic ependymomas, the posterior fossa A type. This was one of the such children, 16 months, is the youngest child we have treated in our center so far, and is doing extremely well so far, but we still have to keep a close watch because they tend to be quite aggressive otherwise. Some of the difficult pediatric low-grade gliomas, this was a cervicomedullary pilostic astrocytoma, which we were observing with Dr. Dev Pujari in Bombay. Eventually, it progressed. There was a partial debulking done in an intraoperative neuromonitoring. They had to stop. The patient was symptomatic, unfortunately, had grade 2 or grade 3 power. We gave pencil beam proton therapy. I have seen with respect to the photon, there seems to be slightly better shrinkage of the tumors, and we don't have the full data on it. We are analyzing it, and you don't need very high doses, about 45 to 50 gray. This particular boy did exceedingly well and has complete recovery of the motor power. You already heard the favorable low-grade glioma story that we do radiation. For these patients, this was one such case, corpus callosum, deep-seated tumor. Only a biopsy was possible. Again, Dr. Dev Pujari's patient. And they showed a good response, although it was an oligodendroglioma with all the three. As you know, we do routinely now all the three molecular markers, the IDH, 1p92, and also the TERT promoter. The NRG is looking in a randomized fashion as to look at the best technology of the proton IMPT versus IMRT in a randomized with a very appropriate clinical endpoint of neurocognitive function and patient-reported outcome. And this will be quite interesting to see when the results will come. Finally, as was mentioned by Professor Mehta, and I completely agree with all of the people, that glioblastoma still is an extremely difficult tumor to overcome. You know, it's so, we have done literally everything, but still no major gain apart from the advent of temozolomide and a little bit about the TTF. All the molecular therapies, including immunotherapy, has failed. So whatever we do, there can be some advantage. It has been demonstrated that lymphopenia, particularly decreases the overall survival in GBM, and we were thinking it is because of the temozolomide. Now we know it's also could be because of the radiation therapy. So there is some data emerging on a phase 2 fashion in GBM as well, where potentially the protons, because of the limitation of the exposure of the lymphocytes during the radiation, could possibly have some benefit. These are very, very early. We don't do it routinely in our practice. This has been being tested in an American NRG study in a randomized phase 2 trial where they want to give as high as, you know, more than 72 grade, such that 75 grade radiobiological equivalent. Whether that will make a difference or not, we do not know. But these are some of the things that are being pushed in the field. Finally, also there has been debate about the cost effectiveness, because there is a reasonably large investment both from the healthcare provider but also from the patient's perspective. But it has been demonstrated based on extensive Marco simulation economic models that, particularly for the growth hormone and also for the risk of hypothyroidism in childhood brain tumors, and the IQ preservation, because eventually you have to see the social endpoint also, the outcomes in terms of survival, but also the preservation of IQ, the reduction of the growth hormone deficiency, reduced adverse events, particularly in young adults and children, whether that has any correlation eventually, even if it is more intense economically, but eventually it actually gains there is a gain, and so therefore it could be cost effective. Whether it is in our country or not, that's a big debate, but nevertheless, there are some interesting data out there. So with that, I thank you for your all attention and also acknowledge the team that we have both in my previous institution and the Apollo Proton Cancer Center. We are running a first Apollo annual Proton Practicum on 15th to 16th May, and I hope some of you can join to learn about the field. Thank you very much for your attention.
Thank you, Rakesh. Now I have one question. How much time it takes it to be effective? Suppose you give today, you have to wait. For example, in gamma knife, we say 4 years. In proton beam, how long do you want to wait? And can you give reproton?
Yes, so both are good questions. You know, in the proton is similar like photon. There is not a major advantage. However, radiobiologically, what we call RBE, the proton has the RB of 1.1 to 1.2 or even 1.3 sometimes. So it has been postulated, even if you give the similar doses, there can be a slightly better shrinkage. And we have already seen, particularly even in tumors like pituitaries or cranios or meningioma, like I mentioned. And so that is one advantage. Re-radiation, whenever you have to do re-radiation, of course, all the international cooperative groups, because of the reduction of the surrounding structures, the proton is actually one of the most favored technologies. And you can sometimes do even re-protons also, particularly, for example, in ependymoma, you have treated initially, and then after a few years, there is a recurrence, and you can re-radiate those patients as well. So both the questions, there is a slight edge over the photons in proton.
So what is the average time when it is?
Sir, that is very difficult to predict because that depends upon many factors. That depends upon the type of the tumor. Sometimes I have seen craniopharyngiomas reducing even few weeks to few months. And on the other hand, some of the tumors may take many years. In benign tumors, the endpoint is not actually shrinkage, the endpoint is stabilization of the tumor, as we know.
Yeah, that is for gamma knife also. So yeah, that's what I'm saying. For gamma knife, you take 4 years.
See, that is the average again. So as I said, slightly better than gamma knife because of the RB is better, because at the end of the day, gamma knife is also photon. And because proton has a better RB, I'm not trying to say too much about it because the difference, the magnitude difference is only small, but there are some early signals on that front.
Okay, thank you. Batish, please take over.
Thank you very much, sir. Thank you, Dr. Rakesh. It's been a wonderful talk. And we now have the panel discussion, which will be, the moderator would be Dr. Anshuman Bansal, who's the Assistant Professor in Radiation Oncology at the Government Medical College, Patiala. Dr. Anshuman Bansal, please.
Yeah, good morning, everyone. Am I audible?
Yes.
Okay.
You're audible.
Okay. So is my screen visible?
Yes, absolutely.
Okay. Yep. Okay. So good morning, everyone. We'll be discussing management of brain metastasis, what and when. And in this panel, we have Dr. Sanjay Dhawan, HOD Radiology, Paras Hospital, Gurgaon. Hello, sir. Dr. Anil Dhingra, Consultant Neurosurgeon, Paras Hospital, Panchkula. Dr. Tejpal Gupta, Professor Radiation Oncology, TMH, Mumbai. Dr. Anurita Srivastava, Associate Professor, Radiation Oncology, Namsi, Delhi. Dr. Vimoj Nair, Assistant Professor, Radiation Oncology, University of Ottawa, Canada. And Dr. Sumit Goyal, Senior Medical Oncologist, Rajiv Gandhi Cancer Institute, Delhi. I welcome all the panelists. Today we will be discussing one case each of CA breast and CA lung who had brain metastasis. We start with our first case. So case 1, Mrs. SJ, 62 years patient, known case of carcinoma left breast post MRM, stage PT3 and 1 M0, ER negative, PR positive, HER2 negative, given 8 cycles of chemotherapy, 4 AC followed by 4 Taxol and local regional radiation, 40 grain, 15 fractions in 3 weeks, last in June 2017, and was put on letrozole for the past 2 years. She presented with incidental finding of liver SOR on follow-up ultrasound in July 2019. PET CT done in July 2019 showed FDG avid SUV max 8.8 isodense lesion in right lobe of liver, segment 5, 2.1 into 2 centimeter. Ultrasound guided FNAC was suggestive of metastatic adenocarcinoma. Biopsy was done, but the material was inadequate for reporting. Patient was treated by SPRT to liver lesion with the dose of 9 day into 5 fractions. She was given 6 cycles of systemic chemotherapy with injection gemcitabine, which completed December 2019. So 1 year post SPRT, she presented with headache and nausea in February 2021, and CMRI brains were suggestive of 2.1 into 2.8 into 2.5 centimeter lesion in left high frontal region, abutting adjacent meninges, and with significant perilesional edema. PET scan was suggestive of single lesion in left frontal region, and there was no uptake in treated liver lesion. So no abnormal lesion was elsewhere in the body. So we have the first question here from our radiologist. So do we have a differential diagnosis on MRI in brain here? And do we require any additional spectroscopy, diffusion or perfusion MRI imaging in this case to reach the diagnosis?
Thank you very much for the invitation here this morning. And the case we are discussing, actually, the diagnosis depends on the clinical setting. In this case, the patient is a known case of carcinoma breast, already having 1 metastasis to the liver. And the MRI, whatever images I have seen, it reveals a mixed solid cystic heterogeneous lesion, which is showing, again, heterogeneous enhancement. There is a nodular component which is showing enhancement. There are cystic areas within it. And the lesion is associated with significant perilesional edema. So in this clinical setting, obviously, we will put metastasis as the first, but a similar appearance could also be seen in a high-grade glioma. So I would not think of any other differential on the images I have seen. And second question, like about additional spectroscopy or diffusion. I think, diffusion and perfusion will show similar results, but MR spectroscopy would be useful if we really want to distinguish between a metastasis and a high-grade glioma. Reason being, high-grade glioma is a very infiltrative lesion. So we could pick up MR spectroscopy choline peak in the areas which we are perceiving as perilesional edema, which is not the case with metastasis. But yes, given the clinical circumstances, obviously metastasis would stay on the top.
Okay. Dr. Tejpal, do you want to add something on this?
So
Are you
I,
replacing?
so I think this is metastasis unless proven otherwise.
Okay.
I mean, since this is the only site of disease, and if amenable to a surgical resection, probably that would be an approach. But for diagnosis, I don't think any other imaging modality is required. This is a metastatic disease in the given clinical context.
So I want to ask one thing more. If you plan this patient for radiation, suppose we plan this patient for radiation, then do you go for any other imaging, or CMRI brain is sufficient?
So if that depends, since this is the only site of disease, we would, if you're planning radiosurgical treatment, we would need very thin slice double contrast MR sequences to identify if there are other additional small metastases, which may not be picked up on a routine MRI sequence.
Okay, see. So we move on to our next question. So the management options, we go to our neurosurgeon. Sir, please, what to do next?
I'm Dr. Dingra. I've seen the images. It looks like a metastatic disease. Then I think no doubt against the gliomas. And if the patient is clinically stable, if there are no neurological symptoms more than only headache is there, I think they have no neurological deficit, no hemiparesis there. We can start with the decongestants and steroids. Thereafter, we can plan either surgery or radiation. These days, I think both have equivalent approach outcome with the surgery or I think gamma knife for radiation. So depending on the situation, if the patient is having mass effect with worsening neurological symptoms, then we can go for immediate surgery. Otherwise, patient is intact, then we can plan, I think, for the radiation, I think.
So Dr. Vimoj Nair, sir, if you are planning, what patients do you consider for radiation with a single brain lesion? So what criteria do you follow to select a patient for radiation?
I think it very mimics what Dr. Thingra has said. In patients who have response to steroids and there's no mass effect and is clinically intact, it could be a candidate for stereotactic treatments. On the other hand, if there is a mass effect refractory to the steroids, one could consider surgery. Now, in the past year, that said, there's been at least 2 patients that have been referred to me with the previous history of breast cancer saying give stereotactic treatment, which I felt looking at the imaging that this might be a glioma. And yes, I did have said, I think we need some more imaging. And the 2 cases ended up being a GBM, but those cases didn't have metastatic breast cancer. Those patients had early breast cancer. But so in this case, to me, this looks like a straightforward, just like Dr. Tejpal said, brain metastasis. And I would favor surgery with that bulk of disease first to reduce the volume in my practice. Yeah.
Dr. Tejpal.
Yes.
So what's your opinion?
I think this looks a slightly largish lesion. It's not a very small lesion. And I would, if this is the only site of disease, it's better to do surgery followed by further adjuvant cavity radiosurgery rather than just do the radiosurgical treatment alone.
Sir, is there any size criteria you follow for taking patient for radiosurgery or?
I mean, for surgery, certainly. I mean, largish tumors, any tumor which is causing mass effect and neurological deficits, you cannot reverse that without doing the surgery. For radiation therapy, if you're talking about intact brain metastasis, we typically would have tumors that are less than 3 centimeter in size, preferably 2 centimeter or less. And for cavity radiosurgeries nowadays, increasingly based on the guidelines regarding contouring of the cavities, it's very difficult to give a single fraction radiosurgical treatment. So we do hypofractionated in 3 to 5 fractions. When you do 3 to 5 fractions, then your volumes can be larger than the traditional 5 cc cutoff that is there for single fraction radiosurgical treatments.
So suppose you plan this patient for radiation alone. Suppose the lesion is very small. So do you routinely undergo these patients with stereotactic biopsies, as we require ER/PR status also? Suppose this is a single lesion.
Difficult question. I think there is data that there is change in the ER/PR status at metastatic sites, and that's why the breast oncologists typically require a biopsy wherever feasible. In the brain, I think that's difficult. Just to do a biopsy for ER/PR, I would certainly not recommend just for getting the ER/PR status. But as I said, I would prefer to do a surgical resection, and that would provide tissue for ER/PR. But if we are planning radiosurgical treatment, I would not advocate doing a biopsy on this patient.
Dr. Anurita, is the opinion different, or we should go for surgery?
No, I think we should go for surgery. It's too large. So there will be immediate symptom relief.
Okay. Thank you. Okay, my next question is, so this patient underwent surgery in Feb 2021, and the HPR was suggestive of metastatic adenocarcinoma, and she is now triple negative. So what should be offered to patient first? The medical oncologist, Dr. Sumit Goyal.
Yeah, good morning, everyone. Here, the patient is now has become triple negative. She had a single lesion in the brain, which was taken care by the surgery. Now, if there is no extracranial disease, even if the extracranial disease is there, first thing we need to be sure that this lesion is addressed properly. So here, I would like to complete the local treatment first. I would like to go for complete the radiation first.
So I think all radiation oncologists will go for radiation first. So,
I think even the medical oncologists would go for radiation to the brain first.
Yes, sir. They are going. So I don't have.
Yeah.
Okay.
Well, I would like to do before going for surgery, a functional MRI.
Okay.
Just to know where is the motor area, because you didn't told about any neurological deficit. What about the hemiparesis?
No, sir. Only patient presented with only headache and nausea. There was no.
Is there any pyramidal signs or not?
No neurological symptom.
No neurological deficit. But anyway, I would like to have a functional MRI to know exactly where the motor area is. Once I know that it is quite far off from the motor area, I will resect it completely along with a little bit of edematous brain, so that there is no need of any further treatment.
Okay. So we move on to our next question. So this is for our radiation oncologist only. Which radiation modality do you prefer in such cases? So obviously we have this patient has undergone surgery. What is the next treatment, Dr. Tejpal?
Yeah, so cavity SRS would be the most sort of logical and appropriate treatment for this patient, provided the patient and the family understands the risk of distant brain relapse by avoiding WBRT. The risk of distant brain relapse at 1 year is approximately 50%. It seems to be a slightly largish tumor, so I don't think a single fraction cavity radiosurgery would work. So we would probably need a 3 fraction cavity radiosurgery.
Okay,
we would offer that as the first choice and explain the risk of distant brain failure by reserving whole brain radiation therapy for future.
So in your practice, routine practice, how many patients are willing for only radiosurgery, knowing that they can have intracranial metastasis within 1 year?
So I think that is a difficult question to answer, but I think by and large, most people, I would say around 70% patients are amenable to just the radiosurgical treatment, with the understanding that by deferring whole brain radiation therapy, there is a risk of nearly 50% chance of distant brain failure at 1 year. They all also realize that it doesn't change the overall survival. So when you give the whole brain radiation therapy at relapse, you achieve the same overall survival. So I would say 2/3 to 70% of the people are amenable to just the focal radiosurgical treatment.
Dr. Vimoj Nair.
Yes, so I completely agree with, depending on the surgical cavity, the first question is what is the performance status after the surgery? Like, is this patient going to come out with good neurological function? And if that's the case, then yes, a cavity radiation surgery would be the best. We do 3 to 5 fraction, but the caveat being one, half of these patients do have failures in the next 2 years. So you may need frequent imaging you could have leptomeningeal, the nodular recurrences, leptomeningeal seedings that could happen, and that would need more imaging. And if you have a patient that can have those follow-up, yeah, it makes sense to do cavity radiosurgery. On the other hand, if you feel that for many other reasons, this patient is not going to live long enough to see the benefits of cognition sparing, then whole brain is appropriate. But 9 out of 10 patients will say, nope, just do even if they are a poor ECOG, will say, just give me cavity radiation, at least in my practice.
Okay. So Dr. Anureet?
Actually, I think we also have to take the cost of the treatment into account, because most of our patients, because we work in a government sector, so most of the patients, they simply cannot afford these high-end techniques, and they come from far off to seek a one-time treatment. They are lost to follow up after that treatment. So in our practice, these patients, I would think, would do better with the whole brain, of course, accepting the decrease in the neurocognitive function. But if you have to strike a balance between the treatment which we can give as a one-time shot to these patients, I think we need to talk to them and explain that this is it. And most of the times the patient are okay and they want to accept it because they don't have the means to come again to the hospital to us.
Dr. Tejpal, I want to ask one question. Are we still doing whole brain RT or not?
Of course.
The patient is affording.
Of course, we are doing whole brain radiation therapy, and I think case selection becomes very, very important when you have to consider whole brain versus focal treatments. And if you select your cases well, I think in India at this point in time, every single patient with brain metastasis is definitely not a candidate for radiosurgical treatment. So a whole lot of patients do need whole brain radiation therapy, and they are very well palliated with the whole brain radiation therapy.
Dr. Anshuma, Dr. Rakesh Jalali wants to make a point.
Just one thing. I mean, I was very good discussion, and I endorse, in our country we have to be pragmatic, and I mean hippocampal sparing whole brain RT is great, and that can make a big difference. But I wanted to ask Tejpal and Vimoj also. I don't know how it's in Canada, because in breast cancer, especially TNBCs and HER2 positive, there is this increased risk of leptomeningeal, especially with short DFI. People are looking at pre-operative SRS, because then the cavity, you don't have to treat this. Whosoever has treated, I have done few cavity SRS. It's a nightmare to contour and where to do, because you have to set the track and you have the TNBC. May not be perhaps in some other like a renal cell, but in breast and lung, there has been a leptomeningeal spread. So what about the pre-operative SRS?
Yeah, so I think the preoperative SRS is catching up in the United States, and currently there is an ongoing phase 2/phase 3 study looking at preoperative SRS. I think one of the difficulties in the Indian context would be when you do the SRS, so within a couple of days, the patient needs to be taken up for the surgery. So that might be a bit of a challenge, particularly in academic government setting. But that is something that is clearly catching up and does reduce significantly the incidence of leptomeningeal dissemination.
No, I agree. It is exciting, and the challenge is to that correlation. At least in our setting, the surgeons don't get, or at least neurosurgeons don't get OR time immediately after the RADS. So it's easy to get to operate a patient in an emergency setting, but elective surgeries are challenging. So yeah, but I think if there is evidence, we would adopt that at this time.
Some of the people do the radiosurgery on a Thursday and Friday and operate them on the weekend. As an emergency, they go to the ER with the edema.
Okay, so we move on to our next question.
I did have a comment there. So just in that context, is there's also papers on using more of a conventional partial brain fractionation in the cavity. There's work done in again, single center, single institution work done when you don't have access to SRS. It's finding that middle ground, not whole brain. We don't have a stereotactic. What about a conventional fractionation or even 3D CRT? But again, those are fractionated, and that can be considered in a low resource setting. Thanks.
Okay, sir. Our next question is, since we know that this patient is having the lesion is abutting the meninges and there is extensive perilesional edema, while contouring the CTV, what modification do we do for meninges and for perilesional edema? Dr. Vimoj.
So we do rely on the consensus guidelines. As the CEC3 the trial showed, the local failure rates were actually higher with stereotactic treatments compared to the whole brain. And one argument they had is basically the contouring. Everybody's just contouring a tight cavity, and we don't understand the implications. So yes, being a bit paranoid, I use the word paranoid because depending on the surgeons, I find some surgeons, there are centers which publish that, oh, they didn't have any leptomeningeal disease by just contouring the cavity. So I would, just like the consensus guidelines, go up to 5 millimeter into that bone flap or beyond the bone flap if it's abutting. In this case, it was abutting the dura. But not going in too much into the edema unless it's enhancing. I don't go deep. And our PTV margins using a CyberKnife system would be 1 millimeter, and we have a Linac-based SRT as well, which is a 2 millimeter, and also a Tomo-based SRT. So we do have 3 platforms where our margins are 1 to 2 millimeter. Now with some of the cystic tumors and some surgeons, I do go more, depending on whether there's a bone flap or not, I do go more on the surface. I've had cases where there is a scalp seeding, especially with cystic tumors, and I do talk to the surgeon, like were there any events during the surgery, and I have done like a pseudo CTV giving at least 25 gray when I'm giving a 30 and 5. So our favorite prescription for the largest cavities are 30 and 5, whereas for smaller ones like 24 and 3. But after we add all these CTV margins, it ends up being big, irregular.
Dr. Tejpal, so you want to add something?
No, so we don't chase the edema, but we also follow the consensus guidelines, although I have some reservations about sort of treating the entire tract. And but when it is abutting the dura, certainly 5 millimeter of the meninges we do take. We use a dedicated stereotactic mask, so a BrainLab or a Sibco mask system. So we use 2 millimeter margins, and typically for cavities which are more than 10 to 15 cc, we give 9 gray times 3, 27 in 3, and those that are more than 50 cc, we give 32.5 in 5, so 6.5 gray times 5.
Okay. So we have already discussed about dose fractionation. Do you want to add something about this, sir?
So I think the Canadian group has the largest, Dr. Sehgal's group has published their experience. They use for cavity radiosurgery 30 grain 5 fraction, 6 gray times 5, and excellent outcomes, more than 80-85% local control of the cavity and less than 10% risk of radiation necrosis. So that is something that can be easily adopted by new centers.
Okay. Dr. Vimoj, what dose fractionation are you following for cavity SRS?
Exactly like the 30 gray in 5 fractions. We find that it's well tolerated. You can be a bit generous with your doses. Usually, structures like chiasm, brainstem, you sort of want to, keep that Dmax or hotspots away from it. So it's easy to plan from that perspective, easy to remember for the trainees. So that is sort of the dose fractionation that we like for the cavity. But if you look at the hyperfractionation, keeping the number of visits to a minimum is always one of the benefits when we look at the cost-effective analysis. So we try to do the 3 fractions whenever we can, so that the taxpayer, which funds the treatments here, would not have to foot extra 2 fractions. So, but 30 and 5 seems to be the standard option for us altogether.
Dr. Anurit, you want to add?
No, I think fractionations have been discussed.
So hypofractionate SRS is the best thing which we are trying after post-op, after surgery.
Dr. Anshuma, I would please request you to wrap up because we're running late.
Fine. So in your routine practice, what radiation toxicities are you seeing? Dr. Tejpal.
So following cavity radiosurgery, we've had our share of radiation necrosis. Most of them have been picked up on the routine surveillance MRI scans that we do every 3 to 4 months when we defer the whole brain radiation therapy. Most of the time they have settled down with steroids, and on an occasional basis we've had to use bevacizumab, but not very frequently. And only less than I think we haven't done probably in the 60 to 70 odd cavity radiosurgeries that we've done, I think we've had only 1 leptomeningeal dissemination So that has been somewhat less in my personal experience.
Dr. Vimoj, sir, which best imaging modality are you following for routinely checking upon radiation necrosis or the side effects?
So, I mean, routinely in an otherwise asymptomatic patient, we use our regular standard scanning MRIs with contrast wideband. We do have spectral diffusion by default in these settings, as our radiology would do. We do have a PET post-radiation as a clinical trial, which looks at post-radiation changes versus relapse. Again, it's an experimental PET MRI. Now, yes, we do find these changes. Most of the time, it's not, at least in my practice, not symptomatic in the resected setting. So you do see these post-treatment changes, which would evolve. And we do use the spectral perfusion, and we do discuss in tumor board as well. And if it's over, within the radiation field, like we don't seldom bother about it. The one thing that always we worry about is, again, it might be a surgeon-specific thing, which many centers say they don't have leptomeningeal disease. For us, we do see some surgeons, we do get some leptomeningeal disease, or these drop metastases where the tumor high up in the parietal is resected and you get these nodular leptomeningeal. So there's these two types of leptomeningeal disease, the sugar coating as it's called versus the nodular. You see those nodular ones, and the data recently shows that you can be aggressive. The nodular ones do respond more, so you should scan them more. So yeah, the nodular ones, I try to scan them more to get these nodular type of leptomeningeal disease so that I can still give local treatments for them. Whereas for the sugar coating type, which is more diffuse, patients may need more whole brain kind of salvage.
Okay, so one quick question from all the radiation oncologists. In all the patients whom you are planning with whole brain RT, how to avoid neurocognitive effects? Are you decreasing the doses, or you are using memantine routinely, or hippocampal avoidance whole brain RT? So in routine practice.
So we at TMH are using quite a bit of hippocampal avoidance. We don't, I have no personal experience of memantine, but hippocampal avoidance is something that we routinely offer to patients if they can afford that on a tomotherapy or a LINAC platform.
Okay, sir. Sir, this is the last question to
Dr. Jalali wants to add something.
No, I just wanted to say we also use quite a bit of hippocampal, and in the Proton Cancer Center, Dr. Srinivas, my colleague, uses memantine a lot. And our breast oncologist also favor memantine, Dr. Sirohi. So we have a reasonable experience.
Okay, sir.
Dr. Anshuma, can you please wrap up?
Fine. Dr. Sumit, last question. What systemic therapy would you offer to this patient?
This patient is triple negative. It is highly debatable whether to offer or not. There is no prospective data to show that there is benefit to offer systemic treatment to this patient. But if the patient is already on treatment, we would like to continue the same treatment.
Okay. So sorry. I
think we'll have to skip on case 2, Dr. Anshuma, because
it's just a short case. We'll have only 3 to 4.
We are already running. I'm really sorry. I personally want to attend it, but we're running 30 minutes late. We have an international faculty.
Dr. Aditi, maybe we could take the case later on after the next session, because we have about 20 faculty who are getting delayed.
Fine. Thank you. Thank you all the panelists.
Thank you, Dr. Anshuma. I would just request Dr. Mehta and Dr. Batish to please conclude the session so that we can proceed to the next session.
Come when you give me speech, beta.
So are you there? So can we please have an expert comment and conclude the session so that we go on to the next session, which is pediatric oncology.
Can I have Dr. Mehta, please? Is he on?
I don't think sir's here at present.
So he's not there. Well, we've had a wonderful panel discussion. I knew it would go on and on and on, and we had to miss one case because there's a huge queue right there. And it was very illuminating, the complete talk, all the talks by all the speakers. The topics were difficult to manage, difficult to handle. And as neurosurgeons, we say that they come to us repeatedly, and quite a few times you don't know the answers. And the details of chemotherapy and radiation, they're improving every day, and it's wonderful. I suppose the answer lies somewhere there. I thank all the speakers, all the panelists very much for the wonderful illuminating talk. Thank you very much, all of you. Thank you very much.
Thank you.
Thank you, sir. And I would now like to hand over the further proceedings to Dr. Neha Singh, who would take it over for the pediatric oncology session.
Thank you so much, Dr. Aditi. I apologize for the delay. Let's not waste any time further. I'll just introduce, we are starting off with the next session, pediatric oncology, and I would like to introduce the chairpersons. We have with us Dr. S.P. Yadav. Sir is a director of pediatric hemato-oncology and bone marrow transplant center at Medanta, the Medicity Hospital, Gurgaon, and Dr. Vikas Dua, who is the additional director and head pediatric hemato-oncology and BMT FMRI Gurgaon. We will start with the first talk. The speaker is Dr. Neha Rastogi. The talk is on cellular therapies in pediatric ALL. What's new? I would request the chairpersons to kindly introduce this.
Thank you very much, Dr. Neha, for the kind introduction. And without wasting much time, let's move on to the first talk of the pediatric oncology session. So we have with us Dr. Neha Rastogi. Dr. Neha Rastogi is a senior consultant in the Department of Pediatric Hematology, Oncology, and Bone Marrow Transplant at Medanta, the Medicity. And she's going to talk on a very interesting topic, which is cellular therapies in pediatric acute lymphoblastic leukemia. So over to you, Neha.
Thank you so much, sir. And let me share my screen. Sorry. Sorry, it's getting. Yeah. So very good afternoon to everyone. So today the topic which I have been allotted is cellular therapies in pediatric acute lymphoblastic leukemia. What's new? So cellular therapy is the transplantation of human cells to replace or repair the damaged tissues or the cells. So it can be patient's own cells or it can be somebody else's cells. So we all know that we are doing the transplants for ages. We are using DLI, which is the donor lymphocyte infusion. They are the old kind of cellular therapies. Now the new ones are CAR T cells and NK cell therapy. So what is the CAR T cell therapy? It is a very in thing today. And CAR T cell means the chimeric antigen receptor T cells. So who is she? We all know. She is Emily Whitehead. She's a ray of hope for millions of patients, caregivers, and medical professionals. She was the first patient who received the CAR T cells. And as she yearly releases her photo on internet, this was the photograph of her last year when she has completed 8 years cancer-free. So what are CARs? So CAR are the artificial antigen receptors which are engineered to fuse an antibody binding domain to a tumor-specific antigen to a T-cell-derived signaling domain. Okay, so they are the T cells in which we bind a antibody domain. Why we need to do so? Because the T cells have their own problems. We all have T cells. If somebody has got leukemia, he also got T cells. So why not his own T cells are killing his leukemia? Because they are lacking in two things. First, they are MHC restricted. Second, they have the T cell exhaustion. So to overcome that problem, we introduce an antibody binding domain to that, so that now the T cell can give the tumor specific cytotoxicity without being MHC restricted and without being T cell exhaustion. So the design of CAR permits MHC independent antigen binding by the inclusion of an antibody derived binding domain. So this is a CAR T cell therapy in which we collect the autologous T cells from the patient, and then with the help of a lentivirus, we insert a CAR gene, and then we expand the CAR T cells outside in the lab, and then we again inject into the patient. So what are the types of the CAR T cells? So they are the first generation, second generation, third generation, and now fourth generation also. So the first generation, as you can see, has only CD3 zeta domain, which is present normally in the T cell receptors. So, but these first generation CAR T cells were good. They were able to kill the leukemia, but they were not able to proliferate they proliferate very poorly. So we come up with the second generations. So second generations have this co-stimulatory molecule, either CD28 or 41BB. So what was the use of this co-stimulation? This co-stimulation helped to augment the T cell cytokine production and proliferation. What was the third generation? Third generation CAR T cells have all the two co-stimulatory molecule along with CD3 zeta. Now we are coming up with the fourth generation, which is still in the phase of research, in which we are introducing the cytokine transgene or co-stimulatory ligand transgenes. What they help is that the addition of these genes enable the expression of cytokines. So, relapse and refractory B-cell acute lymphoblastic leukemia is accompanied by a dismal prognosis. The development of the CAR T-cell therapy has introduced a new therapeutic option, and the only CAR T-cell which has been approved for the pediatric use is tisagenlecel, which is Chimera. And it was being evaluated in the ELENA trial, which we will talk about later on. So what are the FDA-approved CAR T therapies? There are two. One is the Chimera and other one is Yescarta. So this Chimera, there were two trials. One was ELENA trial, which was done in pediatrics. It was done in the B-cell ALL. And other trial was done, which is the Juliet trial, which was done in lymphomas in adult. And after that, it was approved. And for the hexacarbatine, which is Yescarta, it was only evaluated through a trial, JUMA-1 trial, which was done in adults with lymphomas only. So it is not being approved for the pediatrics right now. So none of these are available at present in India. We are still hoping to get either of them, or the Tata Memorial Hospital, Mumbai, is also preparing their own novel CAR T therapy. So now coming on to the new strategies. Since we see that after expansion of these CAR T cells in the patient, they later on lose these CAR T cells. So we are coming up with the new strategies that we do something so that they can live longer inside the patient's body. So the novel strategy is to promote in vivo CAR expansion, uses T cell engineered to express the CD19 antigen presenting cell as booster cells post initial CAR infusion. So now coming on to the CAR mediated toxicity. So these CAR T cell infusions are associated with few toxicities. First of all is the cytokine release syndrome. So most of the doctors who are doing the haploidentical transplants or dealing with the pediatric hemato-oncology are well versed with the cytokine release syndrome, which we see with other cellular therapies. So similar one is what we saw in T cells. So it is characterized by fever, but it can be associated with constitutional symptoms and hypotensions, and sometimes a patient needs vasopressors, and sometimes it can be intubated also. The IL-6 levels are high, so tocilizumab is usually used to treat these syndromes. Next is the immune effector cell-associated neurotoxicity syndromes, ICANS, and the third is related hypogammaglobulinemia. So in the ELENA trial, it was found that about 6 months post CAR T cell therapy, 83% of the patients have hypogammaglobulinemia and needed the IVIG infusions. So what is the role of consolidative transplant following the CAR therapy? Pediatric data shows that following use of the short-lived C19 CARs harboring the CD28 co-stimulatory domain, if you do a transplant also to consolidate, then there is a decreased relapse risk. So this was a paper from Blood 2016 which showed the same. Now coming on to the ELENA trial. So it was published in 2018 in New Journal NEJM. So it was a single cohort phase 2 multicentral global study of tisagenlecel in children and young adults with relapsed or refractory B-cell ALL. It was generated ex vivo with the use of autologous T cells of the patient, which were induced or transduced with the lentiviral vector to express a CAR containing the CD3 zeta domain to provide a T cell activation signal and a 4-1BB domain to provide a co-stimulatory signal. What was the eligibility criteria? To be eligible for participation in the study, patients had to be at least 3 years of age at screening and no older than 21 years of age at diagnosis, and have to at least 5% lymphoblast in bone marrow at screening. Patients who had previously received anti-CD19 therapy were excluded. So what were the results? So they have included 75 patients, and the overall remission rate at 3 months were 81%. Event-free for survival at 6 months was 73, and overall survival at 6 months was 90%. And if you see at 12 months, that event-free survival was 50% and overall survival was 76%. And regarding the side effects, tocilizumab was given in 48% of the patients because cytokine release syndrome was seen in 77% of the patients. Neurologic events occurred in 40% of the patients. So what was the conclusion of this trial? In this global study of CAR T-cell therapy, a single infusion of the Tisagen Lulucel provided durable remission with long-term persistence in pediatric and young adult patients with relapse or refractory B-cell ALL with transient high-grade toxic effects. Now coming on to the next, that what are the alternative target antigens in the B-cell malignancy? So most of the trials is being going on CD19. The approved therapy is also the CAR T cells against CD19 because it is a very stable molecule, but there are other alternative targets also. So why CD19 is the ideal target? Because it is expressed uniformly in high site density on B-cell malignancy and is not shed as soluble molecule. So the effect of the treatment can come for a longer duration. But targeting a single antigen in cancer has the side effect of potential for antigen loss variants to emerge. So alternative molecules which were used was surface immunoglobulin light chain, CD20 and CD22.
I'm sorry, Neha, to interrupt, but your time is up. Try to wind off in 2 minutes.
Okay. So this was a trial which showed the CD22 CAR T cells induced remissions in CD19 CAR naive and resistant B-cell ALL. Okay. So what are the limitations of CAR T cell therapy? That it cannot be used in all patients because many patients have significant T-cell lymphopenia and many patients have rapidly progressive disease. So we cannot wait for a long time for these autologous T-cells with the CAR T gene induction. Second, there is side effects like CRS and ICANS, and there is sometimes target antigen loss also. And also, we cannot use the third-party CAR T cells because the risk of associated GVHD is very high. So what are the alternative? NK cells is a useful alternative because they don't need a prior antigen priming. They are not restricted by the MHC molecule, and they can distinguish. Very important is they can distinguish between the normal and the stress cells because the normal cells express self MHC class 1 molecule and they show the no kill signal. Also, NK cells do not cause GVHD, so that make a safe choice for third party option, off-shelf cellular therapy option. Also, the allogenic NK cells are less prone to rejection by the recipient alloreactive T cells. But this NK cell therapy also has its own limitations, which is the short lifespan and limited cell numbers, often requiring ex vivo expansion activation, and the susceptibility to immunosuppressive tumor microenvironment that could in turn limit their trafficking and effector function. These are the other molecules which are being investigated for the CAR therapies. Now I am coming to the last point, which is the CRISPR-Cas9 gene editing. So the CRISPR-mediated gene editing as the next frontier for the cell therapies. The discovery of CRISPR revolutionized the field of gene editing because of its simplicity, efficiency, reproducibility, and low cost. The CRISPR-Cas9 technology used in the laboratory for gene editing relies on two key elements, the Cas9 enzyme, which acts as a pair of molecular scissors to cut the DNA at a specific locus, and a piece of RNA called guide RNA. The guide RNA can therefore guide the Cas9 enzyme to the desired target sequence for gene editing. But the disadvantage is that you can have a non-specific and unintended genetic modifications to the CRISPR gene editing. So at this point of time, CRISPR-mediated gene editing for CAR T-cell therapy is in the investigational phase only. So thank you so much for riding this star journey with me. Thank you so much.
Thank you very much, Neha, for this fantastic talk. And I don't know whether we have any questions in the chat box or not. Oh, there are no questions. So Neha, if I can ask you, there are a lot of people who are listening to you. They want to know what you talked about is BMW. So when can we expect our own Tata car in this country?
I really don't know, but I think in next year or two, we might get it. They have recently published in 2021, they have recently published their data in molecular genetics, and I think they are using the second generation of CAR T cells. I think in a year or two, we might get.
Thank you very much. I think your cellular therapy might give a ray of hope to a lot of people who have relapsed refractory leukemias and who are not who would not be benefited with just chemotherapy or transplant. Thank you very much, Neha.
Thank you, sir. Thank you.
Sir, can we move on to the next talk, sir?
Yeah, over to you, Yadav, sir.
Right. Yes, sir.
It's a pleasure to introduce the next speaker, Dr. Anupam Sachdeva, who would speak on HLH in children, a difficult topic, but sir has been a mentor to so many and a great teacher. So over to Dr. Anupam Sachdeva. Thank you.
Okay, thank you very much, Satya. Pleasure being there for the Paras conclave. And, you know, it's a matter of pride that for Gangaram as well as for me, that, you know, almost everybody who's been up in the pediatric oncology group at the moment is, you know, from Gangaram itself. So it's really good to have that sort of a feeling. Okay, what we are going to do is that we are going to talk about our series of 118 patients of HLH, which we have already sent for publication to a journal. Now, hemophagocytic lymphohistiocytosis is an aggressively and frequently fatal hyperinflammatory syndrome. Early diagnosis and aggressive management are crucial for preventing mortality. Now, needless to say that I'm going to present the data of nearly 10 years, and we have learned every day how to improve the things. And now we have reached that stage where our results are much better than what they were 10 years back. So HLH is basically comprising of primary and secondary forms, and primary form includes familial HLH and immune deficiency associated HLH. Secondary HLH is often associated with infections, malignancy, or rheumatological disorder. And it's not that HLH comes under the realm of pediatric oncology and hematology alone, but rheumatologists see it in the form of a macrophage activation syndrome. The intensivists see it all the time, and we are called in by the intensivists to take care of these patients. And you know, if Satya and anybody would remember, there was always a tussle between us and the intensivist whether to give chemotherapy in these patients or not, because they were, if I may be allowed to use the word, shit scared of adding etoposide, etc. So we'll just try to unravel that also. So what is HLH? Basically, it is unbridled, release of cytokines with at the approach of a stimulus, and that leads to activated tissue macrophages, leading to hemophagocytosis, and so on and so forth. There is a diagnostic criteria for HLH, which is the 2004 criteria. Either you can have a molecular diagnosis, or you have to have 5 criteria out of the 8 listed here. And I won't go into the details of it, but lately people have also started using H score, in which you may not have all the 5 criteria satisfied, but if some criteria is exorbitantly high, then we can probably treat it as HLH. That's the basic basis behind the H score. Now, the diagnosis of HLH has increased in the last few years. I'm not, we used to see MODs and SIRS long time back, and I remember that in our residency, these patients would come with, transaminitis, with bilirubin high, coagulopathy, seizures, and that used to be the end of the story because we could never save these patients. So these patients now we usually classify them as HLH. Previously, many cases were misdiagnosed because of its non-specific symptoms and overlapping features with a systemic inflammatory response syndrome, MODS, and sepsis. In India, there is a paucity of data and less awareness in pediatric HLH. Hence, this study was conducted. Now, there are studies from Chennai, Dr. Ramachandran's study, which define about 125 patients of HLH. Also, recently in the Journal of Critical Care, there was a study from one of the critical care units with about 75, 80 patients of HLH. Now, this our study describes the epidemiological features, outcomes, and prognostic factors at diagnosis associated with mortality of pediatric HLH. So it is a retrospective analysis which was conducted in children aged 0 to 16 years diagnosed with HLH between Jan 2010 and December 2019 in the Department of Pediatrics, Sir Gangaram Hospital. Now, remember that we are actually storing all the data prospectively. So we delved into that prospectively stored data and pulled out all the patients. 118 patients were included in the study, and the median age at diagnosis was 4 years. We had patients as young as 13 days and as old as 15 years, because 16 was the cutoff which we used, and 66% were males. The infections were a major chunk, with 50% of the patients suffering from infections. Familial HLH was another good bit, which included about 24 patients, 24% of the patients, and 18% had rheumatological diseases, and about 8% were malignancy associated HLH. The majority of patients presented with fever, hepatosplenomegaly, and lymphadenopathy. Very few patients, somewhere around 23, presented with CNS symptoms and bleeding, etc. When we look at the lab investigations, we focus on the tall TARS, the hyperferritinemia, patients with increased LDH and pancytopenia, etc. Bicytopenia were the major problems. There was a group in which we had increased soluble interleukin-2 receptor also. 78 patients had that. So 89 out of 118 patients fulfilled the HLH 2004 criteria, and rest were treated on the basis of clinical pathological suspicion and on the basis of the H scoring, which we did for these patients. Median follow-up duration was about 13.5 months, 3 days to 102 months was the range. And on treatment given was that 20 patients received only treatment for the trigger. Then another 42 chemotherapy, and 9 received HSCT. Now this 9 has moved on to almost 14, 14 now in our hospital. The overall mortality was 38%, and among them 23% of the mortality was within the first 30 days. Cause of death was sepsis in 58%, refractory disease in 25%, and other causes in the rest of the patients. Now, the mortality in the steroid-only group was 26, in the trigger-only group was 31, chemotherapy was 34, and HSCT was just about 9% in these patients. As far as prognostic factors is concerned, presence of coagulopathy, presence of hyponatremia, presence of hyperbilirubinemia, and increased serum interleukin-2 receptor were the 4 things which mattered as far as prognosis is concerned. I'll come to in detail about serum ferritin also. Now, in this slide, you can see that the higher the ferritin, the more are the chances that you will not make it. With patients who had more than 1 lakh ferritin, out of 3 patients, 2 didn't make it. And for those who had less than 1,000 ferritin, 15 patients were there, out of them 3 made it. So, higher ferritins are usually associated with the high mortality also. Overall survival and event-free survival, if you look at the survival graphs, the Kaplan-Meier curve, the overall survival was, it was around 60% or so, 60-65%. Now, there was a case report of dengue in Malaysian children, and we found that in our patients also, the issue of dengue was very high in some of our patients. The total number of patients which we are seeing were 2 in China, 2 studies from China, 1 from Chennai, and our study had 118 patients. The median age at diagnosis was 4 years. Infection was the most common cause of HLH, which was consistent with studies done by Ramachandran and Oguz et al. Hyperferritinemia, increased LDH, bicytopenia, and increased IL-2 receptor were present in most of the patients. If you look at the ferritin levels, the median ferritin was in our study was 6,504 compared to 3,171 and 1,261 in the other studies. The range in our patients was 44 to 2,97,000 in one of the patients. The prognostic factors for mortality in our study was hyponatremia, hyperbilirubinemia, coagulopathy, and increased soluble interleukin-2 receptor. The Ramachandran study did not show any significant risk factor for mortality, whereas the study from China showed that, I think it's the study from Turkey, not from China, which showed hypoalbuminemia and etoposide usage as one of the causes.
Sir, try to wind it up because
we are
thank you.
Mortality was in fact higher in the non-HSCT group as compared to the HSCT group. And the present study, the overall mortality was 38%, and in early mortality was nearly 62% in some of them. So early diagnosis and appropriate treatment are necessary for better outcome. Poor prognostic markers at time of diagnosis are hyponatremia, hyperbilirubinemia, coagulopathy, and increased SIL2R. Early identification of these markers and prompt initiation of treatment are crucial to decrease mortality. In fact, it has been said that if you do give etoposide infusion early, it improves the prognosis in majority of the cases. So thank you very much. I just wanted to present the data so that we come to know what is the Indian perspective as HLH is concerned. We have now done about 14 HSCTs, And the last 5 have been successfully done, been successful, including one with, haploidentical transplant in a 14, 15 years old child done from the mother. Thank you.
Thank you, sir. So over to Vikas to introduce the next speaker.
All right. Thank you very much, Anupam sir, for a fantastic talk and a wonderful paper which you shared. And for the next panel discussion, let me introduce the moderator for the panel discussion. So we have Dr. Datta. Dr. Datta is the head of the Department of Radiation Oncology at Amrita Institute, Kochi. And over to you, Dr. Datta.
Yeah, good afternoon. I'm sorry, I think it is late, and I will try to. Can you allow me to share the screen, please? Yeah. Good afternoon. I think you can see my screen. Yeah. Achha. I welcome our panelist, neurosurgeon Dr. V.S. Mehta, her Simrat Singh Beed, and our pediatric oncologist Sujata Musharraf, Dr. Tejpal Gupta. Tejpal Gupta is there?
Yes, I'm there. I'm there, Devran.
Yeah. And you need to help me. And Dr. Srinivas Chilikud is there he's in Proton Man. And Dr. Aniruddha Chattoraj, he is a pathologist. He is going to help us in lot of ways. Dr. Sunil Sangha is a radiologist, and Dr. Mansi is a pediatrician.
Just a small correction, Dr. Datta. Dr. Mansi Sajdev is a pediatric oncologist in Fortis Memorial Research Institute, Gurgaon.
I'm sorry, Dr. Mansi is a pediatric oncologist. Yeah. Now, see, if we in last, what is new means what has happened in last 1 decade in low-grade glioma, pediatric low-grade gliomas. Now, there is a newer classification for pathology. There's some molecular prognostication that has happened. That high precision radiotherapy has shown superiority over conventional fractionations, and Dr. Jalali's paper is there in that. There are targeted therapy that has come in, and the surgery has become more. Now, I will start with the surgeons. What has changed in last 1 decade in pediatric oncology surgeries?
No,
Dr. Mehta?
Yes. The surgery, there are a lot of advancement have happened. See, in an image-guided surgery, MRI, tractography, and functional MRI. So all those and the surgical techniques, the image guidance, all those things have improved surgical results. And even microscopes have improved. Endoscopes have improved.
So what has happened with that? Toxicity has reduced, or total duration of stay, or better complete resection? Which one?
That you can, predict the surgical outcome.
Okay, so
that's the most important.
The prediction about the surgical outcome has improved with better technologies and more advancement in the machines which we use during the surgery. Dr. Harshimzra, do you agree with that, or you want to add something on it? Dr. Shodhi, you are there? Yeah. Achha. Dr. Mansi, you want to add something that if the surgery has changed your approach when a patient comes to you, that you can, as it can be predicted, and if as per the prediction the surgery does not happen, and if there's a residual disease, you think there is something, it is more adherent, or biology is more different? Dr. Mansi is there?
So yeah, hi Dr. Atta, I'm here.
Yeah.
So we all know that low-grade gliomas in the pediatric age group is a heterogeneous group of cancers that we are seeing. And we are seeing a lot of heterogeneity in the patient population that we're seeing. So we cannot really, so as Dr. V.S. Mehta said, that now we can predict who's going to undergo a GTR or a STR. When we have a GTR, that's like the best thing for the surgeons, the neurosurgeons, and for the pediatric oncologists as well, because that's all they need. But the problem is when we don't have a GTR, or when we actually just can do a biopsy and nothing else. So really things have changed, and I'm sure that you're going to talk about that in the coming slides, but things have changed in the past 2 decades in the management of patients who have low-grade gliomas in the pediatric setting.
Now, in pathology, Dr. Anuruddha,
yes.
now what I understand that, see, this is a WHO classification for pediatric low-grade gliomas, right? And it is more classified. But do you think that in pediatric group, the morphological overlap is more? Means it is very difficult sometimes to see on a morphological basis have a diagnosis.
Exactly. That is the basic the difference with adult gliomas. The underlying genetic alterations are different, and the infrequency of transformation to high-grade gliomas is also different.
Yeah.
And as you all know, the upregulation of the RAS MAPK pathway is an almost universal feature, unlike adult this thing. Morphological overlap, what it creates a problem, like oligodendroglioma in. Sorry, can you hear me?
Yeah.
For example, there's a lot of histological overlap. Like oligodendroglioma-like components are seen in many of these pediatric low-grade gliomas, like say pediatric polymorphous low-grade neuroepithelial tumor of the young. Even in pilocytic astrocytoma, you can get a prominent oligodendro component at times. That diffuse glioneural tumor with oligodendroma-like features and nuclear this thing.
So
the similar. So this problem that arises that in adults, oligodendrogliomas, most of them show IDH mutation and one P19Q co-deletion.
Yeah.
Now that is very infrequent in childhood oligodendrogliomas. What you get is various mutations in the MAPK pathway.
Yeah.
So they behave in a much more benign pattern. Similarly, diffuse astrocytomas. In you have the idea in the adults, you have the IDH and ATRX and P53 have helped us to classify them in that last 2016 classification. That you have the diffuse astrocytomas, which are IDH mutant, and ATRX is not there is loss of ATRX.
Yeah.
Then you call it as a IDH mutant diffuse astrocytoma.
So that is different entity what we get. Acha, Dr. Tejpal, we are treating the pediatric low-grade gliomas for many years with morphology only, and we know that there is so much of morphological overlap. Now how you can interpret the data which is already there in the literature?
So I think now we're moving into the 2021 classification, actually, which is just due to come out, and the WHO 2021 classification. I think 2016 was a big step forward where the molecular genetic features were introduced. The 2021 takes it slightly further forward. In fact, they have now, for pediatric gliomas, there is a separate entity of circumscribed gliomas, which includes the pilocytic, the PXs, the gangliogliomas, which is essentially a RAS MAP kinase pathway disease. So I think as we move forward, morphology will take a backseat and molecular genetic testing will be at the forefront. I'm not saying that you just can ignore the morphology, but I think you have to supplement your morphology with molecular genetic testing and then decide on further therapy for children with low-grade gliomas.
So now we will not able to take a call without a proper morphological testing in pediatric gliomas. Now, what do you feel about this? That one pathway disease. That so now there is a concept that all the pediatric low-grade gliomas are one pathway disease. There's a MAP kinase disorders, and that ultimately gives rise to so many other different mutations. What do you feel on that? Is it practical? If you say one pathway disease, if you MAP kinase, if you block it, actually we have a cure, like imatinib in CML. So is it like that? Is it practically possible, Dr. Tejpal?
So 90% of circumscribed gliomas in children are RAS MAP kinase pathway disease, but that's a complex pathway, and there are several areas to target, and you target one pathway, and downstream to that you get some so the tumor cells find something else to proliferate. So I don't think one therapy targeting RAS-MAP kinase pathway is going to work, but essentially whatever published data is there, 90% of all pediatric low-grade gliomas do show some alteration in the RAS-MAP kinase pathway.
Now,
yeah, just to add to what Dr. Tejpal is saying is that there was a recent study by the COG when they had used sorafenib as an inhibitor for these patients, and they actually saw paradoxical increase in the size of the tumors in these patients. And that is what is, that's what highlights the importance of actually going in deep and finding out the exact mutation that you want to target, and just not blindly like we are saying, do just RAS-MAP kinase inhibitors in general.
So why it happened? See, now this sorafenib is an eye opener for us. So giving sorafenib is a targeted therapy, and it can actually be counterproductive, and that shows us that we need to have a proper mutation. Now, if you see, Dr. Sujata is there. Dr. Sujata.
Yes, yeah, I'm here.
Now you see in the molecular pathways there are so many. It is not one. In all have multiple, and if we see in pilocytic we have a fusion, and Sega there is different, PXA there is a mutation. So all has it beta. So all have a different proportion of percentage that these mutations or fusions are there. Now, with that we can have a protocol for the molecular testing. Is this practical in what are the informations what we have now in low-grade glioma? Dr. Sujata?
Yeah, so currently, I think as more and more inhibitors are available,
and it's very hemispherical and do the testing accordingly. Is it practically possible?
So it is practically possible wherever it is available. So like being in Mumbai, I can send it to Tata, so I can say it is practically possible. But the logistics may be a concern. But I think as much possible, it's a good idea to get this done whenever for the cost implications are not too much in terms of the long-term therapy that these tumors need. So with newer and newer agents coming up and all, I think it is practically possible to do it.
Dr. Anirudh,
I mean, unless we start thinking in that way, we won't do it.
We're not able to do it. Dr. Anirudh, do you do it? Do you after morphology? Do you send for this kind of these tests?
Actually, in our center, I'm from Onquest Laboratories. Right now, we are not doing many of these this thing. Though some of them we hope to introduce, like this thing. But right now, we are not carrying out most of these.
Now, this is such an interesting one. See, there are so much of overlap and so much of mutation variations. Like what I understood, that even in our pilocytic astros, that BRAF mutation, there is a mutation also. There is some variations which may not pick up in that. Valine may not be aspergillate, so that can happen. So that may not pick up sometimes, but that mutation is there. So how to tackle that? Because so much of variations are there. Is there still with a lot of ambiguity in diagnosis with molecular still pending?
But there
need to be solved.
So there is a majority of them have the fusion or the BRAF V600E. So at least targeting those two to do is a good idea. And the midline ones to do the histone H3K mutations.
But what
so that approach is at least.
Yeah, valine is not been in 600 position. Valine is aspargillate or some other molecule, and amino acid has been changed, which is not going to pick up the molecular test what you are doing, mutation, the SNPs doing. So how?
But your majority will be picked up with the fusion or the mutation. Majority would be picked up. Those would be the smaller number which are not picked up.
And these are the ones that we can actually target. I mean, even if we are missing the ones that are not targetable, but we still made the diagnosis, I think that is okay. But then the V600E, the KIA 1547 that Dr. Sujata is talking about, and then the H3K27, I mean, those are some of the things that we can actually target these.
Can I add? I think see these. I mean, you asked the question, very relevant question, whether how impactful these molecular testing should be done. Should they be done in every patient? Is a good question, because I mean, these targeted therapies are all very, very good, and we are very excited and very happy that these have emerged. But the fact remains, the definitive treatment, these need to be given for a very, very long time. And we know from the BRAF inhibitors that once we stop them, they actually progress quite rapidly. So they need to be given for a longer period of time. So the definitive treatment still stands, the surgery still stands. These targeted therapies are to postpone so that we don't subject very young patients to, say, radiation, or postpone or avoid certain treatments. But I don't think we need to do it in every child who comes. I mean, of course, they are very good in differentiating, understanding the biology of the tumor, in understanding, I mean, the common ones, which Dr. Musharraf mentioned, the V600E. Of course, there are other V600Es, and it can be tested by immunohistochemistry. So it doesn't need any specific, the mutation at least, not the fusion. So there are certain things which can be done very easily, and they should be done for every patient. And then there are certain things which should be reserved in situations where we are kind of desperate to avoid certain treatments and to postpone certain treatments, or in a very advanced setting where we are more desperate to give any response to the child.
Now, can I have bring one point I wanted to this thing? The hemispheric, this diffuse astrocytoma, grade 2 or grade 3 in children, as opposed to grade 2 diffuse astrocytoma in the hemisphere of a child, carries a different connotation to an IDH wild type diffuse astrocytoma in an adult. In an adult, a diffuse astrocytoma which is IDH wild type, it can be considered on a grade 2, can be considered to be a glioblastoma.
Okay.
It behaves as badly as a glioblastoma. In fact, they will be considered as a glioblastoma in the next classification if it has those that EGFR amplification or +7 -10 or third promoter mutations.
So it is not
exactly. Morphologically, they look the same, but an astrocytoma grade 2 IDH wild type in a child is very benign. Yeah. Whereas it has this thing. If it has these things, but there are various other MYB, MYBL1 and other FGFR mutations.
Yeah.
But IDH wild type in an adult carries a grave connotation.
The doctor. Yeah.
If I may add something, now what is considered standard of care for chemotherapy in terms of vincristine, carboplatin versus vinblastine. Yeah. Now, actually, the PSYOP Asia is going on, and there was a presentation from Europe, wherein European continent is doing a head-on trial between vincristine, carboplatin, vinblastine, and a MEK inhibitor like trametinib to see, to use as a first line. So these are definitely trying times. Once those get approval in the outer, in the developed countries, these are going to start trickling in here, because that would be a bigger market for the country like India with so many patients too. Until then, it is difficult. That's how I think about it.
COG phase 3 trials also on the same lines that they are opening. So hopefully that will give us an answer.
Now the phase 2 is there. Achha, now Dr. Tejpal, what do you think about this? Is it we are going like a medulloblastoma way in pediatric low-grade glioma as well? That in low risk, intermediate risk, high risk, depending on the location, pathology, molecule, and age.
So, I mean, pediatric low-grade glioma is extremely heterogeneous, much more heterogeneous than medulloblastoma, I can say that. Yeah. And whether or not we accept a risk stratification, I think there is very widely varying prognosis. The cerebellar pilocytic astrocytoma with BRAF fusion will behave very indolently, as opposed to a some other circumscribed glioma with BRAF V600E a mutation in the hemisphere. So definitely it's extremely heterogeneous, and I think not only the location is important, because that predicts how safely you can resect it. I mean, if it's in an eloquent location, an optic pathway glioma, or something close to the motor cortex, it's difficult to resect them. As the cerebellar pilocytic is easy to resect. So location is important because it sort of defines the extent of resection that is possible. But otherwise, I think molecular genetics trumps the histology, and grade really doesn't matter. Grade is not so important.
Yeah. Now, what do you feel that this is a PSYOP protocol for low-income countries like India? I think. See now, is it the practical protocol that here, if you see, the targeted therapies are not there. It is a surgery and resurgery, and in sometimes radiation and chemotherapy. So is it the practical protocol still we need to follow in Indian subcontinent?
So, Devnarayan, targeted therapies are not there in the guidelines, even in the Western world. They are being investigated. As Sujata said, the LOGIC trial in Europe and the COG trial in the US, in the first line setting, now they are comparing head-on chemotherapy versus targeted therapy, a combinatorial approach using BRAF and MEK inhibitors. So unless that data comes, that is not going to, I mean, they are not going to be there for the first line. Certainly in relapsed and the second line setting, increasingly in the West, people are using these drugs. But as Srinivas pointed out, the duration, the cost, once you stop, I mean, there are a whole lot of practical and logistic challenges, and it's not going to be so easy to adopt them in the Indian context.
But I still feel we should all continue, because the morbidity that is with low-grade gliomas with chemotherapy and all, for a year at a time, more than a year at a time, these are oral tablets. And you do see responses in at least a selected proper cohort of patients.
Sujata, I'm not trying to suggest that we should not pursue them. I mean, what I'm trying to say
No, I'm just seconding your this thing. Yeah, seconding, and it's good enough data to take them into a phase 3 trial in the well-developed world. So hopefully that comes like a...
Frankly speaking, I am not in great favor of these. I mean, of course, randomized trials need to be done. But I mean, how can you compare a drug which has nearly 80% response rates in most of the situations, compare that to chemotherapy where best responses are stable disease?
Yes.
Nevertheless, they need to be done, because we need to understand the context, and the morphology also will play a role.
Can be cured. Right?
But Srinivas, their endpoint is overall survival. They are not looking at progression.
I know. But as I said, responses cannot be ignored.
Yeah. So actually,
we are talking about Dr. Datta. I'm so sorry. Mansi, just hang on. Dr. Datta, sorry to interrupt. We just have 5 more minutes, and I can see that you have 20 more slides.
More than enough. Achha, now see, if you see the radiation, now what they are saying, the surgery is the first line, and the targeted therapies is the second line. This is a very interesting article has come this year, in 2021. Radiation is the second line after progression of molecular therapy. Do you agree with that, Dr. Tejpal or Srinivas?
I mean, we don't have access to these molecular targeted therapies. So for us, radiation has been the second line after failure of chemotherapy, and will continue to remain the second line.
Now, high precision radiation, you feel that all patients or low-grade glioma should be treated with high precision, or
no doubts on that. No doubts on that. I think there is now a level 1 evidence towards that. So children with low-grade glioma should be treated with high precision.
So we should have a hippocampal sparing, left temporal lobe sparing for all patients who are low-grade glioma treating with radiation.
Of course, not at the expense of tumor control. So it will depend on the site where you are treating, but every attempt should be made to try and restrict doses to these structures.
Now you see the outcome, as Srinivas was saying, the outcome is excellent, even if the gross total excision is done. So the molecule, there need to be a long-term follow-up data for the molecule targets to show that there's any survival benefit advantage. Now about the proton. Now, there is enough data to show that even if it may not be long-term data, but maybe intermediate or term data to show that proton do have some advantage over photon. Srinivas, what is your take?
I mean, definitely. I mean, high conformal radiation therapy techniques and proton therapy will always have a role. Always have a role in young
outcome.
The question is, well, the question is, in which patients we can avoid the radiation altogether, or in which patients we can postpone radiation. Those are the important questions to be asked. I think high conformal radiation therapy techniques such as proton therapies will always have a role, and it will always remain a major part of the treatment for these.
So, Dr. Tejpal, do you feel that at some point of time, maybe 5 years or 10 years down the line, photon will be replaced by proton in low-grade gliomas?
Certainly not in the next 5 years. Certainly not in India.
Yeah.
But of course, there will be a gradual shift to the proton world as more and more centers come up and becomes more affordable and accessible to a larger population.
Now, there is a...
if you give me a choice, I think children with low-grade gliomas should preferentially be treated on protons, but the healthcare systems don't always allow that. So
yeah, and cost, like Dr. Tejpal is saying, that is a big issue still.
Now, there's an interesting thing, Dr. Tejpal. Do you think that this kind of thing can be done? Like sometimes the spontaneous hemorrhage in low-grade glioma can be predicted by one kind of mutation. Many like these articles are there, so which can predict the toxicity, predict the outcome. Is it practically possible to use this kind of molecular informations in terms of assessing the response to treatment or toxicity, something like that?
So we do see post-treatment changes, including hemorrhage in pediatric low-grade gliomas, not so infrequently. Hemorrhage is not very frequent, but I'm personally not very sure or convinced that imaging or a molecular genetic abnormality can quite easily predict that. I'm not very sure about that.
As rightly said by Dr. Tejpal, these are, most of these are anecdotal, and we cannot take them really on a face value.
These are all anecdotal. Dr. Sunil, I'm sorry I kept you waiting for long. So now there's something called radionomics. When there we cannot do a biopsy proper, we cannot do. So there we have one article like that in brainstem glioma. So is it possible to have a radiological diagnosis which will give us a predictive or prognostic importance?
Yes, radionomics is a new relationship between imaging characteristics and genetic expression, gene mutation, that is genomics. So in some tumors like medulloblastoma, it has been seen that SHH type of medulloblastoma occurs in the lateral cerebellar hemisphere. So treatment can be directed. Ependymoma A and B also
can be
occur at different locations. So these locations at the lateral recess of fourth ventricle is A type ependymoma and B type is central. So in some tumors, this relationship has been proven.
Yeah. Now, Dr. This is a pilocytic astro-optic pathway gliomas. Now, do you know this patient need any kind of molecule before you start the treatment? Dr. Tejpal?
I mean, this is too huge. We would actually consider debulking surgery. It's just too big. I mean, what 3-year-old, half the brain is occupied by that tumor.
Yeah. So now this is again a pilocytic astro in a 3-year-old, treated with surgery, then a small residual, the chemotherapy was there, and then recurred, progressed on chemotherapy, and then radiation was given. Now, there is a residual. Do you think the targeted therapy is there in this patient, or is it?
Dr. Datta, sir, please try to wind off in 2 minutes. Time is up.
2 minutes. It will be in 2 minutes.
So Devnarayan, this is stable following radiation therapy. There is no role of giving any maintenance targeted treatment in such situation. Only when it starts to grow back again, you should consider for salvage therapy.
So it is only in progression there is a role of targeted therapy. Now this is a pilocytic astro of spine, IDH1 mutated. So, and you can see that there is a lesion in some other areas as well. So IDH mutation in pediatrics are different from adults, and that need to be defined in different way. Anyone, Srinivas or Dr. Tejpal?
I would be very hesitant to accept the diagnosis of IDH mutation in a pilocytic astrocyte.
Very unlikely.
Yeah. Okay. Now this is a ependymoma, small rect surgery done, radiation given and recurred, and then we did a CSI for a recurrence. So now in ependymoma, CSI is a standard in recurrent setting.
I think there are two schools of thought. The Princess Margaret, the Toronto group, Sick Kids and Princess Margaret, they do CSI for all infratentorial ependymomas at relapse. The St. Jude's uses a different sort of policy. So if the PFA type with 1Q gain, then they would do CSI. Otherwise, if it's a local recurrence only, they would do local radiotherapy. And that is our experience also. We are doing CSIs for either distant relapses or PFAs with 1Q gain.
Now, last thing is it is a midline glioma, midline tumor, and do you need to do a H3K27 for all these patients, and need to do a biopsy in brainstem glioma or midline tumors for all patients now, because we have potentially have a target for this histone mutation?
If it's in the thalamus, pons, or spinal cord in a child, you have to do this thing. H3K27 and IHC is available. And whatever the morphology, even if the morphology is low grade, it is taken as grade 4.
Yes.
It is a high grade glioma. It is not a low grade glioma.
In brainstem glioma, we never used to do a biopsy. But now with this H3K27 or potential target, do we need to do biopsy for all brainstem glioma patients?
Not all, but the...
Yeah, yes, Sujata, go on.
Dr. Sujata?
So not all brainstem gliomas. So say if you're thinking about a DIPG, which looks classically on radiological diagnosis as a DIPG, you may avoid doing it. But if you see a exophytic tumor, sorry,
but that also can have a potential target. Means in tomorrow also
it can have a potential target, but you need to have the surgeon who's willing to do, the parents who are willing to take that as a diagnosis, take that as a risk. And the availability of target, at least in India.
I think Sujata is right in there that you don't need to do a biopsy for a classic DIPG in a 6-year-old child, but the lesion that you are showing, this is amenable to a safe biopsy and should be considered. And Ramandeep had a question, how many low grades do you see histone mutation? So that's not so uncommon. Morphologically low grade diffuse midline gliomas, at least 25% of what I remember from our data, 25% were low grade on histology, but did show a histone mutation on.
I have recently reported 2 cases out of 6, which we got recently. 2 of them morphologically were very low grade.
I thank everyone for their excellent participation. And Dr. Mehta, Dr. Hasmeet, Sujata, Dr. Tejpal, Srinivas, Arundhati, Anuruddha, Dr. Sunil, and Mansi. Thank you. Over to the panelists, over to the chairperson.
Thank you, Dr. Datta, for fantastically moderating this panel discussion. I just have a question. So what is the group's experience with bevacizumab in low-grade gliomas? Any of you can answer.
Yeah, so we have used bevacizumab for optic pathway gliomas when there has been sudden deterioration in vision when they were on chemotherapy. Unfortunately, we haven't had a very gratifying experience. The other tumors where we are currently testing bevacizumab is in diffuse intrinsic pontine gliomas, where they have hyperperfusion on MRI. That's being done as part of a clinical trial. If there is hyperperfusion, we are adding bevacizumab to standard radiation therapy. But personally, I'm not a very big fan of bevacizumab in pediatric gliomas.
Thank you, Dr. Tejpal. Mansi, your views on that?
Yeah, I actually have one patient who is actually getting bevacizumab at this point, who is a pilocytic astrocytoma. Initially started on carbo and zinc, had some progression, also had a foot drop, so really couldn't give the vincristine or the vinblastine, so moved on to bevacizumab. So we're waiting for a repeat MRI and see what's going on, but neurologically and otherwise clinically, the patient is doing well.
Thank you very much, everyone. And I know, and everybody knows it very well, that surgery cannot replace anything. And hello. Thank you very much, all the panelists and the moderator. And we move on to the next talk. Over to you, Dr. Yadav.
Okay, thank you. So it's a pleasure to introduce the next speaker, Dr. Manas Kalra, who is a senior consultant at Gangaram Hospital. A topic proof outcomes of neuroblastoma. We have done a lot in leukemias, but it's time to make it better in neuroblastoma. So over to Dr. Manas. Thank you.
Good afternoon, everyone. I hope my screen is visible to all of you. I would like to thank the organizers for this opportunity and congratulate them for a well-conducted meeting. So, I've been given the difficult task today to talk about can we replicate the success in neuroblastoma in India? So the first thought process that comes to everybody's mind is, oh no, how are we going to do that? This is a very difficult disease. But I'll kind of share my thoughts when, I started writing them on a piece of paper and pen and just, kind of reflected on what all steps we take to manage these patients, and at each and every step, what interventions we can make to make a change for these patients. So, the hindrances in success are the late diagnosis, the pathways of referral, abandonment, financial issues, the extent of surgery, and the multidisciplinary team meetings that are essential, the autologous BMT availability and execution, radiotherapy, and yes, immunotherapy. So lack of monoclonal antibody is not the only reason why we are doing poorly in neuroblastoma, because that is the first thought that that comes to everybody's mind. Oh, we do not have CH14.18. How are we going to improve the success of neuroblastoma? But believe me, we have a bigger dragon to tame when we talk about managing children with cancer in our country. So the late diagnosis is the first point that I mentioned, and there have been plenty of studies which have highlighted that most of the neuroblastoma patients come to us very late. 2 studies from PGI and 1 from Adair Institute have all shown that majority of neuroblastomas presenting to them were in stage 4 disease, and a very small representation of patients coming in stage 1 or 2 disease. So clearly we are not diagnosing them early. Why is that so? This is a disease which has got a huge spectrum of presentation. Abdominal mass is just the commonest presentation, but believe me, that's not what we always see. Hypertension, chronic diarrhea, lump in the neck, Horner syndrome, bony swellings, severe bony pains like something like a Hutchinson syndrome, opsoclonus myoclonus, and paraparesis are other manifestations of this disease. This child with hypertensive crisis had a bony swelling on the scalp when carefully examined. The other one with these bony swellings was being evaluated and treated for tuberculosis. Raccoon eye is a manifestation of this disease and often ignored, and people do not realize that the patient already has orbital metastasis by the time the child presents in this way. Skin nodules. This child very recently presented to us with skin nodules and was getting treatment for all sorts of diseases for last 2 months before we could actually diagnose neuroblastoma. Some of these patients present to us in medical emergency, and if we do not identify and treat them appropriately, the outcomes of neuroblastoma are not going to improve in our country. The most important being paraparesis, obstructive uropathy, hypertension, Horner syndrome. So we all know that spinal cord compression is a medical emergency, and often due to a lack of multidisciplinary team discussion, these children are not able to get the best treatment. We need to discuss whether chemotherapy, radiation, or surgery is the best way to go for your patient. Most often, chemotherapy does its job for such patients. This child, being treated for all sorts of neurological problem, actually had opsoclonus myoclonus. You could see the myoclonic jerk in this patient, which was leading to a diagnosis of any child who's presenting with those saccadic eye movements and such a kind of a myoclonic jerk. We need to look for a neuroblastoma, which might be very small. And by the time this child is identified, diagnosed, started on treatment, the boat might have already sailed. Mediastinal masses is another area where children present and are often treated as tuberculosis. But just a lateral X-ray points towards a posterior mediastinal location of this mass, which in a young child is almost always a neurogenic tumor. So these are some patients which we need to be aware in the pediatric age group. In the infantile, we have these very sick children who have stage 4S neuroblastoma. The West report outcomes of 80 to 90% for these children who do not have a marrow or an extensive bony or a bony metastasis. And believe me, in our country, that is not what the outcome is. These children require urgent attention, diagnosis, chemotherapy, sometimes radiation, and then only we can have good outcomes for neuroblastoma. The other big problem that we face day in and day out when we talk about pediatric cancers is abandonment. A lot of work has been done by our Indian colleagues on abandonment issues, identifying abandonment, defining abandonment, trying to understand the extent of abandonment. But really speaking, a lot needs to be done in the ways to actually improve the abandonment rates. And I was just, trying to mention this important study whereby providing holistic support and a prospective tracking strategy, abandonment numbers can be actually reduced very drastically, and that leads to good outcome of every cancer and also neuroblastoma. We looked at the access to childhood cancer care. And with Neha, who came in from Australia to do this study with us, we identified that the referral pathways for children with cancer are extremely complex in India. And by the time these children come to a pediatric oncologist, or say a medical oncologist, or a surgeon, or a radiation person, by that time the boat has already sailed, and these children have actually gone through hell in their lives before the treatment can be started. So we need to find ways to actually optimize these referral pathways so that children with cancer can have good outcomes. Now, coming to the risk stratification, you have identified the disease, you have kind of, made sure that the patient is going to take treatment. Now you need to do a risk stratification. Now, with every passing year, the risk stratification is becoming more and more complex. We need to find out what we can do in India and how we can optimize the risk stratification for our patients. Doing IDRF is not at all difficult. You just need to walk into your imaging room, discuss the imaging with your surgeon and your radiologist, and you'll be able to identify whether the patient has an IDRF or not. I like this slide which was shared with me by Dr. Mukta Ramadwar, which in a very simplified way tells us how we look at histology in neuroblastoma. If you go through the full literature of how you look at the histology, it can be quite, daunting to go through pages and pages of histology. But just a simplified algorithm can actually optimize your histology. This, along with the age group and the MKI numbers, you are able to say whether the patient has a favorable or unfavorable histology. For the SIOP PODC, if you are not able to get a MIC amplification, LDH, ferritin are surrogate markers that can be implied. I'm not saying that you do not do an NMIC amplification, but I'm saying wherever facilities are not available, if we do that, the outcomes of neuroblastoma can improve in our country. Wherever all the facilities are available, I will fully recommend that we do the ideal staging workup and the entire risk stratification for these patients. But, even to date, doing a 11q aberration, doing a ploidy is not that easy for our patients, and most centers do not have access to do that. Once you have done your risk stratification, even if you do not have access to the high-end, solid tumor cytogenetics, just by the basic workflow, you are able to risk stratify and allocate treatment. And if we do that appropriately, outcomes of neuroblastoma are definitely going to improve. So we need to understand that the low risk, mainly it will be the surgical intervention. For intermediate risk, we may need to give chemotherapy with surgery, and the high risk are going to need the entire spectrum of treatment. And we cannot achieve that by unless we do a multidisciplinary team approach, which unfortunately is still not followed at many cancer centers in India. Coming to the chemotherapy aspect. Now, we need to choose our own regimen for our own center. If we end up with too much toxicity with the COG kind of a protocol where anthracyclines are used for the patients and high doses upfront, we may not have good outcomes. So we need to understand, SIOPEN protocols, the rapid COGEC are usually not associated with too much toxicity. So your center, whatever best supportive care is available, please choose the chemotherapy accordingly. And maybe an agent with a lesser toxicity might suit your patients more than the others. When we come to surgery, often, we see that some of these high-risk neuroblastomas undergo very aggressive surgeries that, we are going to remove 99% of the tumor. Sometimes children end up with biliary leak, chyle leak, multiple complications post-surgery, and the adjuvant treatment after that is delayed for, 2 months, 3 months, sometimes, longer periods. Are we going to get good outcomes for neuroblastoma with that? No. So I think, again, we need to discuss what is the optimal way. And I would suggest a maximal safe resection for your patient, so that 2-3 weeks into the surgery, we are able to start with the adjuvant treatment. Coming to autologous bone marrow transplant, with good training, more and more doctors coming with a training in bone marrow transplant and being trained abroad. I think this is something which is doable now in our country, and we have access to that. and there are different regimens, but Bumel is probably the one which has stood the test of time, and CEM is probably losing its role in managing neuroblastoma by the form of autologous transplant. Now, this very interesting paper from PGI Chandigarh, where they found their own low-cost adaptation to do an autologous stem cell transplant. So, the earlier paper of PGI, it mentioned a cure rate of 10%. So they were really not doing well. So when they adapted their own new strategy, their outcomes have improved. They did not cryopreserve the stem cell, they did not use the stem cell, the central line, and there were many other methodologies. They gave rapid Kojak on an outpatient basis, and with all these attempts to improve outcome, they could actually very well document that there was almost like a 20-30% jump in their outcomes for that particular center. Now, again, I would like to re-emphasize that this may not be applicable for every center. For your center, if you're already at, say, 30% outcome or 40% outcome for neuroblastomas, you probably would, stick to whatever you are doing and try to improvise upon that. Single versus tandem transplants, I think most often people are using single transplants because the benefit with tandem transplant is not very significant for us to propagate that in a low and middle income country. Okay. Now, the other way the PGI, looked at for the patients where transplant was not possible. So post-surgery, they introduced the TVD block, which is commonly conventionally used for patients who are refractory. Their upfront block was Cyopen. If the patients underwent surgery and their disease was kind of under control, they went ahead and give consolidation with TVD block, and 4 blocks were used. And with that, they could document about more than 30% outcome for their high-risk neuroblastomas. The next step for treatment of these patients is radiotherapy. It is challenging. We have so many radiation oncologists today with us. There are more and more facilities coming up. There are NGOs that are supporting radiation, and we can try innovative strategies to avoid daily sedation, which can be a challenge for these young babies. Augmentation.
Manas, try to wind up, Manas.
I'm just going to wind up in 2 minutes, sir. Augmentation of maintenance with appropriately using immunotherapy with retinoic acid also gives probably a 10% advantage to these patients. Next comes the immunotherapy, the main big game changer for patients with neuroblastoma in the Western countries. While they were dealing with refractory disease as the big problem, they invested into the monoclonal antibodies and got a 20-30% improvement in their survival. For our country, that is still a dream. I think collaborative efforts, patient advocacy groups, IAP PHO chapters' role in talking to the drug companies, Government of India to get these novel therapies in India, and support from colleagues abroad is probably going to help. For those who are interested in managing neuroblastoma, there is an ICMR consensus document. There is a SIOP-PODC document wherever limited sources are available. And there are INPOC trials now available where all the biology studies and risk stratification and ploidies and NMICs are being done free of cost for their patients that can improve the risk stratification of their patients. So to come to a conclusion, we need to promptly diagnose, suspect and diagnose. We need appropriate referral, a holistic support for these patients, nutritional support, patient tracking, accurate risk stratification, a multidisciplinary team approach, a maximal safe resection, autologous transplant, facilitate radiation, a good supportive care, and patient advocacy to improve the outcomes for these patients. So can we replicate success in neuroblastoma in India? Probably yes, to a great extent, but not still quite there. And I'm sure with time, we are going to reach there. Thank you.
Thank you, Manas. Now over to Dr. Vikas to introduce the next speaker. Thank you.
Thank you very much, sir. So Manas, I have a question for you. I have a patient right now who has got high-risk neuroblastoma. We have given 7 cycles of OPEC, OJEC-based therapy. And now we know it very well that transplant is to be done and the family is running short of money. So we were actually debating in our unit whether to give a single drug melphalan for that patient and do a outpatient transplant. So what is your view on that?
So I would recommend that you go through that PGI's paper, because in that they have used melphalan for a few patients of theirs and try to do a kind of a mini transplant for their patients. I am not sure of the subset analysis for what happened to those patients who were given only melphalan, but you know that is something that in that paper has been mentioned as one of the agents used for their transplant. I personally have not used that. We mainly use Bumel based conditioning for our patients for a transplant.
I think Bumel is the standard of care, but when you don't have money, that's the thing. That's the problem what you practically face. So I
understand that. Yeah, that practical challenge is there. So, you know, something is better than nothing. And I would recommend that, you know, we try to consolidate whatever gain you have achieved in this patient with some therapy post-surgery.
Thank you very much, Manas. And thank you. So over to Dr. Ramandeep Arora. Dr. Ramandeep Arora is a senior consultant in Department of Pediatric Oncology at Max Super Speciality Hospital, Saket. And Dr. Ramandeep is going to talk on WHO Global Initiative for Childhood Cancers. Over to you, Dr. Ramandeep.
Hi, good afternoon. Thank you so much, Vikas and Satya, and to the team at Paras, Neha, for giving the opportunity. It's a 15-minute talk. I will try and do it faster than that so that you know, we are able to stick to time, or at least claw back some of it. I hope you can see my slides.
Yes, sir.
Yeah, thank you. So I'm going to talk to you about the WHO Global Initiative for Childhood Cancer, and there's a link over here which I have attached, which you can easily find through Google. And I'm going to talk mainly on three parts: the context of this initiative, what exactly is this initiative, and what has been done in India over the last 2-3 years in that regard. So as you all very well know, and there's not much point reiterating it, when we treat a child with cancer, there are three main stakeholders, and the role each of these stakeholders plays depends on how the dynamics of the institution is and what resources are available. And again, I'm not going to go through all of these, but I've summarized over the years and decades what have been the various initiatives which have been taken by each of the stakeholders, whether that's the government stakeholder, whether it's the pediatric oncology community stakeholder, or whether it's a civil society stakeholder. All of them have evolved over the years to a smaller or larger extent, and together are trying to provide the best service possible to children with cancer. And all of you on a day-to-day basis experience this. Now, within this comes WHO, which obviously is a very desirable stakeholder. And as pediatricians, we have been used to hearing them in the context of diarrhea and pneumonia and so many other things. But we've always dreamt and hoped that this would also happen in the context of childhood cancer. So finally, they decided to show an interest. And this has happened by a concerted effort over the last, say, 6 years. There was a side event in 2015 in the WHO World Health Assembly. This led to a formal resolution where the governments actually said, because the governments have to give a mandate, and told the World Health Assembly that yes, childhood cancer is a public health priority. This was the first time this had ever happened. This then led to the following year having the WHO Global Initiative Childhood Cancer launch in Geneva in August 2018. And this has subsequently led to a lot of activity, which I'm sure some of you would be aware of, and I would bring that information to you in the coming slides. So the main thing we said is, let's pick a number. So for the year 2030, we should ensure that assuming that the global average is 30% survival, we should double this to 60% survival for the entire world and reduce suffering. So that takes into account palliation as well. And if we do this, we will save 1 million or 10 lakh more children by the time 2030 comes. So that has been their target. We are now in 2021. We are 1 year behind because of the pandemic, but that is where the work is going on. Now, the work which they are doing is happening at obviously global level, regional level. For example, in the context of India, it is WHO CRO, the Southeast Asian Regional Office, and at country level. And all of us, all of you would be engaged in some form or the other at one level or the other. So, for example, in the global initiative, there are technical packages being developed. There's a background guide, framework document, etc., and a lot of tools which are in the process of coming out soon, which will allow hospitals and countries to assess where they are and monitor their progress. There's a lot of advocacy documents being produced in terms of workforce, access to medicines. as well as indicators to monitor and evaluate progress being made. Now, this is an example of the first document which came out, which is the background document, Global Initiative for Childhood Cancer. Subsequently, this is the actual logo for this entire 10 years, Cure All, and it's an accurate acronym for the various aspects of the WHO GICC program. And then finally, this framework document, which is currently in production, which summarizes all the action points. And after this is produced, then will come the detailed technical packages with instructions on what each hospital or each country could do to make progress. Along with this technical package and the global work being done, WHO is operating through focus countries. So it clearly cannot adopt the whole world, but it is working with governments and choosing certain countries. So the first focus country which was chosen was actually in CRO, and that was Myanmar. And things had been going great there till the recent political upheaval. Subsequently, they have chosen one country in each of the WHO regions. So Peru, Ghana, the Caribbean, Uzbekistan, Myanmar, Philippines, and Zambia. And now they're choosing the second round of countries. And being a country, a focus country, expedites things. But if you are not a focus country, because most countries will not be one, that doesn't stop you from still using the tools and the information to bring about change in your own country. Along with focusing on certain countries, they have taken focused cancers or index cancers, and these are 6 in number. On the left hand side, you have 3 which are leukemia, lymphoma, so ALL, Burkitt's lymphoma, and Hodgkin's lymphoma. And on the right hand side, you've got solid tumors and CNS tumors, which is retinoblastoma, Wilms tumor, and low-grade glioma. And the logic being that these are common cancers, highly curable cancers, prevalent in countries, and if we catch them and treat them properly, very high outcomes are possible. And you've just heard this panel discussion on low-grade gliomas earlier today. So what's the last part of the talk, which is what's been happening in our country over the last 2 to 3 years since this WHO GICC was launched in August 2018. There are 2 aspects to this. One is what has been done by WHO CRO. So what I have learned in the last 2 years is that WHO works through the regional offices, and the regional offices work through the national offices, and the national offices works through the government. And there is not much say which any other body like the PHO IAP or the INPOG or individual hospitals have in this. So the first workshop was done in 2019 June, which was organized in Delhi. At that time, Andrew Bavi came, who is the WHO officer for this, and he introduced the whole idea. Carlos was here, who represents St. Jude's Global and is a partner with the WHO on this. Myanmar, which was the first focus country, was chosen, and they talked about their initiatives. And finally, the remarks were given by Ritu Bhalla, who's a double childhood cancer survivor. A year after this, the second meeting was done, and this was done virtually. By this time, a SEER CC network had been formed, which is basically a childhood cancer network. The governments of each of the countries in the CRO region were asked to nominate centers of excellence. And as you can see from India, North India, South India, East India, and West India, 4 centers were nominated. Along with this, they also invited 2 partners, St. Jude's Global by the virtue of their partnership with WHO, and CanKids as a civil society representative. And together in this meeting, they further discussed how action would take place. And again, when they're discussing both within these hospitals, but also in the wider context of the country like India. In parallel, the pediatric oncology community and the civil society have been trying to generate momentum within our own community. So with the June 2000 WHO meeting, we also had a parallel event in Max Hospital, and many of you were there. That then led to detailed discussions in the PHO FOCON Varanasi in September 2019. And finally, in October 2019, we had a chance again to meet with the WHO officer, Andrel Bavi, and develop some ideas. And all of this was summarized and published in the Pediatric Hem-Onc Journal I think last year, by the title WHO GICC India Responds. And I would encourage anybody who wants more information to kindly have a look at it. So what has been achieved so far is that there's been some sensitization and awareness done within the pediatric hem-onc community. There has been a buy-in from the leadership of PHYAP, INPOC, CanKids, and others who have committed to this effort. There has been brainstorming and identifying of areas of focus, which have been then consolidated into 9 task forces. And I will highlight those task forces in the subsequent slides. And finally, we have reached out to all these stakeholders, not only international stakeholders, but also the government of India. So they know that there is a desire and a momentum within the pediatric oncology community, because that is very key to get the government on board. They need willing partners. Our next steps, which is what is happening right now as we speak, is to broaden the coalition, identify the stakeholders both in the central government and the state government. We want to align what we are doing in the pediatric hem-onc community with what the WHO CRO is doing across this area. Our task forces, which we have created, need to be populated, and anybody who has any interest can please contact me or write to me. I'm sorry, I've not put my email, but that can be easily obtained. And of course, for all of this, we need funding and resources. So these are the 9 task forces which have been agreed by consensus. And as Manas was showing in his neuroblastoma talk, it's not just about one drug. You have to address multiple issues to improve outcomes. So similarly, if we want to improve the outcome of cancer in India overall, we have to look at multiple areas. And we have been sending out a Google form to those who have an interest to choose a task force or more than one task force and say what they can contribute. And then once we have collated a list of interested individuals, we will reach out to them and start convening task force meetings. And ultimately, we want to develop an Indian coalition. This is obviously an expanding coalition with the government, with international and national organizations, with civil society, with professional societies, with foundations, and of course, all the hospitals from which you come. I think that's where we are till now. I once again thank the organizers for giving me the platform to share this, and would welcome your engagement and questions. Thank you.
Thank you, Dr. Ramandeep, for a fantastic talk. And if we have, do we have any questions?
Vikas, can you allow me to ask one question?
Please go ahead, Manas.
Raman, I just want to ask you about, the engagements with the Western countries and their interest in developing and supporting pediatric oncology in the low and middle income countries. I personally feel that the developed countries have invested a lot in Africa and many other Asian countries, but their interest in India has been less as compared to their interest in other developing countries in the world. Do you think this observation is correct? And if it is correct, what are the ways that we can, get their help to improve the existing pediatric oncology outcomes and structure in our country?
So Manas, the great question. The observation is correct, but that's not because of lack of interest. What happens is when you approach a Myanmar, there are only 2 centers, Mandalay and Yangon. If you approach a Ghana, there's only Accra. But the minute you look at India as a partner, you say, okay, where do I start, right? So what people tend to do is they go to the centers where they have trained. So if you've trained in Australia and Westmead, you would find a partner there. I have trained in Liverpool, I would go and find there. So that's one of the reasons why it's been difficult for, say, a St. Jude's to say, I will take over the country or I will engage with the whole country, because where do you start? The second reason is that India, of course, has enormous strengths. So many of the problems, like getting expert advice, like getting proton therapy, like getting, MIBG therapy, etc. So many things can be found in-house. Advice, virtual tumor boards, genetic tests. So you don't need to depend on the Western colleagues who are very well-meaning to find all the answers. If we can get our act together and collaborate, many of the answers can be found within. And so there has been that's also been a reason why the engagement hasn't happened. And finally, and most importantly, what twinning has taught us over the years has been the single most important factor for success of twinning is a local motivated champion and partner. So a Western country cannot do anything with you as long as you are not willing to engage and you want them and you're putting the effort in. And once that happens, then I think the collaborations will happen.
Thank you, Raman.
Thank you very much, everyone. And I thank all the speakers, the panelists, the moderator for a fantastic session. I thank Dr. S.P. Yadav, Dr. Anupam Sachdeva, sir, my mentors. And with this, we wind off this session, and we are eagerly waiting for the next talk, which is going to be on sickle cell disease in children, the newer options. Over to you, Neha.
Sir, would I request Dr. Yadav and you to stay and chair the session, the next session as well, if it's all right?
Yeah, please. Yeah.
Yeah.
Sure.
Okay. Fine. All right. I'll invite the next speaker. Can I have the slides, please?
Please go ahead.
This talk is on sickle cell. Dr. M.B. Agarwal and Dr. V.P. Chaudhary are not able to join us right now. So Dr. Yadav and Dr. Vikas will be chairing the session. Sir, I'll just request Dr. Yadav to please introduce Dr. Nitya Bakshi. It's on the screen. Madam is a assistant professor in Department of Pediatrics in Emory Children's Hospital and University from Atlanta. Ma'am will be speaking on sickle cell disease in children, the newer options.
So Dr. Nitya, we are eagerly waiting for your talk because we in India have been doing many transplants for these patients of sickle cell anemia. There are many patients who travel to us all the way from Africa, from different countries in Africa, and they come to us for the transplant. But somehow there is less of awareness of these transplants in our country. So if I have to tell you, I've done more than 50 transplants for patients of sickle cell anemia from Africa, but not even a single from our own country. So we are really very excited, and we want to listen to you. What are the newer options we have for these patients? Over to you, Dr. Nitya.
Thank you very much. I want to share my screen. Okay. Good morning, everybody. Thank you very much for inviting me today to speak. I want to thank the organizers as well as our esteemed panelists for inviting me to give this talk here today. So I am from Emory University in Atlanta, and also a pediatric hematologist, oncologist at the Afla Cancer and Blood Disorder Center at Children's Healthcare of Atlanta. So as far as sickle cell disease goes, we know that the global distribution of the hemoglobin S mutation directly corresponds to the regions where malaria is endemic. And India is definitely one of the hotspots where sickle cell disease is very prevalent. We know that sickle cell disease involves all organ systems. It is a chronic multi-system hematological disorder, and as you can see, is associated with both acute as well as chronic complications of almost every organ system. These complications, it's important to remember, are progressive and accumulate over a lifetime. And as you can see, that they tend to increase with age, particularly the end organ complications such as kidney disease, avascular necrosis, for example. In India, the haplotype that's usually found is the Arab Indian haplotype, but what was believed to be mild is, on further examination, is not necessarily universally mild despite high hemoglobin F levels. You can see that this is a comparison between two groups, one in Valsad and one in Nagpur, that show that there is a much higher rate of clinical events in the Nagpur cohort. And some of this is related to the presence of alpha thalassemia, but that the Arab Indian haplotype, which is believed to be mild, is not necessarily always mild. In fact, when clinical events were studied in a prospective pediatric cohort in India, they were higher than what was described in the cooperative study of sickle cell disease in the United States. So in this study, Jane and colleagues studied both a non-newborn screening cohort as well as a newborn screening cohort. So newborn screening cohort followed those patients who were identified at birth with the diagnosis of sickle cell disease. And as you can see, that the event rate of pain crises and anemia and splenic sequestration, as well as are much higher in the Indian cohort as compared to the cooperative study of sickle cell disease. As is the mortality, which when tracked over time is also a lot higher even in the newborn screening cohort as compared to the CSSCD. So, which brings us to the treatment options that exist for sickle cell disease. And I'm going to go over both both treatment options that have been existing for some time and those that have been that have come in the last 5 years or so. So the most well-known treatment option obviously is hydroxyurea, which is an inhibitor of ribonucleotide reductase, and its primary mechanism of action is through the induction of fetal hemoglobin. However, high induction of fetal hemoglobin is not the only thing that hydroxyurea does. It actually also lowers neutrophil and reticulocyte counts, improves RBC rheology, and its mechanisms can really be nicely seen in this figure described from Russell Ware in Blood back in 2010. Hydroxyurea was the first medication for sickle cell anemia that was approved in adults in 1998 and more recently in children in 2017. And the data for hydroxyurea has been longstanding and very robust in sickle cell disease. The first study to show any efficacy was on a large scale was the multi-center study of hydroxyurea, where hydroxyurea was shown to reduce painful events as well as time to first and second pain crises as compared to placebo. This trial enrolled adult patients and subsequently, even at the end of this trial, this study followed up patients, and at the first 9-year follow-up, an estimated mortality reduction was 40% with hydroxyurea. And as you can see, that the mortality in sickle cell anemia was related to the levels of hemoglobin F, as well as prior episodes of painful episodes, as well as acute chest syndrome. At a 17.5-year follow-up in the multi-center study of hydroxyurea, it's unquestionable about the survival benefit of using hydroxyurea in sickle cell anemia. And you can see that, people who used it for 10 to 15 years had more benefit than someone who used it for 5 to 10 years, for example. But definitely there is a survival benefit in this study with the use of hydroxyurea. When it comes to children, Baby Hug was the definitive trial, which studied infants as young as 9 months of age prior to the onset of clinical events. And even in that subset, hydroxyurea, when compared to placebo, improved hemoglobin and hemoglobin F levels and clearly reduced event rates. So these, you must remember, are children who have never had a sickle cell, have not had sickle cell anemia related events and have received hydroxyurea prior to that at a very young age. And in the Belgian cohort, hydroxyurea use even with children is associated with a survival benefit when compared to no treatment. In the Indian experience, fixed low-dose hydroxyurea, which is 10 milligram per kilogram, as opposed to the usual 20 milligram per kilogram starting dose, has been used. And there have been multiple publications that have described this experience. This regimen has been preferred because it is requires decreased monitoring and the cost associated with it. It's generally well tolerated without significant adverse events and has shown that there is a clinical benefit in reduction in number of pain crises, blood transfusions, as well as hospitalizations. After hydroxyurea, the next drug that came approved was L-glutamine, which was approved in 2017 for children age 5 and older. And L-glutamine is a precursor for NAD in the red blood cell. And given the oxidative stress that occurs in red blood cells in sickle cell disease, what L-glutamine does is that it increases the NAD redox ratio and sort of mitigates this oxidative stress. And when studied in a phase 3 trial, L-glutamine reduces pain crises and hospitalizations by about, pain crises are reduced by approximately 25%, which can be seen in these graphs over here. And it also reduces the median number of days to first pain crises to 84 days when compared to 54 days in the placebo arm. They also noted that in the study that acute chest syndrome was less frequent in the L-glutamine arm as compared to the placebo arm. The third drug that I'm going to talk to you about is crizanlizumab, which is a monoclonal antibody that blocks the endothelial adhesion molecule P-selectin. And if you remember, P-selectin is expressed on the endothelial surface and is a and adhesion of leukocytes with to P-selectin on the endothelial surface triggers the is part of the vaso-occlusion cascade in sickle cell disease. So crizanlizumab was FDA approved in 2019 for ages 16 and older, and its efficacy was shown in the SUSTAIN trial, where high-dose crizanlizumab, when compared to placebo, reduced the rate of pain crises by 45%. And the effect was even more pronounced when they did a per protocol analysis. In the SUSTAIN trial, they also showed that high-dose crizanlizumab reduced the time to event, time to first and second pain crises after enrollment. And you can see the marked separation of the curves here at 12 months of treatment. Voxelotor is another oral agent which is now available, also FDA approved in 2019 in ages 12 and older. It is a hemoglobin S polymerization inhibitor, which reversibly binds to hemoglobin to stabilize the oxygenated hemoglobin state. It increases the affinity of hemoglobin to oxygen, and it was most recently studied in a phase 3 trial, the HOPE trial, that showed that voxelotor significantly increased hemoglobin levels and reduced markers of hemolysis. And so the absolute change in hemoglobin was 1.1, with a relative change in decrease in both reticulocyte count as well as indirect bilirubin, which are markers of hemolysis. And however, voxelotor did not show any change in the event rate and pain crisis in this study. And then the last treatment, which is a curative treatment that we'll study, is hematopoietic stem cell transplant, which, as we all know, is the only curative therapy in sickle cell disease. It is limited in application for a multitude of reasons. One of them is the availability of HLA identical donor, then the intensity of the treatment, the costs associated with it. And there's a lot of literature about how decision-making in regarding hematopoietic stem cell transplant is in sickle cell disease. In general, in hematopoietic stem in a transplant with HLA identical sibling donors, the outcomes are quite excellent, with a 5-year overall survival of around 91.4%. And here in this curve, they have been the outcomes have been stratified by source of the hematopoietic cell transplant. And in general, younger age at HCT predicts good outcomes of HLA identical transplant. And you can see here that the best outcomes are actually at the youngest kids. But the decision, there is a lot of risk-benefit weighing that goes on when considering hematopoietic cell transplant. On one side is the potential for cure, freedom from sickle cell complications, improved survival, not having the progressive accumulating damage that happens in sickle cell disease, which is weighed against the risk of death from the transplant itself, treatment-related complications, long-term effects, particularly infertility. And then there are other factors that influence these, and in different situations. Some of it is age of the donor and the recipient, the donor options that are available, and other treatment options that I have now listed for you, particularly the new drugs that have disease modifying ability. So in general, I hope that that I can communicate that there is significant morbidity and mortality associated with sickle cell disease, with multiple treatment options now available, including curative options for sickle cell. And thank you again for allowing me to share this and speaking with you today. I'd be happy to take any questions.
Thank you very much, Dr. Nitya, for a fantastic talk, and we would be happy to have questions from the audience. Okay, so I have a couple of questions for you, Dr. Nitya. So we know it very well that FDA approved hydroxyurea in 1998, and for pediatric age group, it was approved almost 5-6 years back. So what is your experience with the combination of hydroxyurea with glutamine? Because there are a couple of patients who actually don't respond to hydroxyurea even after going up on the dose. So have you ever tried combining hydroxyurea with glutamine? Because glutamine was also approved by FDA in 2007.
Yeah, yes, they are used in combination. In fact, the Indari trial described people being on hydroxyurea. So they are used in combination, particularly if you are running into complications while on hydroxyurea. So I think that's okay.
Yeah, so in our experience also, we have seen that patients who don't respond to hydroxyurea, if you combine that with glutamine, sometimes you can see responses. And what is your take on hematopoietic stem cell transplant? Because the recent publications from EBMT group, from CIBMTR, and from Eurocord, the overall survival is close to 97%, 5-year-old survival is close to 97%. So do you feel that still we should hesitate in going ahead with transplant and think of these newer options, or HSCT should be the standard of care for everyone?
So I think it's a very complex question. There are many nuances to that answer. I think in general, the thought is that patients should know of all possible options, and use of hydroxyurea or another disease-modifying therapy does not preclude the option for going to bone marrow transplant. The decision for bone marrow transplant, I think, is very complex, especially when you consider a child who is young and who may not outwardly have complications. There are a lot of factors to consider. One of them is obviously donor, which is a barrier. Then the current complications that they have already had, and weigh them against the risk of future sickle cell disease related complications. In my experience, families have had a lot of difficulty, even when they have an eligible donor, and they would like to consider transplant, I think deciding when to do so and when to proceed is an extremely complicated decision for families, because you have to sort of then account for all of the things that could, all of the risks of transplant, and then also the long-term morbidity from the transplant itself.
Thank you. And we all know it very well that the starting dose of hydroxyurea is 15 to 20 mg per kg. But in your experience, what is the maximum dose you have used, and have you really observed toxicities because of that?
So the maximum tolerated dose is, that is described is up to 30 milligrams, sometimes a little bit higher too. And in general, hydroxyurea is very well tolerated. If there are toxicities, then they're typically reversible. So the general recommendation is to, at least here, is to escalate to maximum tolerated dose where you have maximum benefit without any side effects.
Thank you. And the last thing is just a comment, because so I know you have just talked about the newer medicines, clesrazumab.
Yes.
So it was approved by FDA in 2019, but it is now available in India. So Novartis is making that, and it is available in India. So if anybody who is dealing with sickle cell anemia patients in India, and the patient is not responding to the conventional hydroxyurea or glutamine, then you can have access to this medicine.
Yes, but it's only approved in 16
for patients more than 16 years. Yeah, that's right. Thank you very much, Dr. Nitya, for a fantastic talk. And with this, we wind off this session. And over to you, Dr. Neha Singh.
Dr. Vikas, could you just facilitate Dr. Nitya?
Oh, Dr. Nitya, this is for you, and we are for your fantastic talk. And
thank you very much.
All right, thank you. Thank you, Dr. Vikas Dua, for joining us, and kindly for the kind gesture that you chaired this next session as well. So thank you so much. We'll move on to the next session. This is a talk by Dr. Saji Kumar. He was not able to, he had to leave early, so his session has been pre-recorded. And to chair the session, I will request Dr. Satya Ranjan Das, sir, to please, I think we can just switch on the video, sir, and your mic. Sir is a professor, pediatrics and clinical hematology in Command Hospital, AFMC, Pune. Sir, I'd just like you to introduce this.
Thank you very much. I think Dr. Saji has recorded speech. So just to introduce Dr. Saji Kumar, he is a professor hematological malignancies and consultant division of hematology, chair myeloma, amyloidosis, and dysproteinemia, and associate chair of research, Department of Medicine at Mayo Clinic in Rochester, Minnesota. He's been an old friend, and he is also been a guiding force for all kind of academic activity related to myeloma in world as well as India. I remember he been coming here to India and Delhi and doing the IMWG and then of course IMAGE first meeting. So I think without any delay, let us start the talk of Dr. Saji Kumar. He's a very well-known person so far myeloma is concerned in the world. Thank you. You can start it.
One, we are. You may go.
Hi, my name is Shaji Kumar. I'm a professor of internal medicine at Mayo Clinic in Rochester, Minnesota. Thank you for the invitation to present at this enclave. I'm just going to start that again, sorry. Hi, my name is Shaji Kumar. I'm a professor of medicine at Mayo Clinic in Rochester, Minnesota. Thank you for the invitation to present at the meeting. I would like to present on some of the recent advances that have happened in the field of multiple myeloma. These are my disclosures. Now, the myeloma treatment paradigm has significantly changed over the past decade or two with increasing understanding of the disease biology and the natural history of the disease. In addition, several new therapies and treatment approaches have been introduced in the treatment of multiple myeloma that has resulted in a significant improvement of survival for patients with this disease. Even though it remains incurable with the current treatment for the majority of the patients, a judicious use of the currently available therapies have led to the ability to control the disease for long periods of time. Now, when you think about the myeloma therapy and the approach to the diagnosis and treatment of monoclonal gammopathies in general, we can think about the precursor stages, the early phases of the disease, then the diagnosis of active myeloma that requires therapy, the early treatment of myeloma, and then the treatment of relapse disease as the patients continue to relapse. First, let's talk about the diagnosis and risk stratification in these patients. Now, we have learned over the past few years that multiple myeloma is always preceded by a precursor phase, often referred to as a monoclonal gammopathy of undetermined significance. Now, based on various modeling, it is believed that the monoclonal gammopathy of undetermined significance probably exists for 15 to 20 years before patients develop active myeloma, suggesting that this probably arises somewhere in the 30s. Now, over time, about 20% of patients with monoclonal gammopathy of undetermined significance will have disease progression to active myeloma in the majority of patients, and in some patients, it can also progress to light chain amyloidosis or a variety of other lymphoproliferative disorders. Now, the natural history of these precursor phases of monoclonal gammopathy, as well as the intervening phase of smoldering multiple myeloma, has been well defined based on large epidemiological studies. Now, during this progression from the monoclonal gammopathy to active myeloma, there is gradual increase in the tumor clone that it can be measured as increasing plasma cell percentage in the bone marrow or increasing amount of monoclonal protein in the serum or urine. Now, over time, we have developed various risk stratification systems that will give us a better sense of who are the patients who are going to progress. And when you look at the graph here for the monoclonal gammopathy of undetermined significance, it is roughly 1% per year. And this risk does not change over time. And even if you had monoclonal gammopathy of undetermined significance for 20 years, the risk of progression still remains 1%. And this is an important consideration when you decide how to follow these patients, which should be on an annual basis. In contrast, patients with smoldering multiple myeloma, which is often considered an intervening stage between MGUS and active myeloma, the risk of progression is considerably higher, with about 10% per year for the first 5 years, and then 3% per year for the next 5 years. And then finally, it approximates the same as monoclonal gammopathy of undetermined significance. Clearly, smoldering multiple myeloma represents a mix of MGUS and active myeloma, and over time, it becomes clear who has already passed the threshold of transformation from MGUS to myeloma. Now, the second important thing to note is that the definition of active myeloma needing therapy has changed somewhat over the past few years. Now, the reason for making this change was because many of these patients in the past would get started on therapy only when they develop end organ damage, which in some patients could be quite late, given that they may have renal failure that requires dialysis or catastrophic neurological end organ damage before we diagnose and treat myeloma. As a result of this, certain myeloma-defining agents, such as a plasma cell percentage of 60% or more, a free light chain ratio of 100 or more, and a presence of more than one non-lytic lesion have all been included as criteria for starting therapy for multiple myeloma. Now, the reason for doing this is because these characteristics actually predict the risk of developing active myeloma for about a risk of about 80% over the 2 years. So it's a concept of starting therapy instead of waiting for something bad to happen. Now, once you make the diagnosis of multiple myeloma, it is important to risk stratify, one from a prognostic standpoint so that patients can be given a good sense of what the outcomes would be. But equally importantly, it can also help us decide what kind of therapies we want to use for these patients. So the revised ISS staging system is the most commonly used risk stratification system in this disease, and incorporates some of the initial ISS staging system variables, including the serum albumin and beta-2 microglobulin, the serum LDH, and also the cytogenetic characteristics, which are important parts or important drivers of prognosis in this disease. And this is an easy to use staging system and divides patients into 3 groups outcomes in terms of progression-free and overall survival. Now, once you make the decision that you have to go ahead with treatment for active myeloma, the next question that comes up is it a patient who is transplant eligible, or is it someone whom we would not consider autologous peripheral blood stem cell transplant? Now, this approach has changed somewhat in the recent years for 2 reasons. One, we know that we can certainly provide stem cell transplant to older patients up to age 75 if we select the patients appropriately without significantly increasing risk. Expanding the utility of this approach beyond the patients that have been studied in phase 3 trials. At the same time, there have been trials showing that stem cell transplant can be deferred in selected patients if they so prefer. So it is increasingly becoming a concept of who wants to get a transplant versus who does not want to get a transplant. Now, if you're thinking of incorporating an autologous peripheral blood stem cell transplant as part of that initial treatment package, then you want to start these patients on what we often refer to as an injection therapy for a brief duration, followed by the autologous transplant, and then in some patients maybe consolidation, but nevertheless maintenance in all these patients. In patients who don't go to a stem cell transplant, these patients often continue on therapy with a given regimen, often until disease progression, with the goal for the initial therapy being that we get to the maximum response that is achievable. So what is the initial therapy if you're thinking about somebody with newly diagnosed myeloma? The most commonly used regimen in the current setting is the combination of bortezomib, lenalidomide, and dexamethasone. This has been shown to improve the overall survival among patients with newly diagnosed myeloma, whether they are going to an autologous stem cell transplant or not. In the original phase 3 trial, only patients who were either transplant ineligible or were deferring the stem cell transplant were included in this study. More recently, we have attempted to improve on this regimen by replacing the bortezomib with the next generation proteasome inhibitor, carfilzomib. In the endurance trial, we compared carfilzomib Lendex versus bortezomib Lendex, and were not able to demonstrate any improved outcomes with the replacement of bortezomib with carfilzomib in patients who are either transplant ineligible or were planning on delaying their autologous stem cell transplant. And when we look at various subgroups, we don't see a benefit for using carfilzomib instead of bortezomib, suggesting that bortezomib, lenalidomide, dexamethasone still continues to be a standard of care regimen. Now, in the setting of transplant eligible patients, the newer approaches have looked at the concept of adding a 4th drug to the combination. And the introduction of monoclonal antibodies, especially the ones that are targeting CD38 like daratumumab, has made it easier to explore these options given the non-overlapping toxicity for these new drugs. So the Cassiopeia trial randomized transplant eligible patients with newly diagnosed myeloma to receive the classic bortezomib thalidomide dexamethasone regimen or daratumumab added to VTD. Patients then received an autologous stem cell transplant, received 2 more cycles of consolidation with the same regimen, followed by a second randomization to maintenance with daratumumab or no maintenance. This trial has shown that addition of daratumumab to VTD significantly improves the progression-free survival, and this appears to be, again, linked to the ability to achieve deep responses like stringent complete response. Now, given that bortezomib, thalidomide, dexamethasone is not a very commonly used initial therapy, particularly in the United States, there was another trial that was done, which was a randomized phase 2 study called the Griffin trial that randomized patients with newly diagnosed transplant-eligible myeloma to either daratumumab with VRD or VRD alone, followed by an autologous stem cell transplant, and then 2 cycles of consolidation with the same regimen, and then continuing on maintenance with or without daratumumab in combination with lenalidomide. Now, this trial has limited follow-up at this time, but it's clear that the responses are deeper with the addition of daratumumab, particularly in terms of the deep responses like complete response, and these responses did improve over time with continued therapy in these patients. Now, we don't have any long-term data, so it's hard to know if the addition of daratumumab to VRD actually improves the progression-free survival or overall survival for these newly diagnosed myeloma patients. The question that comes up next is whether there is a role still for autologous stem cell transplant with these newer regimens like bortezomib, lenalidomide, dexamethasone. The IFM 2009 trial evaluated the role of autologous stem cell transplant in the context of these newer therapies and randomized patients to getting 8 cycles of VRD or 5 cycles of VRD with the stem cell transplant, with all patients getting lenalidomide maintenance post consolidation. With updated data from this most recent ASH meeting, the randomized trial still shows a significant progression-free survival benefit for patients getting transplant compared to patients who are delaying a stem cell transplant. With longer-term follow-up, we have seen that a significant proportion of the patients, almost 70% of those patients in the non-transplant arm, did eventually get an autologous stem cell transplant at the time of relapse. And when you look at the overall survival and the PFS2, the PFS2 being a surrogate for the overall survival, we still do not see any difference in between the two arms, suggesting that delaying an autologous stem cell transplant to the time of first relapse did not impact the long-term or the overall survival outcome for these patients, suggesting that that is a viable alternative. Now, what about transplant ineligible patients? In these patients, the 2 standard regimens up until now had been the bortezomib melphalan-prednisone or the lenalidomide dexamethasone. So the Alcyon trial looked at adding daratumumab to the VMP regimen, and so patients with newly diagnosed transplant ineligible myeloma were randomized to VMP versus Dara VMP, and then patients getting Dara as part of initial therapy continued on daratumumab maintenance. This trial clearly showed that addition of daratumumab significantly improved the depth of response for these patients that transferred or translated into a better progression-free survival. Importantly, with longer follow-up, there is also an overall survival improvement with the addition of daratumumab to VMP. Now, given that the first trial already showed that the lenalidomide dexamethasone is better than thalidomide-containing regimen or melphalan-containing regimen, the RD had become the standard of care, especially for the older, frail patients. So the Maya trial looked at adding daratumumab to lenalidomide and dexamethasone and compared it to Lendex. And this phase 3 trial clearly showed that the addition of daratumumab not only improved the progression-free survival and the depth of response, but in fact, it also improved the PFS2, suggesting that in the with longer follow-up, we are likely to see an overall survival benefit for the DRD regimen. What is quite striking with the DRD regimen is that we still don't have a median PFS, suggesting that the progression-free survival with this approach can be is likely to cross 50 months, suggesting again that a VRD followed by transplant and len maintenance in the transplant eligible patient population and daratumumab lendex in the transplant ineligible patient population both are associated with a almost a 5-year progression-free survival from the first diagnosis. And that is incredible progress that we have made in the field of multiple myeloma. Now, what are the other approaches for this transplant ineligible patient population? There was data that was recently presented looking at ixazomib. This is an oral proteasome inhibitor, which when combined with lenalidomide and dexamethasone, significantly improved the depth of response and also led to an improved progression-free survival compared to lenalidomide dexamethasone. Even though numerically this is better, it failed to meet the statistical threshold for significant difference. However, There are 2 points to note. One is the ixazomib Lendex does give the option of an all-oral regimen for initial therapy of myeloma that is quite effective. And when you look at the median PFS of 36 months, this is quite comparable to the bortezomib Lendex data that we have seen from the SWOG trial or from the Endurance trial. Now, unfortunately, despite this improved PFS in the first-line setting, which is crossing 5 years, the majority of these patients will relapse, and we have to think about what to do for the relapsed patient population. And I think it's important to think about this relapse therapy again as the early relapses, where you have a variety of different options, to late relapses, where the options have considerably shrunken, and the late relapse refractory patient population, where we really have to look at novel therapies in clinical trials. For the early relapse, there have been several phase 3 trials that have looked at bortezomib-based combinations. The Endeavor trial looked at replacing bortezomib with carfilzomib, showed an improved response rate, an improved progression-free survival, and an overall survival. The Panorama trial looked at adding a histone deacetylase inhibitor, panobinostat, to bortezomib dex, improved the depth of response, and improved the progression-free survival. No overall survival data. The Castor trial added daratumumab to bortezomib dexamethasone, improving the survival outcomes. And there was a randomized phase 2 trial that examined elotuzumab added to bortezomib dexamethasone, and again showing some modest improvement in the progression-free survival. Now, a variety of other phase 3 trials have looked at adding newer drugs to lenalidomide-based doublet, and these include the Aspire trial that added carfilzomib to Lendex, led to improved PFS and overall survival. Tourmaline trial added ixazomib to Lendex, improved the progression-free survival. Pollex trial added daratumumab to lenalidomide dexamethasone with improved PFS. Overall survival data is still pending. And finally, there's the phase 3 Eloquent data that added elotuzumab to Lendex, improving both PFS and overall survival. The problem that we face in today's practice is that the majority of the patients would have been treated with lenalidomide maintenance for a prolonged period of time and are often refractory to lenalidomide at the time of their first or second relapse. And this can significantly narrow the interpretability of those phase 3 trials we just talked about, particularly the trials that use the lenalidomide-based triplets. And in that context, we really have to think about how do we change or use a triplet that will incorporate a new class of drug or 2 new classes of drugs. So there were at least 5 randomized trials that are quite informative in the setting of Len refractory patient population. The Icaria trial looked at combining isatuximab, that is an anti-CD38 monoclonal antibody, in combination with the next generation IMiD like pomalidomide and dexamethasone. And this trial showed that adding isatuximab to PomDex clearly improved the progression-free survival with a positive trend towards an improved overall survival as well. The Apollo trial, on the other hand, looked at adding another CD38-directed monoclonal antibody, daratumumab, to pomalidomide dexamethasone, again in patients with 1 to 3 prior lines of therapy. And this trial showed a very comparable results to the Icaria trial, again showing a significant improvement in the progression-free survival. So far, the data suggests that both the monoclonal antibodies, isatuximab and daratumumab, appear to have similar benefit either by itself or when used in combination with other drugs. Now, the other monoclonal antibody that has been important in the setting of myeloma therapy is elotuzumab. This is a monoclonal antibody that targets SLAMF7 on the myeloma cells, a different antigen. This phase 3 trial clearly showed that adding elotuzumab to PomDex significantly improved the progression-free survival, suggesting that this would be an alternate approach for these patients. And finally, there's no phase 3 data, but phase 2 data shows that adding the next generation proteasome inhibitor like carfilzomib to pomalidomide and dexamethasone also improves or provides a reasonable progression-free survival for these patients. Now, the other approach has been to completely switch both classes of drugs. So if you're Len refractory, use a proteasome inhibitor and a monoclonal antibody. So the Cantor trial looked at adding carfilzomib to or daratumumab to carfilzomib dexamethasone and showed that the triplet significantly improved the progression-free survival compared to the doublet of carfilzomib dexamethasone. On a similar vein, the IQMA trial added isatuximab to carfilzomib and dexamethasone in the relapsed myeloma setting, and again showed that the addition of isatuximab clearly improved the progression-free survival, similar to what was seen with the daratumumab in the CANTOS study. So now we have data from these two phase 3 trials showing that we can use a next-generation proteasome inhibitor with a monoclonal antibody in a patient who is refractory to lenalidomide with significant improvement in their outcomes. And finally, there's also the carfilzomib used in combination with cyclophosphamide and dexamethasone, a phase 3 trial that was presented at ASH, showing that you can get about a 2-year PFS with the use of carfilzomib, cyclophosphamide, and dexamethasone. Now, what happens when patients have gone through a couple lines of treatments for this relapse disease? And at this later stages of relapse, these patients are often refractory to a proteasome inhibitor, having seen carfilzomib often, a IMiD, often been treated with pomalidomide, and a CD38 monoclonal antibody, having received treatment with daratumumab or isatuximab. So in that setting, we really have to think about using drugs with novel mechanisms of action that these patients have not seen. So selinexor is an oral drug that is a nuclear transport protein inhibitor that was recently approved. Now, the selinexor is given in combination with dexamethasone or can be given in combination with other standard of care drugs. So the STORM trial looked at selinexor, dexamethasone, and showed that you can get about a 26% overall response rate, including patients who are penta-refractory, that is refractory to the PI, IMiDs, and the monoclonal antibodies. In the STORM trial, the PFS was only 3.7 months, but when you look at the subgroup of patients who did have a response, their overall survival was better than what one would have expected for such a late stage disease. More recently, selinexor has been studied in a phase 3 trial. The Boston trial randomized patients to getting bortezomib dex with or without selinexor and showed that the addition of selinexor to bortezomib dexamethasone improved the depth of response and also improved the progression-free survival. Based on this data, the drug is approved for use in combination with bortezomib. The other new drug class that is targeting or having a different mechanism of action is belantamab mafodotin, which is a BCMA-targeted monoclonal antibody that is conjugated with a toxin, which is the MMAF or monomethyl orostatin F, which is linked to the monoclonal antibody, which allows this toxin to be targeted directly to the plasma cells. Now, in the single-arm trials, the DREAM2 trial, belantamab was administered at 2 different doses of 2.5 milligram per kilogram or 3.4 milligram per kilogram. Both doses led to significant responses and also the response rate of about 30% with a median PFS of about 3 months. But in patients who responded, the duration of response was well beyond 12 months. Now, in addition, there was a third drug that was recently approved called melflufen, which is a melphalan, which is linked to a moiety that allows it to be targeted to the plasma cells. And this also used alone or in combination with dexamethasone appeared to have activity in relapsed myeloma. Now, once patients have gone through all these available therapies, we really have to look at novel approaches with novel mechanisms of action. Now, in that vein, the immunotherapies have really caught on. With the recent ASH meeting, we saw a variety of different immunotherapy approaches that have been tried in myeloma, including antibody-drug conjugates, T-cell engagers, as well as chimeric antigen receptor T-cell therapies. Now, in particular, the CAR-Ts are of great, have shown great results. Now, the CAR-T concept is familiar to all of you. It is basically a T-cell receptor that has been modified to bind to the tumor cell antigens. The most common antigen that has been targeted is BCMA or B-cell maturation antigen. In contrast, the T-cell engagers uses a bispecific antibody that binds to a CD3 on the T-cell as well as an antigen on the plasma cells, which has been BCMA for the majority of the molecules, but there are also others that are being explored. This allows the T cells to come close to the myeloma cell, resulting in an immune synapse formation and tumor cell death. Now, several CAR-Ts have been studied in clinical trials. The most advanced is ide-cel, which has gone through phase 1, phase 2 studies, and the results have recently been published. When you look at across all these different CAR-T cells, what is striking is that the group of patients who were treated in these trials had a median of 6 lines of therapy. Majority of these patients were triple-class refractory or triple refractory. And these patients were able to achieve deep responses, including MRD negativity with the use of CAR-T cells, suggesting that this is a very powerful immune platform for these patients. Now, one of the disadvantages of the CAR-T cell is that you have to collect the T cells, modify it, and reinfuse, which often can take up to 4 weeks, which means patients with advanced myeloma may not be able to wait for that long. This may not be a problem as we start moving CAR-T cells to the upfront setting. However, this is the place where other T cell redirecting therapy like the T cell engagers can be of value because they can be taken off the shelf. Now, we saw a bunch of different T cell engagers that were explored, or the results of which were published at the ASH meeting. Majority of them were targeted towards BCMA. There was one that was targeted towards GPCR5T, talquetamab, and one against FCRH5, which is cevostamab. And again, many of these studies had patients who were triple refractory, but the majority of the patients, again, 70 to 80% of these patients actually responded to therapy with these T cell engagers. And this is remarkable. Now, we already talked about melflufen. This has recently been approved, and the data from the single arm trial shows that this is something that can be quite effective in these patients. Now, how do we treat patients with myeloma in future? We know that the myeloma, especially in the relapsed disease, can be highly heterogeneous and can have multiple different mutations. And an example of a futuristic trial could be this MyDrug trial that we are currently accruing to, where patients with high-risk myeloma have gene or mutation profiling done. And based on the type of mutations, they are directed to tumor or mutation-specific drugs. For example, patients with RAS mutations will get cobimetinib, a MEK inhibitor, in combination with standard of care myeloma drugs. So this trial is currently accruing. So to conclude, the treatment of myeloma has significantly evolved over the past 2 decades. A combination of proteasome inhibitor and IMiD remains a standard of care induction prior to an autologous stem cell transplant. While 4-drug combinations are being explored, we need more data. Though in high-risk patients, use of a quadruplet injection is likely to be reasonable, given the depth of response, which can be quite important for these high-risk patients. Transplant still remains a standard of care in the eligible patients, while a delayed approach is okay. In patients who are transplant ineligible, a VRD light or a daratumumab lendex would be an appropriate regimen to use. Immunotherapy platforms are rapidly evolving. We have several new therapies that are coming online for treatment of myeloma, and this will likely to move to the earlier lines of therapy in the near future. Clearly, the treatments of myeloma continues to evolve, and the outcomes for survival of these patients will continue to improve over time. And we anticipate that we will soon be able to cure a fraction of these patients, and for the remaining patients, maintain this to be a chronic disease. With that, I'll conclude, and thank you for your attention.
Setting of multiple myeloma.
Not yet. Still going on trials.
Can I request Dr. Satyaranjan Das to give an expert comment on the talk? That was a very extensive and elaborate talk on such a vast topic, which was covered by Dr. Shaji. Dr. Satyaranjan, can we have a comment from you?
Thank you, Dr. Aditi. This was, as usual, excellent talk by Dr. Saji. We have been listening to him for many times. As usual, he has brought out the standards of therapy in myeloma remains that we have to look for transplant in most of the eligible patients and give them a kind of DRD regime, or maybe improved with the monoclonals. Today, like the daratumumab has been approved as first line, so we can even go up and start with daratumumab and get a deeper response and can go to transplant. And he is actually, there are a lot of molecules today available. He has brought out all those new drugs which can be used in multiple myeloma, and particularly in the relapse setting. We have to change the that proteasome inhibitor from one to another, and we may have to change the IMiDs also from one to another. In addition, there are some monoclonals which has come now, which can be used in particularly relapse setting, and still we can get some better results. Of course, at the end, he brought out that CAR T has been doing excellent in myeloma setting. I just saw one question on the chat box. I don't know. I'm not able to read that. Okay, if somebody has got any, just 1 minute here.
I can't.
I can't see, but there was some thing was there in the chat box, but now I see it is nothing is there. I don't think there is any question in the question answer box also. So to summarize, I think it was a wonderful talk, and he has enumerated the new molecules and combinations of new molecules in the form of various studies which have been tried in multiple myeloma, particularly relapse refractory, multiple myeloma, which really becomes difficult in our country. Now, of course, with many new medicines being approved and being available in our country, multiple myeloma is no more a big challenge, though they keep on continue on medication for a longer time, and the survival is excellent in our country. In our centers also, we see myeloma surviving more than 15 years from the diagnosis. Excellent thing. Any other, if somebody is there to ask question, otherwise Dr. Aditi, you can take on.
Thank you so much, Dr. Das, for chairing the session. We went ahead of time, but you were patient enough to stay and chair the session. And Dr. Shaji couldn't join because it would be late night at his place, so he preferred to have a pre-recording. But
at 1:20, when I saw that previous sessions are running, I know that it will be very difficult for Saji to, start at that time there. So I was expecting something will be there. Anyway, but his recorded presentation was also very excellent and, really very nice. Thank you.
Right, sir. Thank you so much, sir. So with this talk, we come towards the end of our session and end of the third day, which is the last day of Paras Cancer Conclave. It was a very exciting and rewarding experience. We had over 8,000 registrations. We had faculty close to 400, including national as well as international faculty from many countries other than India, including US, Europe, and many neighboring countries. And the delegates on the first day touched around 800. On the second day, it was around 1,400. And today they were close to 600. Very interactive and very practical discussions. And towards the end of the session, I would like to thank all our faculty, all our delegates, our IT team providing the digital platform, our team of Horizon, which provided support for our scientific program, Mr. Ravi's team, Madhawks, for providing the social networking support. And I would like to thank our viewers. And last but not the least, our organizing team who have been working very hard and very closely from all three centers, Paras, Patna, Panchkula, and Gurgaon, to bring it to the form that you see today. So Dr. Rao is here. Sir, would you like to add something to it?
Nothing. I mean, I think really thank all the participants who have really taken pains to stay back, not mind the delays, and still give excellent deliberations. I think they were the show. We just organized it, but they're the ones who were responsible for the success. Very, very good deliberations. Thank you, each and everyone, wholeheartedly. And of course, thank all the organizing team who have worked so hard. Thank you.
Thank you, sir. So with this, we conclude the first Paras Cancer Conclave, the third day and the last session. Thank you so much for being with us.